famous lectures of our teachers on anocolorectal diseases. So starting with the first lecture will be taken by Dr. Rahul Bansal sir. It's on role of diet and lifestyle in prevention of colorectal diseases, and will be chaired by Dr. Abhay Shankar Gowda sir. Dr. Abhay Shankar Gowda completed his graduation and post-graduation from SDM College of Naturopathy and Yogic Sciences, Ujre, Karnataka, affiliated to Rajiv Gandhi University of Health Sciences, and he is a gold medalist in his MD, which was the first batch of its kind in the whole country. He has more than 22 years of work experience in the field in various capacities. He has explored his skills in undergrad teaching and postgraduate teaching, clinical, academic research, administrative, social responsibilities, and handled special responsibilities, and has contributed vastly to the field. He has experience as an external examiner, Deputy Chief Superintendent, PG Guide, delivered numerous health talks at public gatherings, schools, colleges, or topics like disease prevention, healthy lifestyle hygiene, yoga in daily life, etc. He has organized numerous awareness camps and naturopathy and yoga treatment camps. He has attended numerous conferences, seminars, and workshops as delegate, invited speaker, paper presenter, and its computer savvy with knowledge of 8 languages. He was also the member of Academic Subcommittee of Yoga and Naturopathy, Ministry of Ayush, Government of India, in addition to the duty of Dean Faculty of Ayush, Swami Vivekanand Subharti University, Meerut.
May we please like to request on stage Dr. Rahul Bansal sir, who's done his MBBS from LLRM Medical College in 1983 and has done his MD in Social and Preventive Medicine in 1988. Sir has more than 43 publications in national and international journals and has more than 138 citations. His keen area of interest and working activity in the field of yoga, Ayurveda, naturopathy, spirituality, and dimensions of the health.
डॉक्टर शंकर गौड़ा जी जो चेयरपर्सन हैं, मेरे मित्र भी हैं और हमारे ऑफिशिएटिंग वाइस चांसलर भी हैं आज के, डॉक्टर मुकेश बॉस जो कि मेरे सीनियर हैं, बहुत फेवरेट बड़े भाई हैं, डॉक्टर शशांक HOD सर्जरी, और साथ ही मेरे प्रिय छात्र हिमालयन के। तो मेरे लिए बड़े गर्व की बात है कि ये कॉन्फ्रेंस जो लोग कर रहे हैं उसमें काफ़ी लोग मेरे स्टूडेंट्स हैं, अविरल हैं, और जो यहाँ के सर्जरी के बहुत सारे असिस्टेंट प्रोफेसर मेरे छात्र रहे हैं। तो मेरे लिए बहुत गर्व की बात है। और सारे इंटर्न्स और जॉर्जिया से आए हुए 5 इंटर्न्स, ये सभी हमारे छात्र हैं। आज का विषय बहुत ही इंटरेस्टिंग है, बहुत इम्पोर्टेंट है, स्पेशली फॉर यंग पीपल, बिकॉज अर्ली ऑनसेट कोलोरेक्टल कैंसर इज इंक्रीजिंग वेरी फास्ट। आप लोगों के लिए रिस्क बढ़ रहा है, मैं बताऊंगा क्यों बढ़ रहा है। और अगर आप लोग थोड़ा संभल गए, if you little bit take some precaution after hearing this talk, my purpose of coming here will be fulfilled. कुछ इंटरेस्टिंग बातें हैं, many of the things you know, but कुछ नई चीजें भी हैं। So, remembering Almighty God, I am starting on my presentation. Prevention of colorectal cancer. I will be mainly focusing on diet because 30 मिनट के समय में डाइट पे फोकस करना ही काफी है, बाकी पे करना मुश्किल है। मेंशन करूंगा मैं बाकी, बट मेरा मेन फोकस डाइट पर होगा। इसका एक कारण ये भी है कि डाइट की जब हम बात करते हैं, डाइट कैन प्रिवेंट इन 2 ways. One is when it goes to the bloodstream and reaches the particular tissues. But in colorectal cancer, diet का direct impact भी है, because this is growing for the innermost layer of the इंटेस्टाइन, सो डायरेक्ट भी इफेक्ट हमें डाइट का नेगेटिव या पॉजिटिव कोलोरेक्टल कैंसर में मिल सकता है। तो इसीलिए थोड़ा सा मैं यंग बच्चों से चाहूंगा कि वो स्पेशली मोबाइल वगैरह से बच के आप मेरी बात सुने, तो आप हो सकता है कोलोरेक्टल कैंसर से भी बच जाएं। मोबाइल तो चलता रहेगा जिंदगी भर, बट दिस टाइप ऑफ टॉक यू मे नॉट हियर बाय गॉड्स ग्रेस। सो टू बिगिन विद, आई विल फर्स्ट शो यू सम पेपर कटिंग्स। मेरा एक शौक है, आपको मालूम है, जो भी पेपर कटिंग अच्छी मिलती है। डॉक्टर छवि आगे आ जाइए, आप फैकल्टी हैं, आप पीजी स्टूडेंट नहीं है। आई कीप पेपर कटिंग्स and use them at the appropriate moment. आप देख के आपको अच्छा लगेगा। ICMR की स्टडी अभी आई है, बड़ी चौंकाने वाली है और थोड़ा सा डराने वाली भी है। It says 1 in 9 Indian at the risk of developing cancer. So हम अभी तक we were little safer in cancer. अभी भी अमेरिका से हम काफी पीछे हैं in many cancers, but we are growing very fast. So it's an alarm bell for all of us कि कैंसर बढ़ रहा है, including colorectal cancer, and we have to be careful. ये भी अभी recent cutting है Times of India की, it was based on a international study. Alcohol use and high BMI key risk factor in cancer deaths. मैं general थोड़ा सा बता रहा हूँ अभी, because what applies to all cancers also applies to colorectal cancer. कुछ चीजें कॉमन है, जैसे फिजिकल इनएक्टिविटी कॉमन है, डाइट का कॉमन है, ओबेसिटी का कॉमन है इन मेनी कैंसर्स इंक्लूडिंग कोलोरेक्टल। ये एक बड़ी इंटरेस्टिंग कटिंग थी। कैंसर के 2/3 मामले खराब जीवन शैली से जुड़े। नाउ मोर एंड मोर कैंसर्स आर बीइंग एप्रिशिएटेड एज लाइफस्टाइल डिजीजेस, मोर ऑफ लाइफस्टाइल डिजीजेस, लेस ऑफ जेनेटिक डिजीजेस। खासकर अगर हम आज वाले कैंसर की बात करें, इट इज मोर ऑफ ए लाइफस्टाइल डिजीज। अब ये देखिए कितना इंटरेस्टिंग है और कितना हार्ड हिटिंग है। हम लोग जर्नल में पढ़ते रहते हैं फिजिकल इनएक्टिविटी इज अ रिस्क फैक्टर, बट जब इस तरह छपता है अखबार में, दैट रीचेस द मासेस। रोजाना 10,000 कदम चलने से कैंसर का जोखिम कम, एंड ऑल कैंसर्स इज, एंड ऑल्सो टुडेज टॉपिक कोलोरेक्टल कैंसर। रिसाइकिल्ड रिस्क कैंसर टाइड टू ब्रेकफास्ट सीरियल बॉक्सेस। इवन जो ब्रेकफास्ट के सीरियल बॉक्सेस हैं, उनसे जो लीच होता है केमिकल, या पानी की बोतल से बिस्फेनॉल ए लीच होता है, दैट ऑल्सो इज नाउ इंक्रीजिंग द रिस्क, बिकॉज हम प्रोसेस फूड बहुत ज्यादा खाने लगे, बॉक्सेस में बहुत ज्यादा फूड लेने लगे हैं। करेला को हम सोचते थे भाई करेला ये आयुर्वेद वालों ने कह दिया, पता नहीं क्या है, कुछ स्टडी है नहीं है, लोग खाए जा रहे हैं करेला। बट a US study led by Indian origin scientists says करेला may have anti-cancer properties. So हमें इन चीजों को खारिज नहीं करना चाहिए। अगर कोई ट्रेडिशनल चीज है उसको सीरियसली कंसिडर करना चाहिए, स्टडी करना चाहिए, तब उसको खारिज करना चाहिए। हल्दी की बात बताऊंगा, हल्दी भी एक बहुत बड़ा एंटी कैंसर पोटेंशियल निकल के आ रहा है। कैंसर के खात्मे हल्दी बड़ा हथियार। हम सोचते हैं ये किसी पत्रकार ने लिख दिया ऐसे ही, ऐसा नहीं है। सम ऑफ दीज आर एक्चुअली रिसर्च आर्टिकल्स, मेनी ऑफ दीज आर रिसर्च आर्टिकल। इंटर्न्स आगे आ जाइए, स्टूडेंट्स आप आगे आ जाइए प्लीज, इंश्योर ये पीछे ना बैठे, पीछे बैठ के मोबाइल में घुस जाएंगे, फिर कुछ बात तो सुनेंगे नहीं, इनको कोई फायदा होगा नहीं। आगे बैठिए। तो हल्दी इज वन ऑफ द वेरी की कैंडिडेट। मैं आपको दिखाऊंगा इसकी रिसर्च कि बहुत जबरदस्त पोटेंशियल है हल्दी में। फल फूल के रसायन कैंसर रोकेंगे। मेनी ऑफ द एंटी कैंसर ड्रग्स, डॉक्टर भावना आगे आ जाइए, मेनी ऑफ द एंटी कैंसर ड्रग्स आर कमिंग फ्रॉम प्लांट ऑरिजिन, और आएंगे अगर हम थोड़ा सा ओपन माइंडेड रहें। अब ये देखिए, बड़ा सुनने में बड़ा सेंसेशनल हेडिंग है, बट ये सही है। मैं आपको दिखाऊंगा कैसे सही है। द वेस्टर्न डाइट, द वेस्टर्न खाना पीना, द वेस्टर्न लाइफस्टाइल is one of the leading causes of all cancers including colorectal. Protein rich diet as bad as smoking 20 cigarettes per day. एक हेडिंग मैंने पढ़ी थी, संभाल के रखी है, मैंने उसको चेक किया, I found it quite true. especially for processed meat. WHO ने एक हेडिंग दी थी कुछ दिन पहले, processed meat is as bad as plutonium. I repeat, processed meat जो KFC वगैरह ये लोग बेचते हैं, आप लोग खाते हैं, young लोग, it is as bad as plutonium as far as cancer is concerned. So we have to be wary of high protein, especially from animal origin. अब ये बड़े इंटरेस्टिंग है, डॉक्टर उमंग को बड़ा मजा आएगा, क्योंकि ये होलिस्टिक खिलाते भी हैं, खाते भी हैं. अगर हम रोटी को बहुत ज्यादा फुलाएंगे गैस पे तो उसमें कार्सिनोजेंस बनेंगे. रोटी को ज्यादा से ज्यादा तवे पे सेक लेना चाहिए. और जब से मैंने ये किया है, डॉक्टर रानी यहाँ बैठी हैं, हमारे घर में अब रोटी तवे पर सिकने लगी है. इट डजंट गो टू द गैस, बिकॉज समझ में आ गया कि जितना हम गैस पे फुलाएंगे, उसको करारा करेंगे, उतना ही वो कार्सिनोजेनिक होगा. सो दैट इज व्हाई दिस नॉलेज इज इंपॉर्टेंट कि हम क्या गलत कर रहे हैं और क्या सही कर रहे हैं. मेडिसिन, वेलबींग एंड माइक्रोबायोम, ये बहुत बढ़िया एडिटोरियल था, मुझे बहुत अच्छा लगा. आप देख रहे हैं मैं कितनी लाइनें खींची हुई हैं इसमें. आगे आ जाइए, बच्चों को बिठा दीजिए आप प्लीज. डॉक्टर शशांक किसी को बोल दीजिए बच्चों को बिठाते रहें वो. तो माइक्रोबायोम भी बहुत बड़ा कैंसर प्रिवेंशन निकल के आ रहा है. मैं आपको दिखाऊंगा. कोलोरेक्टल कैंसर में तो माइक्रोबायोम शायद वन ऑफ द बिगेस्ट प्लेयर बन जाए आने वाले समय में. और एक और चीज बड़ी इंटरेस्टिंग, डॉक्टर डेविड स्पीगल हैं, जिन्होंने 20 साल पहले एक ऐसा पेपर छापा था जिससे पूरी दुनिया में तहलका मच गया. उन्होंने ब्रेस्ट कैंसर के विमेन में साइकोलॉजिकल काउंसिल से सर्वाइवल 50% बढ़ा के दिखाया. यानी कि जिन सीए ब्रेस्ट विमेन को काउंसलिंग दी गई, उनका सर्वाइवल बढ़ गया. सो उसके बाद उन्होंने बहुत काम किया और अब इनका पेपर आया है, माइंड मैटर्स इन कैंसर सर्वाइवल. सो हमें खाली पेशेंट की बॉडी को ही नहीं मैनेज करना है, हमें उसके माइंड को, उसकी कॉन्फिडेंस को, उसकी होप को भी मैनेज करना है. एंड नाउ आई स्टार्ट द प्रॉपर slides, that is diet and lifestyle factors in colorectal cancer. मैं जो भी बताऊंगा आपको, I will try to give a reference first and then I will tell you कि ये कहां से है. So this is the reference. Colorectal cancer constitutes a major portion of global burden in developed country. ये one of the leading cancer है already west में, और हमारे यहां तेजी से बढ़ रहा है. A rapid increase in colorectal cancer has been observed in developing countries जहां पहले लो था. अफ्रीका में, युगांडा वगैरह में डॉक्टर बर्किट जब पहुंचे वहां 25 साल पहले, वहां उन्हें कोलोरेक्टल कैंसर ही नहीं मिला, क्योंकि यहां होता ही नहीं है, किसी अस्पताल में नहीं मिला. तो ऐसी हालत थी डेवलपिंग कंट्रीज में. देयर वाज हार्डली एनी कोलोरेक्टल कैंसर. अब तो आप देख रहे हैं तेजी से बढ़ रहा है. दैट अगेन प्रूव्स कि लाइफस्टाइल का बहुत बड़ा रोल है कोलोरेक्टल कैंसर में. इट इज द थर्ड मोस्ट कॉमन कैंसर इन मैन एंड सेकेंड मोस्ट कॉमन इन वुमेन. एक और खास बात है कोलोरेक्टल कैंसर में, क्योंकि ये स्टेजेस में डेवलप होता है, प्री कैंसरस, फिर पॉलिप और फिर वो, तो इसलिए इसका अर्ली डायग्नोसिस बहुत इजी है. अगर हम स्क्रीनिंग करते जाएं, ऑकल्ट ब्लड देखें और उसके बाद कोलोनोस्कोपी वगैरह करें, there is a very good scope of early diagnosis and treatment, which is secondary prevention. और वेस्ट में बहुत सारी कंट्रीज ने अपनी मोर्टेलिटी इसलिए कम करी है, they have reduced the mortality of colorectal cancer by doing mass screening. So that is one good thing about colorectal cancer. But I would like to add, even primary prevention is also very effective, can be effective in colorectal cancer because we know a lot of things. और आज का प्रेजेंटेशन यही हमें दिखाएगा. ये एक रेफरेंस है, गट माइक्रोबायोम इन इट्स रोल, और मैंने कोशिश करी है सारे रेफरेंस पबमेड के या उसी लेवल के मैं आपको दे रहा हूं. आई हैव ट्राइड टू इंक्लूड ऑल वेरी हाई इंपैक्ट जर्नल्स. अब ये देखिए, इन रिसेंट ईयर्स सीआरसीज इन दोज अंडर 5 years नोन एज अर्ली ऑनसेट सीआरसी कोलोरेक्टल हैज बिकम इंक्रीजिंग प्रॉब्लम. ये आप यंग लोगों के लिए एक अलार्म बेल है कि आप लोग ये मत माने कि नहीं, तो सर तो 60 साल से ऊपर के हैं, इनको चिंता करनी चाहिए. आपको भी करनी है, क्योंकि अर्ली ऑनसेट शुरू हो गया है. यू हैव टू बी केयरफुल फ्रॉम नाउ एंड इट इज इंक्रीजिंग. and it is epidemiologically, pathologically, anatomically, metabolically and biologically different from late onset CRC. तो ज्यादा उस पर हमें ध्यान देना है, प्राइमरी प्रिवेंशन पे भी और सेकेंडरी प्रिवेंशन पे भी, बिकॉज यंग लोगों में बढ़ रहा है, इट इज इंक्रीजिंग इन यंग पॉपुलेशन. ये एक और रेफरेंस है न्यूट्रिएंट्स जर्नल में, एंड व्हाट डज इट से? Though the incidence of mortality from colorectal cancer has decreased, why it has decreased? Because of early diagnosis and treatment. मैंने आपको बताया. But incidence of CRC in young people has in. वही बात, again it is coming that it is increasing in young people. This is the from the same reference. ये एक तरह से समरी मान लीजिए आप, जितना इसमें लिखा है लगभग इसी पर ही सारा काम हुआ है. आई हैव रेड सो मेनी पेपर्स इन लास्ट फ्यू डेज. लगभग दिस समराइजेस द प्राइमरी प्रिवेंशन ऑफ. कुछ एक्स्ट्रा पॉइंट्स हैं, आई विल गिव यू. आपने देखा अभी 10,000 कदम चलेंगे तो कैंसर का खतरा कम होगा. दैट इज वेरी ट्रू फॉर कोलोरेक्टल कैंसर ऑल्सो. इफ वी वॉक, इफ वी आर एक्टिव, if we are jogging, running, cycling, moving, the risk of colorectal cancer decreases. This covered in many studies. Diet rich in fruits and vegetables also बिल्कुल established हो चुका है कि it is, and not just because of fiber, because of micronutrients and many things which the fruits and vegetables give you. High fiber पे खूब काम हो चुका है. Folate is another area where they are working. Calcium. Even dairy products are being found. I'll show you. Wholesome dairy products also have been found to be protective in CRC. Vitamin D, B6, magnesium, fish consumption, garlic. And मैंने लास्ट में बहुत छोटा छोटा लिखा है, regular use of aspirin and NSAIDs. Why? Because aspirin के ऊपर question mark लग गया. आपको मालूम होगा, aspirin was thought to be a wonder drug. It is. But its side effects have been found to be bad, especially in 60 plus. It can lead to bleeding disorders. NSAIDs आपको मालूम है long term use में they have been found to be nephrotoxic. किडनी को नुकसान करते हैं NSAIDs. So ये दोनों चीजें हम रेगुलर नहीं यूज कर सकते as a prevention of. Now this is another JAMA open access journal है ये, and it is an umbrella review. ध्यान दीजिए, स्पेशली जो स्टूडेंट्स हैं. अम्ब्रेला रिव्यू मतलब मेटा एनालिसिस का भी जो एसेंस है वो अम्ब्रेला रिव्यू है. सो मेनी मेटा एनालिसिस हैव बीन रिव्यूड एंड दे हैव कम आउट विद दिस वेरी इंटरेस्टिंग. दिस इज अ वेरी स्ट्रॉन्ग एविडेंस आई कैन से, बिकॉज व्हेन यू रिव्यू मेटा एनालिसिस, उससे ऊपर तो कुछ है नहीं. एविडेंस सजेस्ट दैट मॉडिफाइड राइफ फैक्टर्स इंक्लूडिंग एक्सेस एडिबोसिटी. ओबेसिटी एक बहुत बड़ा रिस्क फैक्टर निकल के आ रहा है कोलोरेक्टल कैंसर में. पुअर डाइट, अभी एक्सप्लेन करेंगे हम पुअर डाइट क्या है. फिजिकल इनएक्टिविटी, बैठ के टीवी देखे जा रहे हैं, मोबाइल देखे जा रहे हैं, ऑल दिस सेडेंटरीनेस इज आल्सो इंक्रीजिंग, प्ले इंपॉर्टेंट रोल इन अकरेंस एंड प्रोग्रेशन ऑफ डिजीज. अब इसमें जो कन्विंसिंग है, अब मैंने उसको अलग से निकाल दिया. दिस अम्ब्रेला रिव्यू, देयर वर फ्यू वेरी important points. Association of red meat, high versus low, alcohol, 4 drinks versus 0, or even occasional drink, incidence of CRC, inverse association. There was a clear indication that if we take red meat versus no red meat, alcohol, even moderate, abhi aage bhi aayega, it has been found to be a risk factor for CRC. It is convincing after sensitivity analysis. Two associations are highly suggestive. Evidence of association between diet and incidence of CRC. अब यहाँ इंटरेस्टिंग पॉइंट मैं दे रहा हूं, डेयरी प्रोडक्ट्स. हम लोगों को कोलेस्ट्रॉल हाइपोथेसिस और डाइट हार्ट हाइपोथेसिस के चक्कर में हम लोगों को घी बंद करा दिया, हमारा दूध बंद करा दिया, हमारा सब बंद करा दिया. बट नाउ दे हैव टेकन ए यू टर्न. आपको मालूम होगा शायद कि नाउ देयर इज ए यू टर्न. दे से हेल्दी फैट्स, नेचुरल हेल्दी फैट्स शुड बी टेकन इन मॉडरेशन. और डेयरी प्रोडक्ट्स के ऊपर जो बहुत बड़ा क्वेश्चन मार्क लग गया था, दैट इज नो लॉन्गर देयर. प्योर स्टडी छप गई है अभी, बहुत बड़ी स्टडी है, और भी स्टडीज हैं which say that we should not avoid totally dairy products. They should be taken in moderation. तो वो कैंसर से भी हमें, CRC से भी बचाता है, इंक्लूडिंग मिल्क, चीज, योगर्ट. योगर्ट का डबल रोल है. योगर्ट इज ऑल्सो अ प्रीबायोटिक एंड पोस्टबायोटिक. आई विल एक्सप्लेन यू लेटर व्हाई इट इज सो इंपॉर्टेंट. योगर्ट यानी हमारा दही, हमारा मट्ठा, वो भी कहीं ना कहीं CRC रिस्क को कम करता है. नाउ दिस इज अनदर पॉइंट. हम लोगों को क्या सिखाया गया? मॉडरेट इवन कैंसर की सोसाइटी तो ये कहती है इवन 1 ड्रॉप ऑफ अल्कोहल इज कार्सिनोजेनिक. सो कैंसर में कोई सेफ लिमिट नहीं है. हार्ट में कंट्रोवर्शियल है, क्योंकि वो स्टडीज जो हैं वो प्रूव नहीं कर पाई एक्चुअलिटी में. WHO ने बिल्कुल क्लियर स्टैंड दिया है, नो लेवल ऑफ अल्कोहल कंजम्पशन इज सेफ फॉर हेल्थ. सो इस गलतफहमी में नहीं रहना चाहिए, खासकर यंग जनरेशन को, कि थोड़ी सी ले लो, अच्छी है दिल के लिए. दिल के लिए अच्छी है नहीं पता नहीं, बट कैंसर के लिए बिल्कुल अच्छी नहीं. Although we found convincing evidence that higher intake of dietary fiber was associated with low CRC, बर्किट्स ने तब कह दिया था युगांडा में जब गए थे कि भाई फाइबर से होता है. अभी ये समझ में आ रहा है, फाइबर इज नॉट सिंपल फाइबर. फाइबर के साथ बहुत सारी माइक्रोन्यूट्रिएंट्स हैं, फाइटेट्स हैं, उन सब से मिलके होता है. इट इज नॉट जस्ट फाइबर. सो इसीलिए फाइबर में जब देखा तो कहीं पर मिला, कहीं नहीं मिला, बट होल ग्रेन्स के मामले में बिल्कुल मिल गया. होल ग्रेन्स के मामले में देयर इज अ कन्विंसिंग एविडेंस दैट इट प्रिवेंट्स अस फ्रॉम CRC. और अभी मिलेट्स की बात चल रही है. हमारे प्राइम मिनिस्टर ने मिलेट्स का पूरा अभियान छेड़ दिया है. मैं समझता हूं ये भी रिसर्च का विषय बनना चाहिए कि क्या मिलेट्स विच आर होल ग्रेन्स, क्या ये भी CRC को प्रिवेंट करते हैं? इसके पर भी काम होना चाहिए और जरूर आपके सामने आएगा. फाइटेट्स, फाइटेट्स की बात बहुत कम होती है, मैंने देखा है. फाइटेट्स को तो पहले हम एंटी न्यूट्रिएंट मानते थे. मुझे याद है मैं भी पढ़ाया करता था, फाइटेट्स को मत लो, वो न्यूट्रिएंट मिनरल के एब्जॉर्प्शन को कम करता है, फाइटेट्स मत लो. बट नाउ दे हैव बीन फाउंड टू बी वेरी इंपॉर्टेंट फॉर कैंसर प्रिवेंशन, स्पेशली कोलोरेक्टल कैंसर. ये बीन्स में और इनमें दालों में मिलता है फाइटेट्स. अब देखिए आप, हाउ नॉट टू डाई इज वन वेरी बेस्ट सेलर सेंसेशनल बुक है ये साथियों, जिसमें डॉक्टर माइकल ग्रेगर ने, ये एक इंटरनेशनल सेलिब्रिटी हो गए, MD हैं, 17 कॉमन केसेस ऑफ डेथ को प्रिवेंट करने का न्यूट्रिशनल फॉर्मूला बताया है बेस्ड ऑन एविडेंस. इनकी किताब में करीब 2000 एविडेंस हैं फ्रॉम ऑल टॉप जर्नल्स. एंड व्हाट डज ही से अबाउट colon cancers? The answer might lie in natural compound called phytates, which is found in seeds of plants, whole grains, beans, nuts and seeds. Phytates have been shown to detoxify excess iron in the body. यहां मैं आपकी तवज्जो चाहूंगा, रेड मीट का जो इतना डेरोगेटरी इफेक्ट है उसका एक कारण है हीम आयरन. हीम आयरन इज ए डबल एजेड स्वॉर्ड. अगर कम लेंगे तो एनीमिया, और ज्यादा लेंगे तो इट कॉजेज ऑक्सीडेटिव डैमेज. एंड दे आर सेइंग दैट रेड मीट का जो खराब रोल है उसका एक कारण है हीम आयरन. फाइटेट्स उस एक्सेस हीम आयरन को डिटॉक्सिफाई करता है. सो दैट इज वन वे द फाइटेट्स इज हेल्पिंग अस. फाइटेट्स में ऑल्सो प्रोटेक्ट अगेंस्ट CRC. A 6-year study of 30,000 Californians found increased meat consumption, increased risk of colon cancer. But eating beans are an excellent source of phytates was found to help mediate some of that risk. यानी कोई अगर रेड मीट खा रहा है, उसको शौक है बहुत, और अगर वो फाइटेट्स लेता है साथ में, यानी दालें खाता है, बीन्स खाता है या खाती है, तो उसका रिस्क थोड़ा सा कम हो जाएगा, ये इनका कहना है. सो अल्टीमेटली इट इज द मीट टू वेजिटेबल रेशियो. एब्सोल्यूट नहीं है, मीट टू वेजिटेबल रेशियो है. और ये देखिए आप, एक स्टडी, बड़ी जबरदस्त स्टडी है ये, थोड़ी पुरानी है, बट इट इज अ वेरी, आई थिंक, a very important study. 8-fold difference between CR की risk between two extremes. High vegetable, low meat, जो typical American diet है, low vegetable, sorry, high vegetable, low meat जो हमारी diet है Indians की, low vegetable, high meat जो American diet है, उन दोनों में 8 times का difference है in CRC risk, colorectal cancer. This is a very important study because 8 times cannot be by chance. When you eat whole grains, the beans and nuts, potatoes are simply absorbed into bloodstream and readily taken out by tumor cells. ये मेरे लिए भी एक चौंकाने वाली बात थी कि phytates को tumor cells बहुत readily uptake करते हैं and they concentrate their compounds so efficiently that phytate scans can be used to trace spread of cancer within body. ये चीज मुझे भी बिल्कुल आश्चर्य में थी कि phytate scan हम यूज कर सकते हैं to track the spread of colon cancer. Now, role of turmeric, जो हमारी हल्दी है, जिससे हमारी पहचान है हमारी संस्कृति की, हर शुभ अवसर पर हल्दी का टीका लगाते हैं, हल्दी का हम यूज करते हैं. वो हल्दी कितनी इंपॉर्टेंट है होती जा रही है. पहली बात तो ये बताऊं, 100 से ज्यादा पेटेंट्स हैं हल्दी के पेंडिंग. 100, more than 100 patents are pending for haldi in the international patent courts. Now, this is one of the studies, PubMed Index journal है ये. Curcumin and colorectal cancer. क्या कहता है ये? Curcumin diffuses. Curcumin is one of the most active ingredient of haldi, which has been successfully extracted and is being marketed. Curcumin diffuses through cell membranes into endoplasmic reticulum, mitochondria, nucleus. It exerts its action as an antioxidant property. Therefore, its use has been advocated for chemopreventive, ध्यान दीजिएगा, chemopreventive, anti-metastatic, anti-angiogenic purposes. In conclusion, curcumin falls with the category of plant origin substances able to prevent CRC in animals. This property offers promising expectations in man. वो दिन दूर नहीं है जब डॉक्टर उमंग मित्तल जैसे ऑन्कोलॉजिस्ट, एंकोसर्जन्स अपने पेशेंट को कीमो के साथ में हल्दी भी देना शुरू करेंगे. शायद दे रहे होंगे, दे रहे हैं. वेरी गुड. ये अब साइंटिफिक है. हल्दी भी साथ में यूज करने में कोई बुराई नहीं है. इट्स अ हर्ब एंड इट इज अ इंडियाज वन ऑफ द मोस्ट, इसको गोल्डन हर्ब ऑफ इंडिया बोलते हैं. इसके ऊपर और भी रेफरेंस मुझे मिले पबमेड इंडेक्स में. Accumulated evidence suggests that curcumin suppresses tumor by colon cancer in various ways. क्या तरीके हैं? Restricting cell cycle progression or stimulating apoptosis, restricting angiogenesis, anti-apoptotic protein expression, cell survival signaling pathways वगैरह वगैरह. Regulating immune response. So there is enough evidence that we can start using haldi as a whole or as curcumin in prevention and management of cancer. The information discussed in present review will be useful in drug discovery process. और आगे हल्दी का और ज्यादा यूज बढ़ने जा रहा है. अनफॉर्चुनेटली मैं यंग बच्चों को बताना चाहूंगा, पिज्जा में हल्दी नहीं डलती. डलती है कहीं? बर्गर में डलती है, पास्ता में डलती है. So you are missing out on something. You are missing out on something big by switching to pasta, pizza, burger because they are, या तो हल्दी वाला पास्ता शुरू करा दीजिए, हल्दी का बर्गर, हल्दी का पिज्जा. हल्दी तो हमारी ट्रेडिशनल फूड में मिलती है एंड हल्दी इज वेरी हेल्दी. टेक इट फ्रॉम मी. ये कोरोना में भी सामने आया. अगेन माइकल ग्रेगर बहुत इंटरेस्टिंग बात कहते हैं. मैन इन यूएस अपीयर्स टू हैव 11 टाइम्स मोर सीआरसी देन मैन इन इंडिया, 23 टाइम्स मोर प्रोस्टेट कैंसर देन इंडिया वगैरह वगैरह. मतलब अभी भी हम वी आर गोइंग बैक टू वर्स, बट स्टिल अमेरिका इज फार अहेड ऑफ अस in cancers. Why? He asked a question, Michael Greger, why? तो इसका आंसर उन्होंने खुद ही है, जो इंटरनेशनल मीडिया में आता भी रहता है. The regular use of more than one possible explanation. Of course, हमारे था वो तो है ही, बट एक थ्योरी आ रही है कि टर्मरिक से शायद हम लोग बचे हुए हैं. अल्जीमर्स में भी आया है बाय द वे. हमारा अल्जीमर्स रेट वर्ल्ड के हिसाब से इसकी वजह से है. तो इसलिए हल्दी को जरूर लीजिए, चाहे किसी फॉर्म में. कॉन्स्टिपेशन एंड सीआरसी. ये भी एक बड़ा इंपॉर्टेंट इशू है और बड़ा लॉजिकल लगता है, बिकॉज जितना हमारा फूड इंटेस्टाइन में ज्यादा स्टे करेगा, ट्रांजिट टाइम जितना ज्यादा होगा, यानी कि जिनको those who don't have regular fecal expulsion, they may be 2 days or 3 days, which is very common in West, that may lead to more stay of the toxic food in the cecum and other parts of colon. तो ज्यादा absorb होगा, which looks very logical कि भाई constipation also should be, constipation and colorectal cancer has been suspected linked to colorectal, but epidemiological evidence is inconclusive. अभी conclusion नहीं है ना, अभी एकदम पक्का नहीं हुआ है, but constipation was associated with moderately increased risk of in this study. Risk of developing again constipation. Chronic constipation is highly prevalent problem. मैंने एक जगह पढ़ा था, यूएस में सबसे ज्यादा डॉक्टर विजिट्स अगर किसी के लिए होती हैं तो वो कॉन्स्टिपेशन के लिए होती है। मगर मैं हल्के वे में कहूं तो उनको आती नहीं है, अमेरिकन्स को आती नहीं है, बहुत एफर्ट लगाते हैं, क्या क्या खाते हैं। हमारे यहाँ फॉर्चुनेटली अभी ऊपर वाले की कृपा से आती है। तो patients with chronic constipation are associated with significantly higher prevalence and incidence of colorectal cancer and benign colorectal neoplasm than matched chronic constipation free patients. These risks increase with the severity of में माइक्रोबायोम। मैं समझता हूं साथियों, छात्रों, माइक्रोबायोम एक ऐसा टॉपिक है क्योंकि ह्यूमन जीनोम प्रोजेक्ट तो फुस हो गया मींस इट हैज नॉट डिलीवर्ड द रिजल्ट्स। बहुत हल्ला मचा, कुछ हुआ, कोई जेनेटिक मार्कर्स मिले भी, कुछ खास कोई दवाई नहीं बन पाई। नाउ द नेक्स्ट रिसर्च डॉलर इज ऑन माइक्रोबायोम। अभी दुनिया में सबसे ज्यादा रिसर्च डॉलर अगर कहीं खर्च हो रहे हैं तो वो माइक्रोबायोम पे हो रहे हैं। और माइक्रोबायोम आपको मालूम होगा, छात्रों को बता देता हूं, हमारे गट में, हमारे स्किन पे, जेनाइटल में, फीमेल जेनाइटल ट्रैक्ट में जो बैक्टीरिया रहते हैं, ट्रिलियंस ऑफ बैक्टीरिया, एंड यू विल बी सरप्राइज्ड, we have 9 bacterial genes compared to 1 human gene. So we are largely bacteria genetically than human beings. तो हमें उनको ऑनर करना चाहिए, उस जीन्स को हमें, उस बैक्टीरिया को हमें रेस्पेक्ट करना चाहिए, because they are our biggest protectors from various diseases including colorectal cancer. That's what the research shows. बर्किट जब गए थे उन्होंने कहा था फाइबर से होता है, फाइबर इज द वन वाई अफ्रीका में नहीं है कोलोरेक्टल। अब उन्होंने पाया कि खाली फाइबर नहीं है, इट कुड बी ड्यू टू गट माइक्रोबायोम, बिकॉज गट माइक्रोबायोटा एंड माइक्रोबायोम एक ही चीज है लगभग, वो फाइबर से बढ़ती है। फाइबर इज वन ऑफ द बिगेस्ट प्रमोटर ऑफ गट माइक्रोबायोम। हाई फ्रूट्स, हाई वेजिटेबल, फाइटेट्स, ये सब माइक्रोबायोम को एनहांस करते हैं। गट माइक्रोबायोम इट्स रोल इन कोलोरेक्टल कैंसर, बड़ा अच्छा रिव्यू पेपर है मुझे मिला, एंड आई हैव टेकन सम डायग्राम्स फ्रॉम इट। Before that, only 10 to 15% CRC are hereditary. मैंने शुरू में कहा था CRC is largely a lifestyle disease. It's primary prevention possible, it's possible secondary prevention, tertiary तो आप लोग कर ही रहे हैं, सर्जरी वगैरह। So that's why this cancer has lot of opportunities. Environmental factor is important and epigenetics भी इसमें आ गया है, and microbiome is now being researched as one of the key player in colorectal cancer. ये एक डायग्राम है, इस पेपर में से लिया है। This summarizes almost all the factors for the early onset of CRC. Again, मैं फिर रिपीट कर रहा हूं, यंग जनरेशन को they have to wake up. They are now being hit more by colorectal cancer. Early onset CRC is a big threat all over the world, especially in India, because we have changed our dietary habits to the Western. We are becoming more sedentary. We are becoming more amenable to, toxins. So the factors they have summarized. External factors for CRC, early onset, infections, radiation, alcohol. I have told you alcohol is, smoking is also another very big factor. और जो दोनों करते हैं, वो आप समझ सकते हैं कितना खतरनाक है। फिजिकल इनएक्टिविटी आ चुका. एंटीबायोटिक्स. Why antibiotics? Because indiscriminate of antibiotic use kills the microbiome. One of the reason why microbiome is going to dysbiosis is indiscriminate use of antibiotic, जो हमने कोरोना काल में खूब किया. जनरल एक्सटर्नल फैक्टर्स में क्लाइमेट, सोशो इकोनॉमिक, वेस्ट में कम से कम ये पाया गया कि लोअर सोशो इकोनॉमिक में सीआरसी ज्यादा है. हमारे यहाँ शायद उल्टा होगा, मैंने ऐसे कहीं पढ़ा नहीं है, बट आई थिंक हमारे यहाँ उल्टा होगा. ऑक्सीडेटिव स्ट्रेस, गट माइक्रोबायोम, इन्फ्लेमेशन, हार्मोन से याद आया, हाइपर इंसुलिनीमिया इज ऑल्सो वन ऑफ द रिसर्च फैक्टर फॉर सीआरसी. ऐसा मिल रहा है कि जो इंसुलिन रेजिस्टेंस या जो मेटाबॉलिक सिंड्रोम है, हाइपर इंसुलिनीमिया है, वो भी कैंसर रिस्क को बढ़ाता है, कोलोरेक्टल को. इवन थेरेप्यूटिक इंसुलिन, जो हम इंसुलिन देते हैं डायबिटिक्स को, that also has been found to increase the risk of cancers including colorectal cancer. तो वो double edged sword है इंसुलिन, हमें ध्यान रखना है. This is the cycle. होस्ट, जो उसका होस्ट के जो फैक्टर्स हैं, लाइफस्टाइल, एनवायरनमेंट, गट माइक्रोबायोम, दे आर फीडिंग ईच अदर. सो गट माइक्रोबायोम इज नॉट जस्ट टेकिंग कि आपने प्रोबायोटिक ले लिया, आपने कुछ ले लिया, कोई टैबलेट्स ले ली तो ठीक हो जाएगा, नहीं. इट हैज टू बी complete lifestyle. These are some of the bacteria which have been implicated in preventing colorectal cancer. Sorry. This is how gut microbiome is going to be the in thing in colorectal cancer prevention and treatment. How? Screening में ये biomarker की तरह use हो सकते हैं. They can have prognostic and predictive value. You can modulate CRC treatment with microbiome and you can do prevention by microbiome. तो आप सोच लीजिए माइक्रोबायोम CRC प्रिवेंशन और मैनेजमेंट में कितना बड़ा प्लेयर होने जा रहा है. And that is why the importance of diet, that is why the importance of yogurt, mattha, fibers, fruits, plants, and all those things. How do you modulate microbiome? FMT is very interesting. Fecal microbiota transplant. Those patients who are dying of some incurable bacterial infection, उनमें जब healthy mother का fecal matter transplant किया गया राइस ट्यूब के थ्रू, वो लोग बच गए. Such things are happening, unbelievable. Healthy fecal matter जब डाला उसके gut में, the person was saved from death due to a uncurable infectious disease. That also could be now experimented in CRC. Prebiotics, you know, probiotics, you know, prebiotics में आपका ये सब आ गया. Healthy food सारा जो holistic, ये जो whole food plant based diet है, सारा prebiotic है. Probiotics आप देते हैं, जो साथ में देते हैं Vizilac वगैरह, वो tablets वगैरह. Postbiotics, ये भी interesting है. Postbiotics में आते हैं आपके अचार, आपका जो होली के टाइम जो आप वो डालते हैं कांजी का पानी, दैट इज पोस्टबायोटिक. और जो सब्जी का अचार बनाते हैं वो पोस्टबायोटिक है. नमक का ध्यान रखते हुए दे आर वेरी गुड, एंड दैट्स वेयर आवर इंडियन ट्रेडिशनल सिस्टम सीम्स टू बी वेरी इंपॉर्टेंट. Selective antibiotics diet, of course. So these are another two references. Even they have worked out the pathway how the microbiome, prebiotics, probiotics, कैसे वो colorectal cancer को prevent कर सकते हैं, इसका पूरा ये डिटेल में है. अभी समय अभाव के कारण मैं आपको नहीं समझा सकता, बट ऐसा वर्कअप किया गया है. In the end, I would like to quote the great Colin Campbell, जिन्होंने अपनी स्टडी से, चाइना स्टडी से, जो यूएस के 2 बार प्रेसिडेंट थे, क्या नाम था उनका, हेनरी क्लिंटन, डॉक्टर Clinton was saved by this man by his China study, and he is one of the most important advisor to the President of America even today on diet. And what does he say? People who ate most animal-based food got most chronic disease. Even relatively small intake of animal-based food are associated with adverse effects. People who ate most plant-based foods were healthiest and tended to avoid chronic disease. This applies to all diseases, including cancer. Now, this is another sensation nowadays. जेसन फंग ने डायबिटीज में तहलका मचाया बाय राइटिंग डायबिटीज कोड, और अब तहलका मचा रहा है कैंसर में बाय राइटिंग कैंसर कोड. वन ऑफ द वेरी वेल रिसर्च्ड बुक, और ये बहुत छाया में है यूट्यूब पे. Is a nephrologist by training, but he has gone into public health, and his book is a very good book for understanding cancer, especially for the young generation. क्या कहते हैं ये? A viable seed planted in the clay will not grow. A viable seed planted in the right soil will not grow without adequate light and water. यानी बीज आपका कितना स्ट्रांग हो, अगर उसकी जमीन नहीं है, अगर वहां हवा नहीं है, धूप नहीं है, पानी नहीं है, वो नहीं पैदा होगा. What is the relevance? Cancer too is a seed that flourishes in the right soil, under the right conditions. यानी हमारी बॉडी की जो इंटरनल एनवायरनमेंट है, जो हमारे खाने पीने से बनती है, हमारे लाइफ से, that is one which promotes cancer. Just cancer cell is not enough. You have to have the right kind of terrain. Terrain बोलते हैं इसको. डॉक्टर डेविड बी एगस में दिखाऊंगा. Unfortunately, cancer research up till now points focus exhaustively and almost exclusively on the seed. हम सीड के पीछे तो पड़े हैं, बहुत अच्छी बात है, यानी म्यूटेशंस, उसके पीछे पूरा पाथवेज ढूंढ रहे हैं, सब बहुत अच्छा कर रहे हैं, बट देयर इज इग्नोरिंग द सॉइल एंड इट्स कंडीशन. प्रिवेंशन को उतना काम नहीं हो रहा है जितना होना चाहिए. मैं तो कहता हूं बोले कुल खुले दिल से, क्यों ना हम त्रिफला के ऊपर स्टडी करें. त्रिफला का क्या रोल है प्रिवेंशन ऑफ कोरोनरी कैंसर में? टर्मेरिक पे तो कर दिया, हरिद्रा उसका क्या रोल है? इनका जरूर रोल निकलेगा, because they are affecting our GI systems. And what David B. Agus says, who is one of the greatest oncologists in the world today, इनकी sensational book है The End of Illness. क्या कहते हैं ये? We have forgotten that curing cancer starts with preventing cancer in the first place. I repeat, we have forgotten that curing cancer starts with preventing cancer in the first place. And that's where I end my talk, and I'm very thankful to the organizers, to all my Dr. Sashank, Dr. Mukesh, all my friends, all my colleagues for giving me this opportunity. ये जो हाथ जोड़ के दिखाया, मैं ऐसे ही करके दिखा.
Anybody wants to ask any questions? जी सर.
उधर माइक दे दो, माइक दे देना पीछे सबको. ये लीजिए माइक. सबको माइक.
Is there any role of fasting in prevention of colorectal cancer, the periodic fasting that we are doing in our culture? Is there any positive effect?
Sir, अभी as of now मेरे को कोई ऐसा रेफरेंस मिला नहीं है, बट इट लुक्स बायोलॉजिकल प्लॉजिबल, क्योंकि जब हम माइक्रोबायोम की बात कर रहे हैं, जीआई हेल्थ की बात कर रहे हैं, तो मे बी इन फ्यूचर वी मे सी दैट, बट अभी तक नहीं है कोई, मेरी नॉलेज में नहीं. बायोलॉजिकली लगता है कि हाँ, इट शुड बी हैविंग ए रोल.
Another thing, nowadays once we are eating the food, the people are usually watching TV and they don't give time. They just swallow it instead of chewing it.
Yes.
So most of the undigested food goes down, and they're not giving proper. Most of the, especially doctors, we are giving less than 2 minutes for the 5 minutes for the food.
Ji.
So if we give more time, chew it properly and don't watch TV and other things, that may also help in better positive effect of the food.
Yes. Actually, there are studies that if you chew twice what you are chewing, the obesity comes down. ये तो studies है कि
Indirectly.
जितना ज्यादा चबाएंगे उतना आपके कैलोरी इंटेक कम होगा and your obesity will go down. But इसमें अभी study मैंने नहीं पढ़ी है, but it looks logical.
Indirectly, it will
could
influence
be.
the colorectal cancer.
It could be.
Thank you. Thank you.
Any other questions?
Sir, I think in fasting there will be less metabolism of body. Like when there is metabolism, when we eat more, there will be generation of free radicals, more free radicals. And in fasting, there will be less production of free radicals, which will be obviously helpful to body, and it may prevent cancer.
Fasting therapy or intermittent fasting is already a known thing in the scientific world. There is a lot of evidence that it can help in cancer. Of course, not elevating cancer totally, but then it can help in prevention. It can help in palliative care as well as the tertiary care, what is required in cancer. There are evidences, but exactly on colorectal cancer, there are no studies as such. But generally, all other cancers, we have established this. That, fasting or intermittent fasting is very, very beneficial. If there are no other questions, then I'd like to proceed further. I really thank Dr. Shashank and the whole team of Surgery Update who have given me this opportunity. It is a very, very special occasion today for me. Let me tell you why. Because Dr. Rahul Bansal is the guru of my gurus. That means the teachers who have taught me, he has taught them maybe about 25 years back. So it's really an honor to be here on this stage along with sir. And the talk what he gave today is a summary which cannot be, I mean, a whole day is not enough for summarizing it, but he has so beautifully done it. He has put the right words, the right evidence, what is required, and it is very methodological. And he made it so interesting. To summarize, I would like to tell that an integrative approach is very much essential for the prevention, treatment, as well as the tertiary care, that is surgical approach or the chemo. Recently, if the surgery department is aware, there was a recent case of colorectal cancer who was sent to me, and we have incorporated diet, yoga, exercise, along with the chemotherapy, what is going on. And I have been given a feedback that the patient is much better than actually what you would have been only with chemotherapy. So definitely an integrative approach using holistic methods, taking care of the patient is our responsibility. See, which system treats the patient is not important. What is best for the patient is what is important. Now, the world is going towards this integrative approach. And to the budding doctors, I would like to just tell you to refer a concept called as psychosomatic disorders, psychosomatic diseases. This is a very in thing now. A lot of studies have been done. There is one other aspect, psychoneuroimmunology. Now, psychoneuroimmunology is based on the HPA axis, that is hypothalamo-pituitary axis. The explanation is given how stress hormones disbalance the sympathetic and parasympathetic, and because of that, the stress hormones affect, and the recovery of the stress hormones, that is the detoxification of the stress hormones to normalize things, cause a lot of damage to the body. So that aspect, if you are aware of, then probably what you will do is you will put in an extra effort in your practice, and where the patients will be benefited highly. Just when a talk about turmeric came, he said already turmeric is being given. So that is the approach required. Now they, what do you call, an experienced, renowned surgeon like sir is saying that he has already introduced turmeric, then there is something in our medicine. So an integrative approach is very, very much essential. To summarize again, lifestyle modification is the basis of cancer prevention or treatment. The diet, mainly the plant-based diet, and the Indian spices are very important. We have to avoid junk food, non-vegetarian. More of raw foods and vegetables are very good because they are rich in antioxidants, flavonoids, and phytates. And mindful eating, that's very important. Mindful eating, we have to concentrate on the food what we eat. We enjoy that food, we taste it properly, we chew it properly, and then eat. That's mindful eating. And uh, the yoga and relaxation, of course, play an important role because, as I was telling about psychoneuroimmunology, let me just add one point about psychoneuroimmunology. A lot of studies already done that cancer can be what you call the prevention, of course. In the treatment of cancer also, lot of help can be given by the psychoneuroimmunology approach, because when stress is reduced, the natural killer cells, because of psychoneuroimmunology, NK cells are increased, and that helps. And also apoptosis, the process of apoptosis which is deranged in cancer, that is balanced again. So if we think of these basic things, then probably we will understand that integrative approach is very, very essential. Stress management is very essential. Exercise, yoga, relaxation, water drinking. A lot of us forget about water drinking. Water is one of the best detoxifying agent, which we neglect, maybe because of our busy schedule, maybe because we forget all that. But water drinking is very important. Sleep is an important factor. Stress management, of course, as I was telling. And to the doctors, budding doctors, again, I know the seniors all are following this, but the budding doctors, use antibiotics very moderately. You will be helping your patients to prevent lot of diseases, including colorectal cancer, because the gut healthy bacteria also die along with the targeted bacteria what you are using the antibiotic for. So I think I have summarized sufficiently. And it was a wonderful session today. I think more of these sessions are welcome. I congratulate the surgery department for taking this initiative. Thank you very much. Jai Hind.
Thank you so much. Informative talk, sir. I would invite Dr. Abhay Shankar Gowda, sir, to kindly felicitate Dr. Rahul Bansal, sir.
Thank you, sir. Thank you, sir. I would invite Dr. M.K. Maheshwari, sir, to kindly felicitate Dr. Abhay Shankar Gowda, sir. Now we are taking a small breakfast break for 10 minutes. We'll be continuing our session in 10 minutes.
and the grade and the stage clearance of margin, that is not sufficient now. In the era of precision medicine, now we require very precisely reported case of colorectal carcinoma, which should include all the markers, biomarkers, which are there in this case or not, so that oncosurgeons as well as full team oncotherapists can decide how to go about it to give best possible treatment to the patient. Because the prevention is very important, but people who are already suffering from it, and then people who are exposed to it, hereditary, these factors are there. For them, what we have as medical professional to give best possible outcome. So to start with this topic, role of ancillary test in diagnosis of colorectal carcinomas. Just to give a brief idea about this cancer, this is the second most common cancer, as it was told in previous presentation also. Peak age of incidence is 60 to 79 years. And this, Dr. Rahul also mentioned this is the worrisome point. This is the increasing trend in young generation. And in this point, the role of lifestyle is much more as compared to genetic exposure. And of course, genetic predisposition, which we are going to talk today. As far as localization of cancer is concerned, this is like mid-gut derivative and hindgut derivative part of colon. We know that both join together, and we separate it out as right side colon and the left side colon. And rectum is kept separately because of its anatomy, peculiar anatomy and presentation, and the outcome that is kept separately. So right side will include cecum, ascending colon and transverse colon, while left side will include splenic flexure, from splenic flexure to sigmoid colon, and of course rectal carcinomas. This is the pictorial picture to emphasize the derivative. That's why they say right side hemicolectomy and left side hemicolectomy. That is depending upon the embryological development in the blood supply, and they have to remove accordingly, the surgeons. And that's how the usual manifestation which come across, like in right side colon, this area of cecum and the large lumen of the ascending colon, tumors, they tend to grow as a cauliflower type of, like exophytic growth is much more common than the deeply infiltrative type. So right side colon carcinomas, they present as a cauliflower growth, while left side, they more of napkin ring type or ulceroproliferative constrictive type of growth pattern is observed in left side of colon. And with this also we can predict what will be the clinical presentation. Here it will be slow, and these will be diagnosed early because usually they present with bleeding per rectum and change in bowel habits. While this side, they say, if this is a dictum which is written in our textbook, that if 60+ % presenting with unexplained iron deficiency anemia, then think about diagnosis of colorectal carcinoma until proved otherwise. So iron deficiency anemia, along with this loss of weight, elderly person, so it is related to, most of the time it is related to colorectal carcinoma of right side. Pathogenesis, that is the main aspect, because until unless we understand the pathogenesis part, we cannot pinpoint the specific biomarkers. For that purpose, I'll briefly describe the pathogenesis pathways. There are main 3 pathways. First is adenoma carcinoma sequence. This is also called as chromosomal instability pathway. Second is, and here more of right side colorectal carcinoma, they follow this, and where the gene, this multi-step, multi-hit step pathogenesis is much more common. Second is microsatellite instability pathway, MIS. we have got a very good repair system in our body that is called MMR. Mismatch repair system is there because every day we are getting so many mutations. When we go to sunlight, we were exposed to UV rays, our skin surface will have so many mutations. But immediately our MMR system will come there. They have so many proteins. They will identify the mutation and they will excise that part. Then repair will be done and then it will be ligated. So beautifully it is taken care of in physiological condition. But if it is unstable, if MMR is deficient, then it leads to this pathway. And third is sessile serrated adenoma pathway, or this is called as SIMP pathway. This is related to CpG island methylation phenotype, that is SIMP. So this is chromosomal. This is at the level of nucleotide. This is further means it becomes or minute. And this one is related to hypermethylation or methylation of CpG islands. So these are three main pathways, and out of which we have to identify that this particular cancer patient is following this pathway, and out of which we have to pinpoint which one is lacking by different techniques, so that the surgeon and the therapist can give targeted therapy accordingly. Especially immunotherapy is the in thing nowadays. So first, just to give a brief idea about chromosomal instability pathway, it is derived from the classic adenoma carcinoma sequence. Sporadic adenoma progress to invasive malignancy. How? Whether it is sporadic or it is related to hereditary, it progresses from adenoma to carcinoma stage, and it does not happen in days or months. It takes very long time to develop, and there will be multiple genetic mutations. And to start with, there is APC gene, which is located on long arm of chromosome 5. So this is the initial most hit, which we say this genetic mutation hit occurs, and this is followed, which is this APC is a tumor suppressor gene, which is followed by a silencing of KRAS. This is hypermethylation of KRAS gene, that is the oncogene. Then there are P53 and then SMAD4. So there are multiple hits by these mutations. So we can see that screening program is so important. If we identify the lesion in an early stage and we do this, all these staining and immunostaining and the PCR and different techniques, next generation sequencing, by which we can identify that this person is having this mutation, so that we can have a preventive aspect or preventive measures, or we can take the measures in a early stage also. So outcome will be much better. So this is chromosomal instability pathway, and main genes which are involved, I'll tell you just. Microsatellite instability pathway, as I told you, we have this very proficient MMR, that is mismatch repair pathway system we have in our body, and main proteins, or you can say the genes which are involved in it are MLH1, MSH2, MHH6 and PMS2. And just to make it very simple, like MLH1 goes with PMS2. If one is deficient, definitely PMS2 also will be mutated. They go hand in hand. While MSH2 and MSH6, they do their work together. So if MSH2 is deficient, so definitely this also will be deficient. And this is called, according to the mutation number, these are labeled as MSIH, means high mutation quantity, or MSI low. And surprisingly, you will, like, it looks paradox. MSIH, they have better outcome. Why? I tell you that these tumor cells, when they have large number of instability, they are more responsive to therapy, and also they are identified by our immune cells readily. So that's why this is a paradox. MSI is H, means high microsatellite instability is there in the tumor cells, but still they have better prognosis as compared to adenoma carcinoma sequence pathway carcinomas. And they account about 15% of colorectal carcinomas, of which 12% are sporadic, and just a small quantity, small number, small volume, that is only 3% are germline, that is called Lynch syndrome. And previously it was written as hereditary non-polyposis colonic cancer, HNPCC, that is Lynch syndrome. And this is the third pathway, that is not the tubular adenoma which is giving rise to colorectal carcinoma. There are serrated sessile adenomas. They like pedunculated, non-pedunculated. So non-pedunculated are sessile. So this pathway usually happens in the sessile adenomas, which are adenomas are benign tumors, and they are considered as precursor lesions for carcinoma. So also termed as CpG island methylation phenotype, that is SIM. And here, role of epigenetics is important for hypermethylation of this pathway, which leads to inactivation of tumor suppressor genes, inactivation of the CpG islands, and it accounts for 35% of colorectal carcinoma. It's a big number, and overlaps with MSI pathway and MLH1 is the hypermethylated gene, because this can happen in both pathways, with MSI also and with this serrated pathway also. So this is the pictorial picture of the same. This is serrated, this is sessile, not tubular, this is pedunculated. And this is the summary of all three pathways. What are the various risk factors for colorectal carcinoma? Some of which have already been pointed out. Besides that, familial adenomatous polyposis, FAP, which we already know, this is autosomal dominant syndrome, and this hereditary non-polyposis, that is Lynch syndrome, family history of colorectal carcinoma, any like close relative is having colorectal carcinoma, that is also risk factors. Previous colorectal carcinoma, ovarian, endometrial or breast carcinoma, more than 50 years age itself is the risk factors. Then inflammatory bowel disease, yes. Here I would like to mention it that like inflammatory bowel disease is also in an increasing trend in Indian population. And this can be prevented. And surprisingly, the like multi-step, multi-hit theory, what we saw that APC gene is hit first as a first step. Here in ulcerative colitis, this is just opposite. APC is the last target. And initially there will be KRAS, TP53 and other genes. Then poor diet, that is already been discussed extensively. Smoking and alcohol also, then diabetes mellitus, acromegaly, streptococcus bovis infection and ureterosigmoidoscopy, just to complete the list of risk factors. And these are the familial factors with their risk for colorectal carcinoma, which I have already mentioned. And there are variations in familial polyposis coli syndrome like Gardner-Turcotte. Gardner will have multiple osteomas, epidermoid cyst, and desmoid tumor, while Turcotte will have brain tumor like medulloblastoma along with familial polyposis coli polyps. Then non-polyposis, that is Lynch, and other juvenile polyposis or means hematomatous polyposis also play important risk factor, though they are considered as non-neoplastic. If they're single polyp of Peutz-Jeghers type or juvenile type, they do not carry a risk of cancer. But if they present as a polyposis syndrome, hematomatous polyposis syndromes, again they have, though lesser, but they have definite risk for carcinoma development. So the molecular basis to understand, these are the two subjects where all these biomarkers were detected: chronic inflammatory bowel disease and various genetic syndromes. So in inflammatory bowel disease, as I already told you, this is just, I'll not go in detail, but you can see that in adenoma carcinoma sequence, chromosomal instability pathway, APC was first hit, here it is one of the last hit. So initially, what is the significance of it to know? In early cases, if we come to know in these inflammatory bowel disease, these mutations are present, that it should be alarming and we should take preventive measures and the thorough follow-up of the patient. So implications of surgical pathology reporting. So what is our role? Pathology reporting and mutual understanding between colorectal surgeon, pathologist, and oncologist are vital to patient management. So multidisciplinary approach has to be there in such type of carcinomas where this genetic mutations and target therapy and immunotherapy can add some years or months to the patient survival. So that becomes very important. And these are the core elements in reporting, and you can understand the role of pathologists, how complicated it is. You should have sympathy towards us. Like we have to know, because that's why whenever we get a report, this requisition form always will ring up so many surgeons. They're sitting here, they can give the evidence, or they can tell about it. Like if any therapy has been already given or not, and tumor size. Morphology may vary and the outcome may vary. And the tumor dimension, perforation, clear-cut surgical perforation is the direct indication of poor prognosis, because straight away stage will be T4A. Then relation of tumor to anterior peritoneal reflection, then mesorectal excision, then histological tumor type and grade. That's all we include in all reporting. But now this thing has added. Last but not the least, that has become very important integral part of pathology reporting, that is ancillary test. So this was the today's topic. That is why we have to know about what is this, what all comes in this ancillary test, and what are the various methods to do it. Main two techniques are involved in having all these studies. That is ISC, that is immunohistochemistry, which can be done in a paraffin block, biopsy tissue, or the excised tissue. We need to have, even liquid biopsy is becoming a new thing, or is a very popular investigation in this colorectal carcinoma, because it is non-invasive. And in that we can also perform immunohistochemistry after making cell block, and then molecular studies by PCR or next sequence generation technique. Why do we need ancillary testing? First of all, we should be very clear about it. Why do we need it? To differentiate hereditary and sporadic, because outcome is different, and we need to know if it is hereditary, we have to include the counseling part, and other family members also we have to screen. To assess molecular abnormalities in unaffected family members of hereditary colorectal carcinoma cases as a part of prophylactic screening. And to predict the chances of metastasis, to predict progression-free survival and overall survival. And also, if this person or this patient case is fit to have immunotherapy or not, whether it will be effective or not. For that, we have to know programmed death cell receptors or ligand receptors. If there is mutation, then accordingly, the therapist will decide whether immunotherapy will be effective or not. So in the era of precision medicine, target therapy based on molecular typing is a need of our, and to achieve this target, identification of specific mutations by different ancillary testing in correlation with histopathological diagnosis becomes very important and has become the integral part of reporting of colorectal carcinomas. So by immunohistochemistry, what all can be done? Mismatch repair genes, almost all can be identified by ISC on paraffin block, histopathology, what we do, and after that we can do this with the help of ISC. And this, why I've written together, they go hand in hand. MLH1, PMS2, then MSH2, MSH6, MSH6 loss or PMS2 loss can be independent factor also, can be independent mutation also. Second is real-time PCR. MLH1 promoter methylation testing MMR status by microsatellite instability. So this better technique will be, in this better technique will be PCR. Multiple, and whenever we want to know whether multiple genes are involved, multiple gene mutation testing MMR status by microsatellite instability also becomes the indication for real-time PCR. Then next generation sequencing, when we want to study the extended gene mutation testing, like RAS gene mutation and BRAF mutation is done by this technique, and this is more, you can say, better results are provided by this technique, next generation sequencing technique. As you go to chromosomal level 2, nucleotide level, and then nucleotide level 2, multiple mutations identification. So your technique will change. Depending on what you want, your technique of identification of these will vary. And what is CTC? CTC is circulating tumor cells. That has become very important non-invasive techniques. You need not have a biopsy tissue. You need not have a colonoscopy done or the excision done. Before that, only if you want to predict whether chances of metastasis are there or not, or in a case of already metastatic case, what type of surgery should be done, whether simple surgical excision or the radio ablation will be required in this case. To decide all this, we need to have the CTC score. And that can be very well done by liquid biopsy. And by simple taking this, 5 ml of blood, peripheral circulating blood, is enough to detect all this circulating tumor cells. Like taking venous sample, and we can do this first the separation, then analysis, then molecular profiling. By this technique, we can identify this circulating tumor cell, not only circulating tumor cells, even the exosomes, even the free DNA particles which belong to tumor cell, we can detect by this technique. MMR loss in metastatic lesion predict response to PD-1 inhibitors. Programmed death receptor inhibitors like immunotherapy, which is the latest thing to is given to the colorectal carcinoma cases. By this, we can decide just taking 5 ml of venous blood. MLH1, MSH2, or PMS proteins play a critical role in mismatch recognition. And this, I told you how they do it. First, they will recognize the site of mutation. Like there should have been 5 nucleotide row. Now instead of 5, now there is a number. This number has become 6 or 8, which is abnormal. To us, it looks like only 2 base pairs are included. What is there? But for ultimate functional effect, it will create a havoc as far as functional outcome are concerned. So our MMR system has to recognize it, has to splice it like a Caesar, and then excise it, repair it, and then ligate it. So everything is done by these proteins because of these genes. And more than about 90% of MMR deficient colorectal carcinoma show loss of nuclear staining for one or more of the MMR proteins. As you can see, brown color shows positivity, and these are deficient. These 2 are positive, and this is deficient. So it will be labeled as MMR deficient, MMRD. If all are showing positive, then it will be written MMRS, that is stable. That's how we do reporting. And then PCR-based MSI testing, as I told you, just base pair level, nucleotide level, simple this replication of these base pairs will be identified. If it is intact, stable, it will be repaired. If it is defective or mutated, then it will lead to instability, MSI-H or MSI-L. Then screening for Lynch syndrome is most common inherited cause, and then in this very important is BRAF V600E protein mutation or presence of this mutation. It will exclude the possibility of Lynch syndrome. Then we have to think about other serrated sessile pathway. BRAF testing and MLH1 methylation testing for MSI workup. Sporadic MSI high CR colorectal carcinoma have BRAF mutation. Alternative can be MLH1 promoter methylation testing. To you, it must be looking very theoretical, but if you think about the patient management, it becomes very important. And to have an idea of how can be interpreted these factors, we should know this theoretical aspect also. So Lynch-associated MSI high CRC have intact BRAF. So if it is mutated, it means it is not Lynch. Of course, again, you have to correlate with the clinical scenario, with the relative history and the age and presentation and type of presentation, that we have to correlate definitely. Screening for mismatch repair deficiency as a marker of microsatellite instability, that I have already told you. Predict response to immune checkpoint blockage therapy. Immune checkpoint is becoming the topic of the research, and many therapeutic agents have been developed after studying these immune checkpoints. Because what are these? I'll tell you just in brief. These immune checkpoints are, these checkpoints are being utilized by our tumor cells. They happily become friendly to these checkpoints so that our T lymphocytes, which can act against these tumor cells, now they will not kill them because they have made this friendly connection with these checkpoints. So if we use inhibitors against these immune checkpoints, if we use some drugs or immunotherapy against these immune checkpoints, now our immune system will be activated against these tumor cells, and the therapy will be more effective. This is the flow chart just to say how we go about. See, all the cases of CRC should be subjected to this MSI typing. If it is stable, it's okay. MSS is for stable. If there is instability high, then it again should go for if it is if it is present or absent. Accordingly, we go one by one, and then BRAF mutation is done, and it is decided in which category this tumor is falling, and accordingly it will be reported, and surgeon and therapist and whole team will decide what therapy to be given. This is also a new thing which I would like to mention. HER2, role of HER2 is becoming important in colorectal carcinoma also. Till now, we were doing as a part of routine screening for breast carcinoma cases, like ER/PR, HER2, and Ki67 is the best breast panel. But now this HER2 is taking important role in colorectal carcinoma cases also. And this can be done by ISC and as well as FISH, especially for indeterminate cases. We have to subject these cases for FISH. That is fluorescent in situ hybridization. So therapeutic target anti-HER2 agents can be effective if these cases show HER2 positivity. Liquid biopsy, I've already told you. Tests performed in blood are circulating tumor cells, exosomes, or cell-free DNA, and detection of colorectal carcinoma, this thing, KRAS and BRAF mutation can be done on the basis of these available tumor cells. This is the technique. I'll not go in detail. I told you first is the collection, then is the separation and molecular profiling, and we can use these tumor cells for research purpose also and for therapy also. CTC score, that becomes important and you should be aware of what is the cutoff limit of the CTC. That is circulating tumor cell score. 0 for CTC number, that is less than 21 cells per ml. 1 score is given CTC number if it is more than or equal to 21. Methods, these are the methods for CTC analysis, RT-PCR, and then physical, this strategy, and then immunomagnetic isolation. Here lies the importance of tumor type and the site. Like, for example, this one, this mucinous adenocarcinomas or signet ring cell type carcinomas, usually they show microsatellite instability and activating BRAF V600E mutation is observed in these cases, and their outcome is supposed to be accordingly whether they're positive showing a mutation or not. Histological type, second is medullary carcinoma type. Again, they show MIS, and then serrated adenocarcinomas, they show BRAF or KRAS activating mutations. So after seeing the morphology, then we can decide which ISC to be put to cut down the cost. Otherwise, if we apply full panel of antibodies in each case, it will be very costly. That's lies the importance of correlating with the clinical scenario, location, and the morphological type. Then we decide what should be the antibody panel. Like and this is important. These type of tumor, they do not have clear molecular correlation. Adenoma like adenocarcinoma and micropapillary type. And these are the grades which we write always, G1, G2, G3, what it means. Already you know G1 is well differentiated and G4 is undifferentiated. Immune response, intratumoral lymphocytes and Crohn-like means those formation of lymphoid follicles. If they are there in the tumor morphology, they will decide to go about this ISC, CD3 and CD8 because they indicate better outcome. Ultimately, what is the aim?
Can you complete?
The last 2 slides. Ultimately, what is the aim? To identify the target areas, that is called biomarkers, which we discussed till now. And these are various biomarkers and their outcome and how they're applied. Which drugs will be effective? EGFR antagonist will be effective or not? They are going to decide all this. This is a list of biomarkers which are under research level. So take home message. I hope there is some take home message, especially for the surgeon. I'll request that if things are not available here for all colorectal cancer cases, this full protocol should be advised and accordingly can decide this. So a multidisciplinary approach should be taken. Ancillary testing becomes very important, plays very important role, and it can identify, as I told you, the tumor predisposition syndrome and all other things which we have already mentioned. So cooperation between surgeon, radiologist, and pathologist is a prerequisite to provide an accurate diagnosis and management to the patient, which can withstand the statement. Histopathology is a gold standard. It will remain so. For a pathologist, every specimen is a patient, which we have to make talk and tell about itself, mostly through treating surgeon. We don't talk directly to the patient, but through the operating surgeon, we have to communicate, and then only the patient is talking and telling about himself or herself. And please read about this also, last line. This culture is a report that role of pathologist. Thank you. And I would like to thank, especially I would like to thank Dr. Shubhangi, Associate Professor of Department, and Dr. Mamta Gupta to provide and to help me in preparing this presentation. Thank you.
Thank you, ma'am, for a wonderful presentation, and everything is very well covered. If there are any questions from the house, I think ma'am will be very happy to answer that.
Correct, ma'am. You have left very wisely. You have left a space. See,
I left the space to create her,
exactly.
but I could not put it. There was some.
That is something missing.
You pointed out correctly. I wanted to make his/her because her is more actually in this subject.
Not about this, sir. Ma'am has correctly said there should be a communication between the surgeon and the womb. There was a patient who has got a swelling in the lid. Dr. Sandeep removed it and sent for the histopathology examination. By that time, the patient informed that I have got another swelling over the scalp, some swelling. That was also excised, was sent. Madam rang me up after 4 or 5 days, said they were two swellings or it was the extension of the same thing. Then remember there were different swellings. Both are having the same histopathology. I'm not able to understand. Is it a syndrome or it's some malignant case? Then I remembered the patient was operated 7 years back for RCC. There were skin mats over there.
Yes, yes. Remember clearly. Luckily, you remembered that case. Actually, it was reported as renal cell carcinoma. Because renal cell carcinoma cases, as you know, they can look so benign. These cells, vegetable type cells, they look. So it was difficult. That lies the importance of communication. It's very important to give proper reporting.
Well, thank you, ma'am. And for the residents, I'll just summarize the whole thing. Molecular marker today is the most important aspect of any cancer, especially metastatic cancer. In any metastatic cancer, NGS, new genome sequencing for molecular markers is required. We are in the era of precision medicine, targeted therapy. And until we treat the targets, the treatment will never be as good. In terms of a non-metastatic setting, colorectal cancer is one wherein all stage 2 cancers, you need to do a MSI. Because if it is stage 2, MSI stable. MSIH or MMRD deficient is a good prognostic sign. And if it is a stage 2 colorectal cancer, these patients do not require adjuvant chemotherapy. Stage 1 never require it. Stage 3 always require adjuvant chemotherapy. Stage 2 will require adjuvant chemotherapy only and only if it is MSS, microsatellite stable. So all stage 2 require it. In the scenario of a stage 4 metastatic cancer, these molecular markers are definitely have to be done. And all patients, and here, as she's mentioned, left and right, today there are two different cancers. A cancer up to the splenic flexor is a right cancer, and up to, from that onward is left cancer. You get these markers done in both the cancers, but it has been seen that if it is a left side cancer, these markers target therapies don't work as well, except for MSS. So if it is a left side cancer, metastatic, even if these targets are positive, you give an anti-angiogenic agent along with the chemotherapy. So all chemotherapies are now associated with the target therapy, which is decided by that. And if it is MSIH on the left side, you give immunotherapy. On the other hand, sorry, on the right side. On the other hand, if you talk about the left side, now left side, this becomes more important, all these molecular markers. And if those molecular markers are positive, you can actually avoid chemotherapy completely. You can just give like anti-EGFR, pembrolizumab and cetuximab, or you can add chemotherapy along with that, depending on how the patient is. So we're talking about target therapies today. And even first line, second line, third line is dependent on the molecular markers. So believe me, it is not a question of cost. Today, cost has come down drastically. When I started practice, this NGS was costing almost 75,000 to 80,000 rupees. Now, a lot of Indian companies have come up, and we can get these markers done for around 14,000, 15,000 rupees. And they should be done because the whole treatment protocol is based on precision medicine. And I think that is why this lecture today, all of you should remember it, especially the residents, because that is how cancer is going to be treated and is being treated today and in the future. Thank you very much.
Thank you, ma'am and sir, for the enlightening talk. Now I request Dr. Umang Mittal, sir, to felicitate Dr. Rani Bansal, ma'am. I request Dr. Shashank Mishra, sir, to felicitate Dr. Umang Mittal, sir. This is to announce that poster presentations will start from 12 o'clock on the ground floor. All the residents who are participant kindly submit their posters in the ground floor outside LT1. Moving ahead with our next talk. The talk is on current management guidelines for colorectal malignancies. Talk will be given by Dr. Rudra Prasad Acharya, who is a practicing oncosurgery since last 12 years. He has special interest in GI oncosurgery, thoracic oncosurgery, uro-oncology, and sarcoma oncology. He has been practicing minimal assist surgery in all types of cancer. Recently, robotic oncosurgery is the new advancement which is practiced by few of the cancer institutes, and he is practicing them. Dr. Rudra is also an expert in treating sarcomas and especially bone tumors in the form of limb salvage surgery. Currently, he is practicing in Paras Hospital, Gurgaon.
This talk will be chaired by Dr. Rudra Prasad. Hello. This talk will be chaired by Dr. Rudramani, who is currently working as an associate professor in Department of General Surgery, Dr. Ramanohar Lohia Institute of Medical Sciences, Lucknow, and is also an ATLS instructor, ATLS India, also a faculty in minimal access surgery programs at RML, Lucknow. His keen areas of interest are minimal access surgery, hepatobiliary trauma, capacity in building India. His awards includes prestigious TB Banerjee Symposia, UPSCon 2021 in Aligarh Muslim University, and he is instructor in ATLS. He has many publications in reputed journals. Also, the talk will be chaired by Dinesh Kumar Sharma, sir, who is a well-known oncosurgeon who is currently practicing in Meerut. Sir, can we please have you on stage?
So after two elite talks from on prevention and pathology, now we come to the main topic, that is the surgery. Because this is a surgery update, it is very important to have the surgical field, how it evolved in field of colorectal cancer. First of all, I thank the organizers of Meerut Surgery, Subharti Surgery Update for inviting me, and Dr. Umang Mittal for inviting for this talk. Now, as you know, colorectal surgery has been the bread and butter for general surgery, which later on went to specialize as with the surgical oncologist and GI surgeons. And now it is a completely evolved field of only colorectal surgeons. So when I completed my surgical oncology training, I went to Sydney for 1 year for a colorectal. I was thinking why it is so important to have a separate colorectal training. But if you see the 1 year I spent there, and when we actually understood the colorectal system, it needs a complete separate mindset to treat these kind of patients, because they are different from the other GI surgery with specific areas of work. So if you see the surgical principles of colorectal surgery, it is based on anatomy, pure anatomy, nothing else. And the anatomy is based on the embryology. As Madam told, right-sided cancers, left-sided cancers, embryological envelope, fascial envelope, these are the guides of the surgeon. whether you do open surgery, whether you do laparoscopic surgery, or whether you do robotic surgery, if you follow the principles and the planes of embryological fascial planes, you will never err in your surgery, because what is important is intact of the mesorectal or mesocolic fossa during the surgery. So many surgeons are doing colectomies, so many surgeons are doing rectum surgery, but when you finally see the specimen, you can know how well the surgery is being done. So that is what I will come to the point of today's. First, I will talk about the evolution, because there have been, in the last decade, there have been a lot of changes in the evolution of colorectal cancer surgery. First is, as Madam told, to understand the molecular biology. I call it Janam Patri. If a person is born, first you make the Janam Patri. The same thing, the tumor needs the Janam Patri or the molecular profiling before treating. Because if it is a right-sided tumor with few of the gene markers, it will behave differently than the left-sided colon. So that is why it is very important to know the molecular biology from the biopsy itself, not from the main specimen. From the biopsy, from the beginning, we should know the molecular biology. Then advanced surgical techniques. Definitely laparoscopy and robotic has crossed all the platforms from open surgery, and they have become the standard of care in today's era. And MRI and CT scan, there are very specific areas of doing the specific type of scans. As for rectum, we do MRI with rectal coil, where you can find exactly the tumor, the T size, the node, and if there are any mesorectal fascial involvement. Because you see, from the surgery starts from the CT scan or the MRI console. The decision is taken in the radiology room, because whatever the patient presents today with a MRI, you cannot change. You can give neoadjuvant chemotherapy, you can decrease the size of the tumor. But once a mesorectal fossa is involved, this tumor is going to fail locally. Then having a small tumor with having distance lymph node. So everything is decided from the radiology, from the MRI console itself. So it is very important to take the radiology in the multidisciplinary team to decide about the tumor management. Similarly, chemoradiotherapy, lot of advancements have made, and this has made the surgeon's life more easier, especially for lower part of the tumors of the rectum, where previously almost 30 to 35% recurrence when we go directly for any kind of APR or a low rectal surgery with entry section. But if you see it in today's era, when you give chemoradiation, the outcomes are so good, it is hardly less than 2 to 5% in today's era, with proper principles of surgical planes being followed. I will go into the details in the later. So similarly, the other most important area is the metastatic colorectal. Previously, metastatic colorectal means it is an end game, hardly 3 to 6 months. Now I will show you evidence. My patient is living after 8 years with a primary liver metastasis. So it is totally different ball game today to treat all these kind of colorectal cancers. And lastly is the interventional radiology advancement for the liver mets in the form of RF and thermoablation. So with this, we come to the surgical technique. The first surgical technique described for CA rectum was TME, that is the total mesorectal excision. Very simple technique described by Bill Hild, who described the plane of avascular plane just in front of the sacrum. And it is so easy when you do a laparoscopic surgery, you can find the plane is so easy to go. And these surgeries have become much simpler when you follow the planes. And similarly, this same principle is now applied to the colon, which is called as complete mesocolic excision. So the fossa is the king. If you maintain the fossa and respect the fossa, take out the fossa completely, because you see what is how the tumor spreads. It goes to the lymphatics, then to the fossa. If you anywhere destroy the fossa, you are changing the direction of the lymphatics, and the chances of having a local recurrence is very high. It is very simple. So you have to maintain the principle of making the complete taking out the fossa along with the organ. Organectomy is not the answer. It is the organ along with the complete facial envelope, along with the lymph node drainage area, which is a lymph node basin, what is called as D1, D2, D3, is the first echelon, second echelon, and third echelon group of lymph nodes. So when you do this completely regional surgery, it is not a organ surgery, it is a regional surgery. Organ, fossa, and lymph node. That will give you the best outcome at a later date, because what you do today will be reflected after 5 years. It is not after 2 years. It is after 5 years. When the patient comes back with a recurrence, it will tell who is the surgeon, and then comes how was the surgery, that will be decided, not today. Now, as I give the background, so many cylindrical concept of rectum was described by Miles. Then lot of APRs were done. But when ultimately Bill Hild described this facial plane, and it is, you see this specimen, it is complete with a facial envelope. Unless you get these type of specimen, it is not a surgery. It is just an organectomy. It is not a cancer surgery. So when you have the complete lymphovascular entity enveloped by the facial envelope, along with mesorectal nodes, you can see the tumor is at the primary, and there is a completely mesorectal fossa in the surrounding. And you can see the planes, and you can see at what part, upper third, lower third, where the tumor is lying. Depending on that and the peritoneal envelopes, you will decide about the surgical technique. And the local recurrence, as I told you, that decreased from 35% to hardly 2 to 5% because of the principle. So it is one principle that changed the complete outcome in colorectal patient. Next comes is the sphincter saving surgery. Are we doing sphincter saving for lower third tumors? Because lower third, it described that the tumors which are present hardly in lower part, that is 5 to 7 centimeter from the anal verge. So when you have such kind of tumor till 5 centimeter, everybody is happy. But if the tumor is less than 5 centimeter from anal verge, most of them, they land up in what is called as APR with a permanent colostomy. But do you think that if a young patient is given a permanent colostomy, he will be happy? He will be moving around the city with multiple surgeons, but he ends up in having a metastasis rather than going for a permanent colostomy. So where is the answer? The answer lies in sphincter saving surgery. I will describe this in detail. So when the TME was developed, the technique is from above to below. Now the new technique has come, which is called as down top technique. That is, whenever you have lower tumors, you do the upper part laparoscopically from above till the end of the mesorectal fossa, but at the same time, you put a retractor on the perineum, and you can see the tumor. Below the tumor, have a proper margin where you want the margin, cut at that side, and go in a downwards upward method, what is called as transanal TME. So when you go this and connect with the above and down, it is a hybrid technique. I do it very often because that happens that lower part, the tumor is only mucosal. It is not submucosal. And with the MRI, we decide whether the sphincter is involved or not. And according to that, after the chemoradiation is over, and we do again a repeat MRI to see the outcome of the tumor. Most of them with today's type of chemoradiation have complete radiological response. There is no tumor at all. Then in these cases, is it justified to give a permanent colostomy, it is not justified. So what we do is a hybrid technique. I do laparoscopy from above and do a transanal excision from below and combine both of them, and I save the sphincter. So that is how the sphincter can be saved. And this is called as intersphincteric resection, where you can go with lower part only mucosectomy or a partial sphincterectomy. Even the internal sphincter can be completely removed also. Only the external sphincter can be trained over the period of 6 months with ileostomy, and it will become fully functional after 1 year, and the person is without a colostomy. See the change, because previously, if you go to a general surgeon, he says 5 centimeter, I do a complete APR, I will do a very good surgery, large surgery, and having a permanent colostomy. The person is having a stoma throughout the life, but there is a lot of change now. You have to do a complete post-CTRT MRI assessment. If there is a complete CR, then the intersphincteric resection is possible, and that leads to more sphincter saving. So this is called as TAMIS. TAMIS requires few special instruments, but we do with standard laparoscopy instrument. TAMIS is transanal minimal invasive surgery. Some people do complete TME with the transanal surgery, but it is under trials. A lot of failures have happened because the MRI assessment was not good. And when they did the TATME, local recurrence was high. So it has to be post-chemoradiation, but still what we talk is that whenever you do such type of surgeries, it is with a pinch of salt. The surgeon must be well aware of MRI findings, and then he can do. Now, next comes whether laparoscopy or open. This answer is already there since last decade. Now, for colorectal surgery, there is no open surgery. Although we are all trained by open surgery in the beginning, before 20 years, but over the evolution, we had to train ourselves because laparoscopy is the answer. And you do one laparoscopy, colon or rectal surgery, in the next day, you will not enter to a open surgery theater, because the planes are so good, so magnified, that in a cancer surgery, whatever you need, the fascia, the lymphatics, the lymph nodes, they are so well visualized, and the planes are so well maintained that it is so easy to do. And with grace of God, with so many expertise, and now I'm a trainer to so many centers, including out of the country. So that will give you the best outcome when you do it laparoscopically, because all the fascial envelope, lymphatics, lymph node, everything you can clear very nicely. And it has been proved with all the trials. You can see the trials. The trials are quite old, more than 10 years, and they have recruited more than thousands of patients. And the outcome is so good that early to home, early to chemotherapy. Whenever you do an open surgery, what is the problem? The person does not come to the chemotherapy for taking the daycare chemotherapy even after 2 months. He always says this pain, that pain, scar pain, everything. But when you do laparoscopy, after 2 weeks, the person is fit, but we give 4 weeks time for the complete recovery, but within 4 weeks, the patient is started taking chemo. So you see, if you give a more window period, you are giving more chance of developing a microscopic disease to a metastasis. So it is very important to bring the patient to a chemotherapy table as soon as possible. So this is all possible with laparoscopy and all the classic color, cost, Korean, so many trials. Now robotic roller trial, so many trials have come in robotic also. Robotic is mostly for the rectum, lower rectum. But because if you have a robot, you can use anything. So we do colon also. But mostly we do in ultra low, very low tumors, robot is fantastic. Because what you are operating is behind a pubis. Pubic symphysis, which is a fixed structure. You cannot make it expand. So whether it is prostate or lower rectum, they are best done with the robotic, because you can reach to any angle, posteriorly, anteriorly, laterally, any angle, and that is the best. So with this, I think this, and the final answer is the pathology, is the king. So if you see all laparoscopy, distal margin, circumferential resection margin, all have been so good in these trials that it has been completely accepted. Now it is the gold standard. Now, to be with percentage wise, if you see the overall survival, the laparoscopy had 83% overall survival as compared to 66% in open. Why? Because you see the magnification advantage has been taken by the surgeon, and that ultimately it is passed on to the patient to have the best survival. Now, as I was talking about intrasphincteric, very well described. You can first understand the anatomy of the anorectal ring, and after that you can see the sphincters and how it spreads laterally. That is more important. So first question is that whether the sphincters, internal sphincter is involved, partial or total, or there is levator ani involvement and majorectal fossa is involved. These are the three questions we talk when we assess these on MRI, and according to that we decide whether ISR is possible or not. Because if it has gone beyond this to the levator, there is no question. You have to do an extra levator resection, which is called as ELAP. That is extra levator abdominal perineal resection, which is totally different. So intrasphincteric surgery is possible now, especially after this down top technique. So I combine the top down technique with the down top technique to complete the TME. And coming to the pathology, you see the specimen. This is a classical abdominal perineal resection specimen. The majorectum is having a coning at the lowest end. Then the muscles are there. How this APR specimen looks like. But if you do them the actual staining, because peritoneal part doesn't need, the extraperitoneal part we usually do the staining, it should be smooth in the surface. There should not be any tethering. So if there is any tethering, now there is a complete pathological grading where it is called as complete majorectal excision or near complete or incomplete. And when you slice it transversely or in a coronal section, you can very well see the tetherings very elusively. So the surgeon cannot lie. When I was in Japan, it is very simple. You do the surgery, take out the specimen. Before doing the reconstruction, you have to go with the specimen to the pathologist. They will put on a table, fix it with the pins, then they will do a photography. Because specimen photography is the only evidence that the surgeon has operated. You can lie later, but photographs will never lie. So they do the photography, then they will put in the staining, then they will slice and again take photographs. Next day, when you are in the office, you will have the previous day surgery photographs. So that is how the surgeon is being assessed by the pathologist. It is not that what you do is right. You are not the boss. The boss is the pathologist. So there is an American College of Pathological Guidelines, how to do the grossing and how to do the specimen reporting. That decides the surgeon's skills and the outcome. So similar is being applied to colon now, which is because the new concept of this fascial envelope. Previously, colonic surgery, people were doing open surgery, putting the hand, just pulling and doing the surgery. There was no respect for the fossa. It is colectomy, hardly it is anything. Somebody says I did in 32 minutes. Somebody says I did in 40 minutes. But when you take the specimen photography, you know in 32 minutes what you do to the fossa. And that decides final fate of the patient. It is not your heroics that will decide the outcome. So take 2 hours do a complete facial surgery complete along with the lymphadenectomy, then the outcome will be different. 32 minutes cannot make the patient. It is just the surgeons to satisfy surgeon's ego. So it is very important to do a complete facial excision, which is called as complete mesocolic excision, mesocolon in toto. Anterior fossa, posterior fossa, embryological plane of the fossa above the psoas. There has to be no fossa left on the psoas muscle. Then your facial plane is complete with the colon. Otherwise, you have left the posterior parietal fossa, posterior visceral fossa over the psoas. And that will have a recurrence hardly in 1 year. It will not have immediate, but it will have in 1 year. So it is very important to know that how to respect these facial planes and do the surgery. And that is best done with laparoscopy because you have 100 times magnification. Even if you want to leave a fossa, you cannot leave because you are seeing that the fossa is being left. So when you try to lift from posterior, you can know that I am going behind the fossa and lifting. Otherwise, bleeding will happen when you go between the fossa and the organ. So very simple. So laparoscopy, why it has become popular is the principles are better adhered than the open surgery. So laparoscopy is more popular, and especially after robotics, it got 360-degree rotation of the hand or the arm. So it can go in any direction. So that is more advantageous to the surgeon. Similarly, coming to the lymphadenectomy, D2 dissection is very common in stomach, but nobody thought that this will come in colon. Now they are talking of D3 lymphadenectomy in colon. So what is it? It is nothing but bare every tissue in front of the SMB, superior mesenteric vein, because we were going always right to the vein in the mesocolic soil. I will show you another picture how the surgeons were more easy to operate when you are in the soil. Soil is a hole that is described, but in medial to the soil there is tissue over the SMB, which if some microscopic tissue is there, the patient comes with a large node in front of the SMB in a right-sided colon after 3 months. So it is a complete surgical failure. So this should not happen. So it is very important. Now you see this specimen. There is a clear-cut, transparent part of the mesentery. The surgeon is very tempted there to, whether you are doing a laparoscopy or open, is very easily tempted to put in that hole and put one clamp above and one clamp below and your colon is out. But the tissue you leave medial to this hole is more important, and that is what is called as D3 lymphadenectomy. It is D3 means everything above in front of the SMB has to be taken. So similar to colon, same photography, same transverse section, you can know there is facial tethering or not, along with the omentum which is intact. So there is nothing to lie, everything is in black and white, very simple. So the other method, what I described, is the transanal TME. Complete transanal TME we are not doing. It is being practiced now in some of the areas like Brazil, Greece, but they had a lot of failures. So some of the trials they've stopped, but still it is a evolution process, because whenever you have a very low rectal tumor, imagine 3-dimensionally, when you go from down to above, you will have a better circumferential resection margin. It is definite. But when they were doing, they were not able to, whether the MRI assessment was wrong or post-chemo radiation, everything is fibrosed, you are not able to know the planes, which led to the failure that nobody knows. It is under now trial, but still this is a very good method. So what we do is at our center is, whenever we have any tumor which is less than 5 centimeter, I do in a hybrid approach. I do the above part, starting from clipping the vessel inframesenteric artery, and taking the complete rectum in the facial plane till the major rectum. Then I do the transanal part below, putting a retractor. And when you go with the mucosal cut and you send that margin also for frozen, whether a microscopic disease is there or not. And then you complete both combined, like a abdominal perineal resection. What you do, it is a two-team approach. One team is doing above, the lower team does the outside the rectum and touches the above team. Same thing is here, but here it is inside the mucosa. And same plane is being touched, and after that you see, you will get a very good rim of mucosal tissue in the lower part, where you can take the colon and do a hand-sewn colonal anastomosis, and you can save the sphincter. These patients, we do ileostomy, and we follow up till 6 months with complete perianal muscle training and physiotherapy. And once they attain the continence, then we do a lupogram, CT lupogram, and then we close the ileostomy. So this is the beauty of new developments, and I will not go into more details. I think the next kid on the block is the ICG. After you do a entry resection, how do you know that the anastomosis is completely vascular? It is very simple. You put 5 ml of ICG intravenously. It is a green color dye available with us. We do in breast also, in esophagus when we do stomach tube, we use that also to know the vascularity. And similarly for this rectum entry section, when you give the 5 ml of dye and you do the anastomosis, then just put your telescope from the anal side and you see the, I don't know whether this video will run. I think it's not running. So it's okay. So when you put the telescope from down, you can see the vascularity, completely green structure at the site of the stapling line. And that gives the best sleep to the surgeon, that you have the best vascularity. So you know this patient, I don't do even ileostomy unless it is ultra low. If it is less than 5 centimeter, I will do a ileostomy, as I told you. But if it is above 5 centimeter, I don't do defunctioning ileostomy if I am satisfied with the ICG testing. So this is very simple. Then, like I told you, I think there is a full panel discussion on metastatectomy, and the colorectal mets have been now it is totally different ball game. You can do as many metastatectomies as many times. I have operated one patient 6 times, multiple quadrant. You just take punch out metastatectomy. I do completely ultrasound guided. I don't do any liver surgery without ultrasound. You can mark all the veins. You can mark all the metastasis before putting the cautery. So it is very intraoperative. Once you put the incision, you do an intraoperative ultrasound, mark your site of metastatic lesion, and also mark the vessels, and then just punch out that lesion with good margin and send for frozen. It will all come negative. Ultrasound guided is the best. Now, in this also, now the development is putting ICG. ICG will show you the tumor very clearly, and you can have a very good margin. So, in conclusion, the principles of TME and CME should be followed. ISR should be taken with a pinch of salt, but if you have a good MRI review, pre and post chemoradiation MRI, then you can do a complete ISR with confidence. As you do more cases, you gain more confidence, as we have got a very good series. Similarly, chemoradiation is the only answer where you will get the lower third of tumors completely vanished. There is a complete response. And laparoscopy or robot, it is a skill. If you have the skill, use it. And it is of the best for the patient. And staplers have changed the lives of the surgeon. Previously at Sydney, when I was doing hand-sewn entry resection, I remember we used to put minimum 30-40 sutures, Still we think that it might leak, but now it is a totally different ball game, and ICG is the new kid to be used. Thank you very much.
Thank you, sir. First of all, before proceeding forward to take any questions, I must congratulate you for this wonderful presentation. And it was the best thing that you have touched every aspect of this developmental part in the surgical aspects of treating colorectal surgeries. And I could see that the people in the audience were mesmerized, few were standing and to listen you. I congratulate once again. And now the session is open for the discussions. If there are any questions, we would like to take up.
Sir, as you mentioned that you also had the training in Japan also. In Japan, they routinely do lateral lymph node dissection for CA rectum. So it's also a routine practice in Paras Hospital?
Yeah. So this depends on the first MRI. In a rectum, in colon nothing, but in rectum, in the first MRI, if you find a mesorectal node or a lateral node from the beginning, then when you give chemoradiation, because Japan is a totally different world, they don't use even chemoradiation in rectum. They do all surgeries. They say surgery is the king and everything is surgery only. So they give chemotherapy, but no radiation to rectum. But reverse, they give radiation to pancreas because they say if you radiate the pancreas will be dead. So there is no leak. So that is their concept. So in rectum, they don't give radiation. And from the beginning, they do a MRI assessment. If they find a lateral node already, then definitely they do the lateral lymphadenectomy, not in routine practice for all T2 or T3 tumors, but T2 tumors. T3 tumors, they will do lymphadenectomy. But in our practice, it is MRI based. In MRI, if you find a node, but when you give chemoradiation, it will not be there. It will go straight away. You cannot find it post chemoradiation. We have seen several times that there is no node at all, but still we do the lymphadenectomy because microscopic. You see, lateral lymph nodes also, they have described just like the esophageal or gastric staging of the nodes. So they have, I don't remember exact number, but 115, 113 like this, they have this numbering. So they have external iliac node, they have internal iliac node, they have obturator node. So if you see a single internal iliac or external iliac node in the first MRI, you must do ipsilateral, not the opposite side. Only ipsilateral, complete lateral lymphadenectomy, which is hardly a 15 minutes job for a laparoscopic surgeon to do a lateral lymphadenectomy. It is only a 15-minute job. So we do it, but not in all cases, only when MRI proved pre-chemoradiation positive node is seen.
Sir, as far as you said, you mentioned for knee and neoadjuvant chemoradiation, in your setting, you prefer short course or long course?
So that depends on case to case. I think Arun is going to take a full class on that.
Does the surgeon has a say in that, or is radiation oncologist that's
No. There is first try to understand it is a unanimous international criteria. He cannot err on it. I cannot err on it. There is a completely what is TNT, what is neoadjuvant, what is short course, what is long. Everything is defined. Everything is black and white. There is nothing called as I do this and you do this. Most of our patients at present are on long course, but there are specific areas where short course needs to be done in order to have the more chemotherapy. Very simple answer given by the latest article from ESCO, that first assess the patient. He has a chance of more systemic failure or a local failure. Very simple. If you assess the patient completely and there is chance of more systemic failure, give short course and push all chemotherapy in front before doing the surgery. All chemotherapy has to be preponed to pre-surgery time. Do short course followed by full chemotherapy, then do the surgery, you will have the best result. But if there is chance of local failure, mesorectal fossa threatened already, it has gone out, the chances of having failure is more then don't fiddle with short course. Give complete long course, that will have the best long-term effect.
So, sir, you said that you don't routinely do a diabetic ileostomy. So, let's say even after any CTRT and the tumor is, you said that if it is above 5 centimeter, you don't go routinely for ileostomy, but below 5 centimeter, you do.
Yeah.
So, in all cases, sir, even the patient has taken NOCTRT.
NACTRT doesn't matter. What is important, because you see, after the type of radiation they give, actually Arun and me worked more than 6 years in Max, and the type of chemoradiation they do, I don't find any problem in operating or vascularity or anything. So for me, it is like a normal tissue.
Okay, thank you, sir.
Thank you for this wonderful talk, sir. I would like to invite Dr. Rudramani, sir, to kindly felicitate Dr. Rudraprasad Acharya, sir.
Thank you, sir.
Thank you, sir. I would like to invite Dr. Varun Kulshetri, sir, to please kindly felicitate Dr. Rudramani, sir, and Dr. Dinesh Kumar Sharma, sir. Thank you, sir. For our next session, I would like to call upon Dr. Arun Kumar Verma, sir, who is a radiation oncologist with a post-MD experience of more than 16 years. Dr. Arun is a highly skilled and well-recognized oncologist. Before joining Subharti, he was working as a principal oncologist in Department of Radiation Oncology at Max Institute of Cancer Care at Max Healthcare, Delhi. For many decades, he led various task force groups that guided the management or the latest treatment approach or research in the field of head neck cancer, brain tumor, lung cancer, esophageal GI cancer, rectal, prostate, and genitourinary cancer, uterus and other gynecological cancer, sarcoma, and other musculoskeletal cancer, lymphoma, and hematological or pediatric cancer. Dr. Arun has been trained and gained experience in all types of advanced cancer treatment at India's premier institutes like AIMS, Delhi, and SGPGI, Lucknow. With over 2 decades of experiences in oncology, he has earned a reputation at national and international level, which has helped him to develop his evidence-based and personalized clinical and ethical approach. We invite you to give your next talk, sir.
Sir. To chair this session, I would like to call upon Dr. DP Sharma ma'am, who is a radiation oncologist at Institute of Liver and Biliary Science, New Delhi. Ma'am has more than 50 publications in national and international journals. She has completed the IACA Palliative Care Fellowship. She is a member of Association of Radiation Oncologists of India, Indian Society of Oncology, and European Society of Medical Oncology. Please join us on stage, ma'am.
Very good morning to all of you, and thank you organizing team for giving me opportunity to talk on role of chemoradiation on anorectal cancer. Most of topics are covered by Dr. Rudra, and they made my job easy, and I will concentrate only on the basics so that the post-op resident get benefited. What do you mean by chemoradiation? Chemoradiation means there is two modality. The radiation therapy and chemotherapy are used simultaneously during a course of time. Radiation therapy, as you all know, is high energy X-rays that are focused to the tumor, and that X-rays will break up the DNA of tumor cells, and then the slowly cancer cells die. And chemotherapy is the drugs which specifically act on the proliferating cells in different way. Some chemotherapy act on the cell membrane, some act on the cytoplasm, or some in the DNA level. So that when these two agents are used simultaneously, then there is a synergistic effect. It is not 1 plus 1 is equal to 2, it is 1 plus 1, 11. So where the chemotherapy is given in either low dose or in a full dose, and the basic purpose of adding chemotherapy is to enhance effect of radiation therapy. If we see how the chemoradiation is applied in case of a colorectal malignancy, there could be three case scenario where it can be utilized. One is the colon cancer, where the surgery is main treatment and radiation therapy is hardly used. Surgery is followed by the chemotherapy or plus minus biologicals. As Dr. Rudra already told, colon is the malignancy which has a special feature depending upon embryology into right and left, and I am not going to discuss about that. In colon, only one scenario where chemoradiation can be utilized, that is the T4 inoperable colon cancer, especially cecal malignancy, where the tumor is adherent to the paracolic gutter, where the surgeon feel it may be inoperable. In those cases, we can add neoadjuvant chemoradiation. Otherwise, it is the dual modality treatment, surgery followed by chemotherapy. The contrast to the colon cancer, the anal cancer is the cancer where the chemoradiation is standard of care and surgery is reserved for salvage. The rectal cancer is something complex where the everything is required: chemotherapy, surgery, radiation therapy in different combinations, and this is called multidisciplinary or multimodality approach, and chemoradiation is integral part of that. The goal of chemoradiation is to enhance local control for, as Dr. Rudra told, is also the main importance of chemoradiation is to increase the sphincter preservation rate, especially in the low rectal cancer by down staging. It reduces the recurrence rate and improve overall survival. What are the indication of chemoradiation? If we see, it can be in the form of definitive chemoradiation, in the form of neoadjuvant, it may be post-operative, or it may be in palliative setting. I will go one by one. The surgery in role of chemoradiation in rectal cancer, how it is incorporated. As we all know, surgery is the main modality in rectal cancer management. However, it has shown initially the surgery alone is associated about about 30 to 35% recurrence rate. So that in those cases, we can reduce these recurrences by adding post-op chemoradiation and by eradicating remaining cells present in the tumor area. For resident, I will tell how the chemoradiation is. If any patient is selected for radiation therapy, then the first step to make the patient make a mold so that the radiation therapy can be given in a particular treatment position, and during treatment patient should not move. And then the next step is to contour or to delineate what area to be treated, and this take about 1 to 2 days to finish the contouring, and followed by there is a team of medical physicists who plan whatsoever dose I want to give to that area, and this is called treatment planning. And what are the area to be spared, like the anteriorly lying the bowel to be spared, and the laterally the tissue, lateral non-specific tissue bones to be spared. And this is the basic workflow, those who not knowing about the radiation therapy, how it to be delivered. These are the trials which have shown that adding the radiation therapy and chemo is going to reduce the post-op recurrences, and further adding chemotherapy that reduces recurrences up to tune of 5 to 6%. So in that, what are the conditions where we can give post-op chemoradiation? If the rectal cancer who get operated upfront, then we have to see as Dr. Rudra has told, we have to see Janam Patri. That means ki post-op histopathology report of that patient, whether that patient is having T3, T4 disease or node positive disease, or having extramural venous invasion, LVI, PNI. These are having a margin positivity or high grade tumor. These factors to be looked into decision making for the considering patient for post-op chemoradiation. What are the disadvantages of post-op chemoradiation? After removing the TME, after removing the mesorectum, there is enough empty spaces generated that get filled with the small bowel, and that bowel come into the irradiated area, and that lead to high bowel toxicity, and sometimes some bowel post-operatively get adhered with the pelvic side wall, and that become a major cause for the late bowel toxicity. Sometimes these patients develop intestinal obstruction also. So that's why another issue with the post-op radiation therapy is the compromised vascular supply post-operatively, and there is no advantage of down staging, especially in low rectal cancer, where if we operating directly, there is a high chance of margin positivity, and patient may land up into permanent colostomy. So that's why the new concept is evolved, that is called neoadjuvant chemoradiation therapy in rectal cancer, where we adding chemoradiation therapy before surgery. And what are the rationale behind that? It improves compliance of patient, it reduces toxicity, whatsoever associated with the post-op radiation therapy, and radiation is more effective in these cases because tumor is present in situ and it is oxygenated tumor. As we all know, the radiation therapy more work in the oxygenated tumors. If it is a hypoxic tumor, then mostly hypoxic tumor are radio resistant. And another importance of the preoperative radiation therapy is down staging, which is very crucial, especially in the low rectal cancer, where we require sphincter preservation for the organ preservation and better quality of life. This type of neoadjuvant chemoradiation, as the previous chairperson, we are discussing what are the type of short course and long course chemoradiation. These neoadjuvant radiation therapy can be given by two types. One is the long course radiation therapy and one is the short course. What do you mean by long course? That in this case, radiation therapy, daily radiation therapy is given 5 sessions per week over 5 weeks. And what do you mean by short course radiation therapy?
This is the 5-session radiation therapy that to be given Monday to Friday. Within a 1 week, treatment is complete. So that's why it is the, as the word says, the long course, it is a 5 weeks treatment. Short course, it is a 1 week treatment. How we choose it, we will discuss in next. These are the trials which I have shown. I'm not going to go in detail. Mostly the whether we use pre-op radiation therapy or post-op radiation therapy, efficacy-wise both are equal, but there are pros and cons of which we have discussed. Pre-op radiation therapy is associated with lesser side effect. That's why it is now a standard of care. There are some trial which also says that the post pre-op radiation therapy is associated, is more effective, and it reduces local recurrences to the tune of 5 to 6% in comparison to post-op radiation therapy, where the local recurrences is to more than 10%. These are the trial how the neoadjuvant chemoradiation are evolved over the time. The indication of pre-op chemoradiation therapy in rectal cancer is standard of care, and these are the indication: locally advanced T3, T4, node positive or threatened circumferential resection margin or oligometastatic rectal cancer, which we are going to discuss maybe in the next panel discussion. Remember, the long course radiation therapy is given with the chemotherapy. It is a chemo radiation, and the standard till date, the standard chemotherapy which to be added with the radiation therapy is 5FU or oral capecitabine, which is a analog of 5FU only. And over the time, a lot of trial is designed to aid more and more chemotherapy agent, but till date we failed to show any extra benefit over 5FU alone. What to be timing of surgery? If we giving the pre-op radiation therapy or pre-op chemoradiation therapy, then there are two concepts. One is the short course, one is the immediate surgery, which is mostly done with the short course radiation therapy. When short course radiation therapy initially introduced, it is given, we give short course radiation therapy, and within 1 week we do surgery. But later on, we realized that if we delay the surgery, even after short course radiation therapy, it has some special advantage, and its effect look like long course radiation therapy. What advantage is associated with long course radiation therapy? In these cases, surgery is delayed up to 6 to 12 weeks. And by delaying the surgery, what will we gain? We gain more tumor regression and minimize surgical complication, because patient get time to recover from the post radiation therapy complications, and optimal it will optimize the functional outcome. Delayed surgery may be associated with higher rate of pathological complete response. As much as we delay, it increases the chance of tumor regression. Additionally, delayed surgery may allow better healing of irradiated tissue and reducing risk of wound complication, promoting better functional outcome, especially patients who require sphincter preservation surgery. As we discussed, whatsoever patient is treated with the neoadjuvant approach, the pathologist after surgery must report how much the tumor regression is happened. The tumor regression, if it is we not able to show any tumor in the post-op specimen, then it is the good. If no viable tumor, that is a surrogate marker, or it is a prognostic factor that patient will have
long-term survival without any local recurrence. And it is not only the patient who achieve the pathological CR, even the patient who receive less than pathological CR, they also have good local, good disease-free survival. So that's why any sort of regression by giving neoadjuvant chemoradiation therapy should be welcomed. The another use of chemoradiation in rectal cancer is non-operative management, where there is a group of scientists or group of doctors who get enthusiastic by the result of neoadjuvant chemoradiation, and they try to avoid surgery in those cases, especially in the selected cases where either patient is medically unfit for surgery or patient refuses for the surgery. In those cases, a watchful waiting is a way where we can avoid surgery in those cases. How we can do, we will discuss. The rationale behind the non-operative management is these are the two trial. The main surgeon who are involved in non-operative is surgeon hypergamma approach, where she found she treated about 72 patients with the neoadjuvant approach, and she found about 100% 100% long-term control, especially if in the patient who achieved the good clinical response, and very low tumor growth, regrowth about in only 21/4 of cases, and that cases also very well managed by the salvage surgery. And the another trial, which is the OPERA trial, that has shown that have experimented whether adding chemotherapy before chemoradiation or after chemoradiation is which sequence is better. That has shown that adding chemotherapy after chemoradiation is associated with higher organ preservation rate as compared to pre-chemo radiation. So how we can do the these we can practice these approaches, non-operating management. It is the watchful waiting. Watchful waiting means we should be vigilant. It should not be कि और ओके रेडिएशन दे दिया उसके बाद फिर फॉलो अप करते रहेंगे. No, we should be vigilant. We should do regular MRI and biopsy, so that whenever there is a doubt कि there is a less response or there is a progression, immediately that patient subjected to be for surgery. This is the how over the time these are the trials are designed. The option of how we can do, the main motto of non-operating management is that to increase the pathological response. How we can increase pathological response? It by adding more and more chemotherapy. That is called total neoadjuvant approach, or by delaying delaying surgery after chemoradiation. That have shown that if we do surgery at 2 weeks, then the pathological CR may be at 25%. If we do surgery after adding more and more chemotherapy, then the pathological CR get increased. The another way of doing non-operative management in rectal cancer is adding brachytherapy. That where we can escalate dose of by pre-op radiation therapy. We can give 50 gray. If we want to escalate dose, then we require something unique therapy like brachytherapy, where we can escalate dose to particular
region of anal canal or anorectal region without, and as well as able to save some part of anal canal, so that there we can avoid the circumferential irradiation of anal canal and later on developing late anal structure. In these cases, the main problem is non-functioning anal sphincter. So we can avoid these non-functional anal sphincter by use of brachytherapy. Still, this is the evolving field. It has many issues because the risk there is a risk of progression during waiting time. There is many histology which are radio resistant. Then a close watch is required, and patient if patient is not compliant for these things to be to understand, then it may be disastrous also. So that's why till date we should wait for to practice these non-operating management. We wait for more and more trials. As the previous chairperson is asking, how we choose short course versus long course radiation therapy. These are the designs by ESMO trial, how we choose. But in a simple word, the both short course and long course radiation therapy is effective in how is equally effective. How we choose it is the patient selection. If we want the down staging, it is in simple word, if we require down staging or tumor located toward the lower rectum, it is better to give long course radiation therapy, because we require some regression, some extra margin for the surgery. And if we in the cases where we don't require down staging, in those cases we can practice short course radiation, can practice long course radiation. Both are equally effective. It is the institutional practice which we have the institution to decide. The another group of cancer where the chemo radiation is effective it is associated with very high local control, about 90% in T1, T2 tumor and about 70% in T3 tumor. Canal, the 100% patient is going to land up with the colostomy. By this approach, we only 13% patient require salvage surgery or colostomy. As the anal canal, every patient is required chemoradiation. There is no sub-staging where we, in which cases we can treat these patients with the radiation therapy alone, or where we can treat this patient can be subjected to surgery alone. That are the debatable point. But these are the only one case scenario where we can do the de-escalation therapy, that is the T1 tumor less than 2 centimeter, where we can treat these cases with the RT alone or surgery alone. But it to be mentioned to the patient, because as per guidelines, no trial is designed for that. These are based on the few prospective studies only. Or the bulky disease where we require escalation strategy, where we add new adjuvant chemotherapy, especially bulky primary or bulky nodal disease. The radiation therapy in anal cancer is about 40, dose is about 45 to 64 gray. The dose is debatable. Most of trial is it depend upon the size of tumor. If it is early stage, then we can give 50 to 54 gray. If it is a bulky tumor, then we can give up to 60 gray beyond. But the escalated dose is still to be proved in the randomized trials. But as a practice, we able to see escalated dose is associated with higher local control, but also as well as at high
complication rate. The chemotherapy which is used with anal canal is the 5-FU the gold standard is mitomycin based chemotherapy, which may be added with 5-FU or capecitabine or cisplatin. And what is the absolute benefit of adding chemotherapy over the radiation therapy? It is around 12.5% reduction in mortality, and it associated with 18% higher local control. These are the trials which are designed in anal cancer. Red are the surgical trial, blue are the radiation related trials, and green are the chemotherapy trials. So in summary, the chemoradiation is an integral part of multidisciplinary care in case of rectal cancer. However, it is used as a sole therapy in anal canal carcinoma. Among rectal cancer, standard of care for the lower or mid rectal cancer up to 15 centimeter from anal verge below peritoneal reflection is pre-operative neoadjuvant radiation therapy, followed by surgery, followed by chemotherapy. The long course radiation therapy with capecitabine or 5-FU is recommended where multimodality found CRM at risk and lateral pelvic node present or down staging is desired for the sphincter preservation. Routine addition of oxaliplatin above 5-FU capecitabine is not recommended. Surgeries to improve pathological response or down staging may further improve disease-free survival, especially very advanced rectal cancer. With this, I would like to welcome question. Thank you.
At the outset, I'll congratulate the organizers for such an academic feast. Also congratulate Dr. Arun for such a wonderful and crisp lecture on the use of chemoradiation therapy in CA colorectal along with anal canal cancers. So now the house is open for the questions. If there's any question.
I think if no question, then we may proceed for the panel discussion. Thank you.
Thank you, sir, for this talk. Now I I request Dr. Sanjay Pandey, sir, to felicitate Dr. Deepti Sharma, ma'am. Moving ahead with the discussion on anocolorectal diseases, the next is a panel discussion on management of managing liver metastasis in colorectal cancer. The panelists are Dr. Yogesh Kumar Nishchal, which has an experience of 15 years in oncology and worked as a senior post MRCP. He did his highest specialist training in clinical oncology in UK, completed diploma in oncology from world-renowned and Pioneer Institute of Cancer Research, London, and complete FRCS in I request this sir on stage. Our next panelist is Dr. Rani Bansal, ma'am, Professor and Head of Pathology Department, Subharti Medical College. I request ma'am to be on stage. Next, I would like to call on stage Dr. Jaraj Bakri and has been a guide to many of today's surgeons. He has been trained at Gujarat Cancer and Research Institute, Ahmedabad, further at Memorial Sloan Kettering Cancer Institute, New York, and Kameda Hospital, Japan. Next, we have on panelist is Dr. Shishir Chauhan sir, who is an interventional radiologist at Healthcare and who specializes in using imaging guidance to perform minimal invasive procedure for diagnosing and treating conditions. Our last panelist is Dr. Arun Verma sir, Head of Department of Radio Oncology with
To chair this session, we may please have on stage Dr. Deepak Kumar Singla sir, Associate Professor, Department of Surgery at Kalpana Chawla Government Medical College, Karnal, with an experience of more than 10 years in teaching undergraduates and postgraduates, which includes MS and DNB residents with more than publication in 40 papers. To chair this session also, we may please again have on stage Dr. Umesh Singh, Assistant Professor, GS Medical College, Pikuhava. Sir is a Fellow of Minimal Access Surgery, also a Fellow of Indian Association of Gastrointestinal Endoscopic Surgeon, and has also done fellowship in Advanced Laparoscopic Surgery. Now to moderate this session, may we please call on stage Dr. Umang Mittal sir, Surgical Oncologist at Subharti Institute of Cancer Management and Research.
Good afternoon, everyone again. Seems everyone is tired of oncology. I think there are hardly any people left. So, well, we'll start with for whoever is interested. And why we are talking about colorectal liver metastasis and not, we normally don't talk about management of other liver metastasis is because colorectal cancer, we already heard that is the third most common cancer worldwide and second most common cancer of cancer death. The most important thing is 20-25% of patients have liver metastasis at diagnosis, and 50% of patients diagnosed will develop liver metastasis. Again, all these things look very similar to what other cancers would have. In fact, a pancreatic cancer or a stomach cancer would actually even have more number of liver metastasis. So why? Why actually are we here talking about it? The reason is that for most of the cancers still, if we don't do anything, the median survival is 6 to 9 months. Same for liver metastasis of colorectal cancer origin. If we do chemotherapy, the survival goes up to 14.5, 15, 16 months. If target therapy a little bit more. In stomach cancers again, or pancreatic cancers, we still achieve the same thing. What is different is that if we can resect colorectal liver metastasis, we have a 5-year survival ranging from 45 to 60%, with a 30 to 40 months median survival. Unheard of in any other liver metastasis. And that is why we really need to see how to treat these patients. These are not the last stage cancers. Liver metastasis does not mean the patient should be left home to die. It means that we need to try something more and try to give a good quality of life. There is almost 10 to 15% 10-year survival in these patients. So better survival in liver metastasis as compared to many cardiac diseases or renal diseases. So that is the reason why we are actually talking about it today. What also has happened in the case of colorectal liver metastasis is from the 90s, where we had a division among the medical oncologists and the surgeons, and we looked at it, and 10% are resectable. They used to come to the surgeon, he used to resect it. We had a very strict guidelines for surgery at that time, less than 3 metastases, 1 segment involved, no other thing, a lot of different things. And we often did not have a multidisciplinary system out there. A person going to a surgeon would maybe get a surgery, otherwise a chemotherapy. What has changed now? that today we have a multidisciplinary system approach. And even though, even today, with the improved resectability criteria that have come up, that even these patients can be operated, we still have non-resectable 60 to 70%. But we have lots of new techniques and new medicines, target therapies, which make almost 50% resectable. So a cancer, a metastatic cancer, with 90% people would not survive for more than a year or so. We have 50% of them surviving for 5 to 6 to 7 years, 8 years. So that is why we really need to understand that we need to chase these people properly and try to cure them. So I'll start my panel discussion. On the first thing is how to diagnose these metastases and decide whether we should be treating them. And I think, like any other cancer, the characterization and staging is important, because only on that basis we will decide as to should we go ahead with treatment. And the first thing comes is imaging, because until we have the imaging, we'll actually not know how to proceed, whether we should try any aggressive treatment in this patient or not. So my first question is to Dr. Shishir. Dr. Shishir, what are the imaging modalities which, in a suspected case of colorectal disease, we should go ahead with?
So the first modality that we usually order is an ultrasound.
Ultrasound.
It's a non-invasive, procedure, very cost-effective imaging modality, which can give us an idea about the location, the size of the lesion, and like what is the nature of the lesion.
Okay, so like this is a patient where an ultrasound shows a liver metastasis.
Yes, sir.
So what are the findings which can differentiate that this could be a METS versus a cyst or a benign condition?
So the lesion will have a hypoechoic or a target lesion appearance. Cyst will have an anechoic appearance with a posterior acoustic enhancement, which is not seen in a metastatic lesion.
Okay. What is the role of contrast in ultrasound? I mean, recently people are coming up with
Yes, sir.
contrast
Yes, sir.
ultrasound can
So the,
actually give a better.
contrast ultrasound has a recent modality has come up. So it has as far as diagnostic purpose is concerned. So we give air bubbles as a contrast agent, and there is enhancement seen in metastatic lesions. In a simple cystic lesion, will not see that enhancement, sir.
Fine. So even ultrasound can actually.
Absolutely, sir.
But once we feel it is metastatic,
Yes, sir.
what is the next test that we normally should advise as a clinician?
So the next imaging modality I would go for is a contrast enhanced CT scan, a triple
Okay.
phase CT scan of the abdomen.
Okay. And how is it superior to the ultrasound that we have done?
Sir, first thing is that the number of lesions can be more accurately seen on a CT. Second, the enhancement pattern of the lesion, if it is enhancing on the arterial phase, with the washout patterns can be seen better on CT. Then the location of the lesions can be better seen on a contrast enhanced. And plus, sir, the primary lesion, to look for a primary, the exact site and location of the primary from where it is arising can be seen on a CT.
And I would believe that in the patient, a future liver remnant could also
Yes,
be a
sir.
better.
Absolutely, sir. Absolutely, sir.
Is there any role of an MRI in the management of colorectal cancer?
So contrast enhanced MRI as far as the volumetric analysis is concerned. So especially when we come to FLR, future liver remnant. So the volume of FLR can be more accurately assessed on MRI as compared to CT.
Okay. Any other reason, Dr. Jalak, that you would go for an MRI in a patient who already has multiple liver metastasis, or you feel that there is a ifs and buts about surgery in that scenario?
Well, I would like to go for MRI only in cases where you see we have abnormal uptake in on CT, or even there's something sometimes when we do a PET CT scan, we get a abnormal uptake on PET, but CT findings do not show it. So then you need an MRI to define whether this is some lesion or not.
Fine. So basically, if there is confusion, so what do you see on? Yeah.
So basically, FRA is used in situations where you
scan has got role in those. But to assess for liver particularly, I agree MRI is probably the best one we have to look into
So,
that.
Dr. Judge, when would you go for a PET CT scan?
As of the practice we do follow nowadays, that we are doing PET nearly in every case. It's not that we're selective about doing a PET, but yet there are guidelines which do differ from that. So the PET should be done in a case where you have a nodal, you can say, extent of the disease, and to know whether those nodes are taking up or not. That will help you in going in for.
Would Dr. Rani's report make a difference in some scenarios where you would not ask for a PET CT scan? The pathology, the type of pathology. Dr. Rudra, any pathology where PET CT scan would not be useful? No, I think a signet mucinous pathology is often not taken up on a PET CT scan. So if a signet mucinous pathology, you might actually, a good CT scan of the chest and a bone scan might give you a better option. That is the reason.
You always find surprises on signet rings. Yes, that's right. That's right.
So what the recommendations are that a liver MRI, a CT scan is the standard. That is no doubt about that. MRI is basically to characterize non-typical liver lesions on CT scan, as Dr. Jalaj and all the people have said. And when the liver metastasis seem resectable potentially, and he has to make sure that whether he actually can do that. So I'm sure at that time he would ask for that. He already said. And a PET CT scan, as they've all said, is one indication would be in a liver metastasis where things are fine. I mean, not in terms of liver metastasis, when a patient treated where the tumor markers are rising. So in that scenario, you would actually go for a PET CT scan. Or again, where extensive treatment is contemplated and you want to be sure that you are doing the right thing. I mean, you're planning a liver resection. And I think I would like to know that there are no extraskeletal meds, and I think a PET CT scan would be a better option for me in that scenario.
Mandatory. It also help in differentiating oligometastatic scenario versus polymetastatic.
No. See, the
Sometimes
fact
we
is,
may able to see the
Dr.
lung
Arun,
mets associated
Dr. Arun,
also.
the protocol is we get a contrast CT of the thorax and abdomen and the pelvis in all the cases. So once it shows that it is a very limited disease, a PET CT scan might not give benefit. If there are SOLs in the liver, then you might have small lesions which are not visible on that, and that is a scenario where a PET CT scan. So that is international guideline. This is not my guideline. This is the ESMO and the we do things differently in India because I mean so many reasons. In breast cancer, actually speaking, देखा जाए तो there is no evidence of getting a PET CT scan done in early breast cancers, but we do it. So we can always prove why we are doing it. But as far as the guidelines are concerned, it is not to be done in every case. That is what I meant. Absolutely. So we should, today we're talking evidence-based medicine. What we do sometimes is different from what. Absolutely. Instead of biopsy, they have a PET scan, and then there's a treat on that. So, So I'll come back to Dr. Rani, because once we have this history that the patient is having something, we get a CT scan done, and of course we know there's a lesion. We see liver mets also. We see a lesion in the colon also, and there's nothing else. So my question would be, ma'am, what type of specimen would you be comfortable, an FNAC or a biopsy? Because the patient already has two places. So what would you ask?
Actually, thinking about the present scenario, we would prefer the biopsy.
Okay,
But
over an FNAC.
yes, if it is not possible or due to any reason, even FNAC, guided FNAC would suffice, or this thing, whatever requirement is there, because we can go for cell block
But
preparation.
preferably a biopsy.
Preferably biopsy.
My question second is, since this patient has presented, this is a synchronous cancer, presented primarily with both, should we go for biopsy from the primary or the secondary? Because the fact is that from the secondary, a simple ultrasound guided Pukut biopsy is feasible. On the other hand, primary would require a colonoscopy and things like that. We already know the patient is metastatic, and the patient has a beautiful virtual colonoscope, which has shown me that there is no polyp anywhere. He's got it from the best place. So now the biopsy should be from which area, from the primary or the secondary? The patient is more comfortable with the secondary, of course.
So you are asking me
Yes.
about this question? Actually, I feel whatever knowledge I have regarding these molecular expressions, we should go for metastatic lesion biopsy, preferably, because there is a change in molecular scenario sometimes. So you can tell me this.
What about Dr.
If you want to add.
Jalaj? Because this patient has come to you and you're thinking it has 4 or 5 meds, I can operate this patient also. You'd want to go for a biopsy from the liver or from the primary? From the liver. Well, I also thought so. But while going through the whole studies, what I found was there's a 15% chance of seeding from the needle side in colorectal cancers. So ideally, this is the ESMO guidelines, and you have to do it. If you can do an ultrasound guide one, then it's fine. But avoid doing a true cut biopsy. If at all FNAC cell block, still okay. But avoid it if you can do it. If there's no other options, fine. But that is what I was surprised was. I also thought that in all cases you can do it from the thing. But here, if you're planning a surgery, then there's 14%. Yes, curative. I'm talking about NED. Yes, this is what I'm saying. We're talking about where we're planning a surgery of that area. So
I think that things we have been talking from ages.
no, but in this, yes, 14 to 20%.
I have yet to see
in
it.
colorectal, 14 to 20%. Yeah, but colorectal, specifically colorectal.
To support your point, I can add one more thing, because this is circulating tumor cells. Studies also show after this ablation of metastatic deposit, circulating tumor cells, they increase a lot. So that point, like you say, this is seedling and all those things, could be related to that.
Okay, what is the role of liquid biopsy? You had alluded to liquid biopsy in your lecture. So what is the role of liquid biopsy in such a scenario? The patient has commissural carcinoma with multiple liver mets.
Yeah, whatever I showed, that there's a more important role in metastatic cases.
No, so in this patient, should we go for liquid biopsy of the tissue per se?
Biopsy.
Biopsy.
Because we need to have much more spectrum.
Well, I would just it is in the evolution, and I think the final judgment is still out whether it can replace the biopsy completely. But just in scenarios where, suppose it's a metachronous cancer at a place where it is you're doubting it's a cancer or not, and this is very close to a main vessel, you can't do a biopsy. In that scenario, maybe a liquid biopsy, or you have a small lung mets. So there is an indication for this liquid biopsy. Liquid biopsy is basically from blood. As Madam said, we take out the CTCs, and then the DNA and RNA testing is done on that, and we get the whole tumor markers, molecular profiling done. But still, in such a scenario, it is not the primary thing. Also, I just want to add something. Yesterday I got a report from a pathologist, and she said liquid biopsy. Now, there was no markers, nothing. So doing a cell block on FNAC is not a liquid biopsy. So that was basically a cell block which had been reported as a liquid biopsy by the pathologist. So I think that is something we need to be careful of, that sometimes in the private sector we get that report and that is not a liquid biopsy. So I just added to that. So Dr. Mani, are there any tumor markers that you would want your clinician to send to you? Any tumor markers that you feel you should?
Yeah, I have already discussed in quite detailed way, but in metastatic disease, first thing which I would prefer is the KRAS mutation.
No, it's tumor markers. I'm not talking about the molecular
CA.
markers. Serum CA.
Serum CA.
So, Dr. Yogesh, any CA would actually make you decide whether this patient came to you. You should be sending to him at all or not. Any level of CA would make you feel that this patient is having meds, and any level of CA would say, fine, I won't send this patient for Dr. Jalaz's opinion at all. Is there any such thing now?
I think if you go by text, they say anything above 30, you should try and go for systemic therapy first.
Yeah.
But obviously we'll have a discussion on that. because it's not only one factor which adds to what we're going to discuss later on, I think clinical risk scores and so forth. So there are a few other factors to consider, and they're not easy all the time. So CA is just one thing, and it may be normal, to be honest.
Absolutely. It may be normal. The patients where TCA is normal, but yes, a certain, above a certain level, maybe a upfront surgery might not be the best option. In that scenario, something else might be systemic therapy. Fine. Again, this is something we have covered in a lot of details before, the molecular markers. So in this metastatic scenario, what are the molecular markers that you feel that we should get done?
Actually, which will change the type of surgery also. That thinking about that, we choose markers, especially this KRAS mutation, then BRAF V600E mutation. They have very important role to play. Like what type of surgery, whether a simple anatomical resection or we have to go for radio frequency ablation. So that will be decided on this mutation basis, because, for example, KRAS, if it is showing positive result, then they say, I may be wrong, but out of literature, what I have gathered is like more than like beyond 6 mm, beyond anatomical margin, which you are observing, you should go beyond that while resection if mutation is present, because recurrence chances are much more in such cases. And moreover, this TP53 alone is, there are no conclusive results, but TP53 with KRAS carries synchronous effects, especially moreover this APC gene, and what I told this in the morning also, this mismatch repair genes, they also have a role, but depending upon this which side it is. Like KRAS is carries worse prognosis, especially on left side of colon. And same we have to decide about this MMR proteins also. And
So-
also HER2 is a new thing.
So basically, in all metastatic patients, you require today, as we had talked that time, all molecular markers need to be done for two purposes. One, to decide the treatment, and also to decide the prognosis. And I think we'll discuss in details about that. But yes, the fact is, all patients who come with metastasis, molecular markers are mandatory, period. There is no ifs and buts about it. And I think all the oncologists would agree to that. So, Dr. Yogesh, this question is to you. We say we have to do it. But exactly what is the role? I mean, what is the role of getting these markers? Then there's expensive test. I mean, even though we might talk to the company, everything, even then all this commute costs at least 25,000 rupees minimum in the most best center which gives you the maximum discount. So why do we want to get it done? A patient, why should we have it at all?
I mean, if you talk about particularly this case, then yes, there is a role to decide on the initial therapy, which has got important aspect of managing and getting a better benefit of PF. How patient is going to perform with different treatment options we have got, especially to try and get an R0 resection, and also for long-term survival. So I think these are vital. I would definitely consider in a limited liver mets, definitely.
Fine. So basically, as you said, it has to be done. And we'll again discuss about it. Just to give an idea, these are the pathways, the signaling pathways, which these molecular markers control. And you have a huge gamut of medicines now, which act against these markers. So you have a targeted therapy against these markers. So these patients, the purpose in metastatic disease is improving the quality of life and the quantity. And the quality of life can be better managed by avoiding chemotherapy. So if we have these markers, maybe we can just give target therapy, not chemotherapy, and the patient can have a good survival. So that is one reason why we want it. So the next part is, this patient has a liver limited disease. You get a PET scan done, everything. It's only in the liver now. So giving three scenarios, I'll first ask the residents. You can see all the three cases. They're visible to you. So in the first case, Dr. Shishir, the first case, what is the scenario? Then I'll ask the residents about what they think about it.
So it's a contrast enhanced CT showing a large single lesion involving the left lobe of liver. So there is no vascular invasion, but the lesion is having a subcapsular location.
Subcapsular. So the residents, what the GR3s out here, can I have one of the GR3s telling me what you would advise in such a patient? You won't advise anything, you will send to the consultant, fine. What do you see in the case, in the second case?
We can see multiple liver lesions. They are smaller in size, but they are spread.
Adjuvant chemotherapy, but chemotherapy would be required anyway.
Absolutely, yeah.
So chemotherapy is important.
Yes.
Dr. Jalaj, what is the role of surgery in the treatment options in CRL?
You see, they are both the options. New adjuvant chemotherapy, yes, we should go in, but a single subcapsular lesion, which can easily be resected, there's a chance that we can go at the same time do both things.
So there's a role of surgery.
Yeah.
Limited disease.
If easily resectable.
Dr. Arun, any role of radiation?
Yeah, we can, if there is a single lesion, we can irradiate by SBRT. Even in multiple lesion, if we able to spare functional liver, remnant of liver, then we can irradiate. The matter or point of debate is sequencing, where we want to, when we want to aid radiation therapy. That is point of debate.
So that is a very important concept that has changed. We don't say, "Mere paas aa gaya, main karunga." The whole thing is about a combination. Whole thing is the multidisciplinary team, and that decides that, because all of this will be required at some time. You might require chemo, surgery, ablation, TACE, TARE, HIE, APV, radiation, but it is more of a combination to give the best result to the patient, and that is, I think, how we use it. We'll talk about it. So if you look at the ESMO guidelines, it says the same thing, that everything is indicated, and you can have local ablation therapy, you can have intraarterial therapies, and the primary purpose is to improve the quality of life and appear for cure. So when you talk about resectability, and this is for Dr. Jalaj, what are the various factors? I'm not talking about liver-specific factors. I'm talking about the various factors which makes you decide that should I go for resection, at all think about resection, or just send it to Dr. Yogesh and say, fine, I mean, it has nothing to do with me. So what are those factors where you consider in resectability before when the patient comes to you?
The very first is the performance status of the patient, right? How the patient is he fit enough to undergo a simultaneous resection of your liver and the colon? And obviously next is how much the load of the disease. The load of the disease will decide multiple meds, single meds, then load of the primary, it's a large primary, or nodal involvement in the primary. That all things decide whether we are going for surgery right away. You see, if there is a load, disease which has a greater load, I would like to have a neoadjuvant chemotherapy and then go in for surgery. Small lesion with a small med and a fit patient, yes, I might think of a primary surgery in that case. Liver function, yes, obviously that comes in the fitness of the patient, that the cirrhotic, non-cirrhotic, if I'm resecting the liver, how much is left? That is what is the future.
Yeah, we're
remnant.
talking about it.
Yeah, right.
Very important.
And obviously, if there is some disease beyond the liver and beyond the tumor itself, yes, I would like to restrict my hand there. And one, give the patient to Yogesh and evaluate the response to the chemotherapy and then decide what to do.
Any extra hepatic disease, were you ready to burn your finger?
I would be ready to go in.
Yes. Or OMD, anything like an OMD where you would say, fine, I'll classify. OMD is oligometastatic disease. There's a big thing today we talk about. Oligometastatic disease should be treated as curative. So one is just the colorectal mets, which is M1A, and then is a M1B. So any extrahepatic disease where you would say that, fine, I'll still go ahead.
Not really. I would like to restrict. I don't think I would like to go a step ahead in anything.
Fine. So I think this is something is still in evolution. Yeah, but very small lung lesions, people are actually trying to go ahead, and sometimes they just go for ablation of the lung and surgery for that. Fine. So what are the resectability criterias concerning the lung? We talked about the whole gamut, but for the liver per se, what are the resectability criteria? Because they have changed a long way from the early 2000s to now.
Yeah.
At that time, you had less than 3, then less than 5 lesions, small segment, largest lesion, less than 5 centimeter. There was a rule of 5, which we used to talk about at that time.
The main thing which has changed is the non-anatomic resections. Now we are more into non-anatomic resections, multiple player metastasis. You can have multiple non-metastatic resections and many other things. I think what's written there, you can just read it. I can't.
See, basically now what they talk about is the only thing completely unresectable is burden of disease is greater than 70% of liver involved, or more than 6 segments, invasion of both the portal veins or all hepatic veins. That is the only completely unresectable thing. Anything before that, which was completely unresectable some time back, it is resected, but maybe technical, also achieving, even if you're not achieving R0, even then, sometimes you go ahead because the disease-free survival, the overall survival is still better if you're not doing that. And even if there's a small extrahepatic, some people go for that. So borderline, or sometimes in borderline, the future liver remnant is less. So even there are procedures to improve that. So the complete resectable would be if more than 20% is there, and I'll just ask you, I would answer that. So we talked about future liver remnant because that's a very important aspect of your liver surgery. So what is the meaning of future liver remnant? Because I think anyone who's interested in doing colorectal liver met surgery, he should understand about future liver remnant. So what is future liver remnant?
Oh, that's the liver which will remain to function later on. Once you resect the liver, so it should be 20 to 30% that should remain in the body so that it takes up the function.
So is the optimal FLR different in different people? In a normal liver?
Yes, but depending on whether the liver is functional, cirrhotic, non-cirrhotic, the cirrhotic liver will need more of remnant. Yes, that's all.
So basically, if it is a complete normal liver, just 20% is sufficient to go ahead with surgery. So even if you can remove 75% of liver, you can still go ahead with surgery. In a cirrhotic scenario, it has to be more than 40%. In a post-NACT patient, and I think I'll talk to Dr. Yogesh later on, these are different scenarios where even though there is no metastasis, but by the purpose of NACT, the liver damage has, that's very important. After chemotherapy, it is not 20%. That is something that we need to know. So I'll come back to Dr. Yogesh. Yogesh, what is the role of systemic therapy before surgery in a CRLM? In a patient with liver-limited metastasis, what is the role of systemic therapy before surgery?
So I think importantly, what we see on the scan is not always the case. So systemic therapy, as we all know, works everywhere except brain mostly. So I would say to also kill the microscopic disease elsewhere. That's very vital. And also to downsize the lesion, the primary and the liver metastasis.
So let's talk about in upfront operable. What is the indication in upfront operable? And downsizing would be a separate issue because in upfront operable lesion, he says, single lesion hai, jo pehle case 1 dekha tha. should or shouldn't I get a neoadjuvant chemotherapy?
Again, it depends on the size. So those factors, again, though not validated properly, those factors are there. Those are clinical, this is CRS scoring. This is the best what we have got at the moment. But I would say still by clinical apprehension, you can say, or clinical mind.
Except for very, very small lesion maybe, and where you've actually gone ahead because the primary was already actually symptomatic. You've opened the patient and you feel on ultrasound, interrupted ultrasound also you have done, and there's a small lesion, maybe that is the indication. Otherwise, in most of the patients, you will go for NACT. So when we talk about diagnosing tumors to make it operable, one option is chemotherapy. Fine. So what sort of chemotherapy you normally would prefer to give in liver limited mets?
So traditionally, 2 doublets have been used, but with more recent data, it has been seen that if the patients are fit, they can have triplets who have shown better response and better overall survival. So normally we use regime FOLFOX or FOLFIRI. FOLFOX is more preferable traditionally, and we add the third FOLFOXIRI. So irinotecan is also added to that. So FOLFOXIRI is the standard of treatment at the moment in such cases, and we then think about the molecular markers.
So this is my other question.
Yes.
When would you get target therapy into this?
So we do, obviously we request them upfront in such cases, and as soon as we have the result, we will add them. So we start.
Will add target therapy in all the cases?
In the left-sided ones, I would say more. Right-sided ones.
We're talking about the liver-limited metastasis.
Yes.
So my question would be, is in all patients where you give NACT?
Not with single lesion usually.
Yeah. So basically, target therapy is added more where you have to make it downsized. So if you're using it as a downsizing tool, you add a target therapy. If it is not required for downsizing, it's not. Is, and as for target therapy, what are the options that you would concern, left or right side? I mean, basically that is.
So for left-sided, we know if they are KRAS wild type, you would think of cetuximab or panitumumab. Those are the 2 options we
along with the chemotherapy.
Along with the chemotherapy. And for the right-sided ones, the obvious choice is bevacizumab.
Bevacizumab. So that is something we need to understand. And the right side, we normally don't use target therapy as the first option, or the molecular markers one. We use a VEGF inhibitor, which is a generalized target therapy, not a specific molecular marker therapy. Is there any role of intra-arterial therapy, Dr. Yogesh, in some scenarios?
I mean, there is limited role, I would say. It all depends on where the lesion is and what have you given before. I think these things come after the systemic therapy first, because majority of the time we don't have that expertise everywhere to go through this. And the evidence is limited in these scenarios, but they do have a role.
Fine. So so normally when you talk about after your chemotherapy is given and you still feel that there is some amount, big tumor, you still have not been able to, been trying to make it, trying to downsize it. And this is a hepatic artery intra-arterial therapy that is given. Normally, previously FUDR was given, but now you're adding oxaliplatin with that. And that is how we do it. I think Dr. Shishir is doing it. I mean, Meerut is blessed to have everything out here. We are doing these intra-arterial therapies today in Meerut itself. And, basically, we don't need the patient to go to anywhere. I'm Dr. Deepti, of course, must be seeing it in her scenario, but, we are thankful that we have people like Dr. Shishir and we are doing it out here. So, Dr. Shishir, this is, what do you see in this? I mean, this is one of the hepatic artery therapy patient where.
So we can see that there is a large liver met, and the first image shows a large liver metastasis. The second image is a digital subtraction angiography, DSA image. So we can see that there is a tumor blush. The second image, the dark area we can see on that second image is a tumor blush. And the third and the fourth image are immediately post TACE and 20 months after TACE, showing that there is stable disease after TACE.
Yeah, so this is something which it's something akin to an angiography, and this is a more selective marker. Then you have Deberry, which is an addition over the taste sort of thing, where you use beads. These are basically beads with irinotecan. That is a newer thing. And then CERT, Dr. Arun, this is something from your side. So what is CERT? What do you do in CERT?
Yeah, it is basically in these cases we use liquid radioactive material which is inserted with maybe peptide based or that get attached to the tumor cells.
So basically, this is a selective intra-arterial radiotherapy. And they use either yttrium-90 or holmium-166 in this. And in patients where, for some reason, TACE and this cannot be used, sometimes this has shown excellent results. So we're talking about a whole gamut of treatment that has changed. People would think it's some science fiction going on, but this is something which is being used in India itself. CERT right now not in merit, but remaining things are being used.
One
So-
moment, sir.
This question, yeah, sure.
What I just want to know, tell that if the lesion is hypovascular, then in such cases the arterial infusion therapy should not be
Should not be used. So that's a very important thing.
One should be very clear thing that one have to find whether the lesion is hypervascular or hypovascular.
Okay.
If it is hypervascular, yes, one should go for arterial therapy. One can go for TACE, TARE, or HAI. But if it is a hypovascular lesion, or if there is portal vein involvement, then one should not consider, because then the chances of cure is less. And if there is portal vein invasion, then the chances of decomposition will be very high.
So are you using CERT in your place at
So
LBS?
we are not using,
No,
we
it's
are mainly considering the TACE, DEP TACE, and for other purposes, radiation therapy.
So now we talked about that most of the patients require a neoadjuvant chemotherapy. And we already talked about that if we give neoadjuvant chemotherapy, the future liver remnant requirement increases. Why does it happen? And my question is to Dr. Rani. Ma'am, this is what is happening to the liver. What is this actually? What is happening to this?
Can't see. Yeah, this is some therapy-induced changes or?
Yeah, basically, I think Dr. Yogesh will be.
So, I mean, we all know that chemotherapy does affect various organs, including the liver itself. So 5-FU especially can affect the liver, oxaliplatin can affect the liver, and they do have changes which over the long-term period can affect the functionality, the synthetic function of the liver, and therefore you see those changes in the liver. And therefore we need more liver later on, more FLR, so that the patient can survive and do better.
What is the difference between the oxaliplatin-induced blue liver and the steatohepatitis of the irinotecan?
So, I mean, basically it's the functionality. So how it changes, you can see difference between what is compromised. On one side, you can see the irinotecan, and one side you can see the oxaliplatin. So it's the functionality of the liver, and the parenchymal changes also which happens. And
So-
the vascularity of the organ also changes.
Which is more damaging, oxaliplatin or the irinotecan?
Well, that's subjective, I would say.
No, I think it's a very clear indication.
Yes.
Basically, irinotecan is more damaging. That is why in NSAT we don't use irinotecan. We use capox or folfox. We don't use folfiri because with an irinotecan you will have steatohepatitis. Liver is badly damaged and you require FLR around 40%. On the other hand, oxaliplatin just causes a blue liver, which is sinusoidal, which is also reversible, and even 30% is sufficient. 30% of FLR is sufficient. So that is one of the things that.
So the problem becomes when there is, say, for example, 60% liver with mets,
Yeah.
and then you try to add the irinotecan. That's where the problem happens.
Absolutely. And then whether you give the chemotherapy less than 12 weeks or more than 12 weeks, I think that is why we want to operate as soon as possible. We don't want to give chemotherapy for more than 12 weeks. But if we give more than 12 weeks, the chances of liver damage are higher, and our results would be compromised. So this is a very fine tuning between the medical oncologist and the surgeon as to when and how to operate, because we want a removal also, but then we also want that our surgery should not be compromised. So that is something that is important. So what are the treatment options, Dr. Jalal? What are the surgical treatment options that we talk about in a patient we have decided now we are going for it with surgery?
How we are approaching the patient.
Yeah.
Whether we are doing, we can say, simultaneously?
He has given the chemotherapy, and the first option I would yes, that is the first thing we're talking about.
What do you either you do it simultaneously or do sequential? The sequential can be the liver first or the bowel first, right? Traditionally, what we do is the bowel first because I'm more comfortable with that, right? And do a liver at a second sitting. But doing the best thing, what I think is to do it simultaneously, right? So at the same one surgery and both the things are done. But that again has to be looked into for the patient fitness and other things, which will decide whether we're doing sequential or simultaneous.
So any indication where would you do a bowel first?
Pardon?
Where you will do a bowel first surgery? Any indication? Normally we do combined. After NSCT we normally do combined. So what in your views would be a way you do a bowel first?
If the response is not very good.
No, bowel first is normally actually done when the patient is very symptomatic, he is in obstruction.
No, the response in the liver.
Yeah. But normally the bowel first is performed only, as you said, combined is the more option, is normally performed when patient is symptomatic. And you know that right now you have to go ahead and operate, and obstruction has to be relieved.
That is an emergency sort of
Absolutely. So normally, as you said,
that is not my choice.
Yeah, but as you said, you prefer combined.
Yeah.
The only reason you would do bowel first is because you had to do it.
Yeah.
It was an emergency. You could not give chemotherapy in that scenario. So that is the indication. Otherwise, the reason I said is we should first give neoadjuvant chemotherapy and plan for a combined surgery. That is a better option. What about this type of surgery? Would you do a wedge, hepatectomy, a two-stage, or a orthotropic liver transplantation?
Wedge, where it's not actually wedge, where it's non-anatomical resections. Non-anatomical resections of the metastasis. That is what we do. And hepatectomies are not less and less done nowadays because you lose a lot of normal liver with that. It's only done in patients where multiple mets are there and you do a staged procedures in that. And
Two-stage hepatectomy.
Two-stage hepatectomy. And obviously liver transplantation is not my foray, but yes, if needed, that is again an option.
So liver transplant is coming up, though the indications are very, very, very limited. I don't think in India you allow liver transplant for liver mets of colorectal origin. But yes, in the West, there's some patients which are being offered with everything else is fine. And you have a liver which is cirrhotic, you can't operate. And then maybe, that scenario in the world can be done.
Actually, the results are quite good. So
Absolutely.
the data suggests 3 year, what I've seen, 3 year survival, more than 80%.
Absolutely. So where you can't do a limited resection and you feel that it would have been possible with a good future liver remnant, I think that is an indication of doing it. So, Dr. Jalaj, again, there is this patient who says, you feel you could have resected large liver mets on the right side, small liver mets on the left side. Now, the fact is, if you resect the whole thing, the patient will not have a liver, the left side is a small one, and you have had to remove few points on that also. So what do you do? Can you make it resectable? Now, this is a patient where before it was inoperable, unresectable. You have multiple liver mets on the segment 5, 6, 7, 8, and maybe 1 or 2 in the 1 or 2 or 3 or 4 on the periphery. So, and doing a right hepatectomy would not be possible. So,
yeah, there's something called hepatic augmentative procedures, right? So there are a few things that we can do to increase the volume of the liver selectively. And I think one of them is portal vein embolization, right? Once you embolize the portal vein to some segment, the other segment hypertrophies. So that's called hepatic augmentation. So these procedures can be done, they can be done during the procedure of the first procedure. We can ligate it, we can embolize it, or then there's some other procedure also which causes we can isolate a liver segment, ligate one side, wait for the other lobe to hypertrophy, and then go and resect. So that's what the procedures are.
yeah, so the basic purpose, the concept of the whole system was that the portal vein supplies the liver and hepatic artery supplies the metastasis. So that is the whole system of doing it. So what can happen is, now we want that the tumor side should shrink, and the one that has less tumor or no tumor but is small, that should hypertrophy. So if we can decrease the size of the tumor side of liver, which is actually the main at that time, and give time for the opposite side to hypertrophy, then we can do a hepatectomy, and the left lobe of the liver sometimes becomes so big that it suffices. So that is the basic concept how it came for. And as you see that, if I show, it's not visible here, but normally if you have just three areas, you can easily do a simple liver resection. But if you have mainly on the right side, and the left side would be very small, you do a portal vein embolization of the right side along with the neoadjuvant chemotherapy that is going on, the target therapy. After some time, the left side hypertrophies, and you can do a hepatectomy. In fact, if you have lesions on the left side also, but small ones, what you do is upfront you operate, you remove the mets on the left side. Otherwise, the increasing amount of blood on the left side will cause the mets also to increase. So you remove the mets on the left side, which are 2 or 3 in number, and then you do a portal vein embolization. Sometimes we add a hepatic vein embolization also, because that increases the hypertrophy of the left side. Sometimes you do ALPS, where what you do is you also divide the liver at that time. You are doing a portal vein embolization, but also dividing the liver after removing the mets on the left side. And believe me, you have a huge hypertrophy of the left side, and now you can easily do a hepatectomy. So you know, we are pushing the limits of surgery in colorectal liver mets, because the survival is excellent if we can remove the mets. So that is what talk about. What about the ablation procedure? What is the role of ablation procedure? I'll ask Dr. Shishir because he's doing it.
So we have 3 procedures that we do. The first one is RFA. So the selection criteria.
Before I start that, what is the method of doing the ablation procedure?
Sir, we have 2 ways. The one is USG guided, the other is CT or MRI guided. So
which is percutaneous one?
The percutaneous one, sir.
But we also have the laparoscopic or the open ones.
Sir, I have not done that.
I know.
But they are, people are doing
Yes.
intra-op. We have the facility to do it.
Yes. So what you would be sent, a patient would be inoperable but limited liver mets.
Yes, sir.
Or liver comorbidities. If that is there,
Absolutely,
it is percutaneous, because it has been seen that even if you are not removing everything, just if your each and every liver mets can be decreased in size, and the size was not too much, but the position was that, you can have a better quality of life and survival. But on the other hand, if you are actually operating the patient, doing breast dissections, there might be areas where resection is not possible, and there under ultrasound guidance again, even in open you are doing ultrasound guidance, you actually can do upfront both the resection and combined with the ablation, which is going on together. So now your next question, what are the methods of doing it?
So first is we can do RFA. RFA is radio frequency ablation. So I'll start with microwave.
Yeah.
So the basic thing is that in microwave and RFA, we are using thermal energy to cause coagulative necrosis of the tumor cells, and we have to make sure that we include at least 1 centimeter of the margin beyond the tumor size. So with the help of the thermal ablation, we are able to cause the death of the tumor cells. But the limitation of RFA is if we are having a vessel nearby, there is something called as a heat sink effect. So the heat is transferred to the vessel, causing a cooling effect. And a lot of researchers think that the recurrence occurs, the cause of recurrence in patients treated with RFA is because of this heat sink effect. So to prevent heat sink effect, nowadays microwave ablation has come up.
Yes.
It is much more effective than RFA.
And the second part is?
Another thing that I would like to add is even some new thing has come called as cryotherapy. So cryotherapy has come up. So instead of using thermal ablation, we are using a freezing effect. Yes. So it is the heat sink effect can be shunted. Like we can limit ourselves.
Yeah, but cryotherapy is still in evolution.
Yes,
I mean,
yes, sir.
basically for the colorectal meds,
Yes, sir.
we still prefer to use the TAs, the thermal ablation,
Absolutely,
microwave
sir.
ablation,
Absolutely, sir.
and the microfrequency ablation. And I think these are two. What can we see in this?
Sir, the first image shows microwave ablation. So we can see the electrode entering the liver lesion. The first image, it's little small. So we can see the second image, we can see the electrode into the tissue. And the third image shows post microwave ablation. We can see the necrosed tumor tissue. The second is a pictorial representation of how we do it. So there is a antenna which is inserted into the tumor with the help of USG or CT guidance, depending upon the site of the tumor. Then there are multiple prongs which come out after we withdraw the initial stellate, and each prong is like given a current, and it causes like a sphere formation in case of RFA, and like a cube or in formation in case of microwave. And then the third image we can see, first is the image shows the lesion, the second shows the electrode being placed into the lesion, and third is the most important thing. On when we're using USG guidance, these bubble formation, the gas formation, that is the end point for us. Okay, now the tumor ablation has occurred.
So these procedures are available out here in Meerut. I have done 2 open ultrasound guidance, and I think Dr. Shishir has done many more. And it's not so expensive in terms of the fact that if you have a liver mets which cannot actually, it's deep inside, the resection would entail a big hepatectomy. Then that scenario, you can actually use these RFAs and give a good quality of life and survival to the patient. So I think we should be more using these protocols. And very frankly, if you don't have it, the rental rate is 90,000 rupees for the machine which comes up. And so within the 1 lakh, 1.5 lakh, you can actually do a very good procedure, multiple RFAs. So I think that is something we should start doing when we talk about oncology. What about the other tools? And I think Dr. Arun alluded to this. What is the full form of SBRT?
Yes, full form of SBRT is the stereotactic body radiotherapy.
Yeah.
Basically, it is also a ablative technique. As we बचपन में जैसे कि हमने एक एक्सपेरिमेंट करते थे, कॉन्वेक्स लेंस लेके और पेपर को जलाते थे, फोकस करते थे. इट इज लाइक समव्हाट लाइक दैट कि वी फोकस्ड a very high energy to the tumor that give a equivalent to the ablation effect. So it is the advantage associated with this SBRT is that it is not a site dependent. We can do in any site. It is not vessel dependent like heat sink effect seen with the RFA. So it can be done in lesser, in 2 centimeter lesion, it can be done up to 7 centimeter lesion also.
And do we have it in our institute?
Yeah, we have this facilities in our institute. For this type of radiation therapy, we require motion management because liver is a motion moving structure. And we also having that motion management system also.
So that is something we can do it out here. Even if you can't get the RFA, SBRT is simply possible out here. So we should be trying to get more and more patients of that. So this is the patient where resectable disease was there. So what I meant was, it is not a question just surgeon. It is a combined effort in the resectable disease. We have given chemotherapy, we have resected whatever we can, try to improve the fusible remnant, and on table, if we find, or on the reports, we find that there are still areas where resection is not possible. We take the help of our ablative guys and our radiation oncologist to take care of that. So you can actually finish all the meds, some by surgery, some by ablation, and downsize them by chemotherapy. So we have to use all of them.
So patient selection becomes key.
Absolutely.
As for SBRT, the other benefit is it's non-invasive. So people who are fearful of needles, not wanting those procedures can,
Absolutely. So this is about patients who are resectable, who are curable. And there we have used all these scenarios with a whole gamut of various techniques, both chemotherapy, target therapy, techniques like portal vein embolization, hepatic vein embolization, ALTS, 2-stage hepatectomy, and so on and so forth, and adding all the ablation. But even now, most of the patients will have unresectable or incurable liver metastasis. Now, what to do in that? Because the fact is, this patient would still want to live a more comfortable life and as much longevity as possible. So my question again to Dr. Shishir and to Dr. Arun, is there a role of ablation or plus minus SBRT in patients who are incurable, unresectable, and should we do treatment of the liver in that scenario? My first question, Dr. Arun.
Yeah, we can aid SBRT if patient is having symptom and we know if this is going to, either patient is going to develop obstructive jaundice, it is near porta. In those cases, we should ablate because it will improve quality of life, even if that patient is resectable and having multiple liver lesions also. We think what are the lesions which are going to decrease his quality of life, and we should treat that lesion.
What about you, Dr. Shishir? What about ablation? Same. So even in unresectable diseases, there will be indications where local ablation can help the patient live a better quality of life, and his survival might not be prolonged, but his quality of life will definitely be better. But as I said, there are very selective cases, and you have to decide as to Dr. Deepti, in your scenario, which patient do you use in a incurable setting for SBRT?
So if the patient is having liver metastasis that is causing or in future is going to cause any obstruction, or there is any lymph node metastasis, large lymph nodes, which may lead to some obstructive symptoms or pain in the periaortic region. So these patients can be considered for radiation therapy. There is a paper by Yakashita et al. For SBRT in cholangiocarcinoma, intrahepatic cholangiocarcinoma. And as per that paper also, in about 75 to 80% of the patient, the morbidity and mortality is because of the liver failure. So if we can improve the liver functions by ablative procedures, maybe SBRT or microwave or RFA or a TASE, so we can at least have a good liver, so that patient can be considered for further chemotherapy. If the liver is not working, then we don't have any choice.
So often it is being used so that the patient can be given more systemic therapy and have a better quality of life. So now for systemic therapy, Dr. Yogesh, how do we proceed for the systemic therapy in this scenario? Patient is having unresectable and incurable disease. We know it will never come for surgery. We are very sure of that. We have seen him. He says, "Kuch bhi kar lo." I am not going to see him the next time. Nothing I need to do. Obstruction hoga to baat karna, stent dalwa dunga main, but otherwise nothing I am going to do. So how do you proceed in this?
So you're looking for palliative purpose here, or extending, prolonging a patient's life, and also trying to maintain the quality of life. So you look for patient fitness. You look for what treatment options we have got, and you take the best course considering the liver function, number of metastases, volume of disease, extrahepatic disease, and so forth. So I think treatment choice is the same, but I think patient selection is key in selecting those treatment so that they have a balanced equation in terms of getting response and maintaining quality of life and not prolonging the suffering and also maintaining the liver function.
And would there be more role of molecular markers, especially in this setting?
There is role. Again, you have to use judiciously for that. Definitely, we need the markers in this setting. Definitely.
Is there any role of molecular markers in deciding whether Dr. Jalla should go ahead with surgery in a borderline resectable CRLM?
I mean, there is role, but I think the evidence is not huge here. I would say this evidence is lacking, but people are coming with more and more, it's...
No, the reason I said it, in the duration of studying that, I realized that it is a very huge liver metastasis, which is just borderline resectable. If these patients are KRAS mutated or BRAF mutated, they do very badly, whether or not you give surgery or operate or not. So one of the indications of not going ahead with PVEs and HVEs is this scenario, that if you are KRS mutated or BRAF mutated, then there is maybe not any benefit of going for aggressive management of making it operable like PV. So that is one thing I wanted to just put in front of the house, that basically...
But those are in mutant cases. We are talking about wild type ones. Definitely in wild type there is role.
Wild type you should go ahead. I'm talking about mutated, KRAS mutated or fine. What is the difference in the right and left side colon disease treatment in such a scenario?
So we know that the right-sided don't do well with, even if they are KRAS wild type, they don't do well with the targeted therapies. So we have had that clinical experience. So we believe left-sided do well, and we should, majority actually come with left-sided ones. So we would like to give them, if they are KRAS wild type, then definitely we would like to give them that extra.
So in today's scenario, if patient comes here to us. What is the regime that you advise in the left side colon metastasis with multiple mets who is not amenable to surgery of the liver?
So if they are fit, you can start with Folfox and you can add based on the molecular testing.
This patient is wild type, I mean KRAS wild type.
So you can add panitumumab. Obviously, it's a costly drug, so you have to think about that. If you can't, then also you can also add the bevacizumab. They also show, I would say, equally good to panitumumab in some of the papers. But definitely, if the panitumumab is an option, then I would go with that.
Now, if it's a left side secret disease with the same sort of thing, KRAS wild type, what about this patient?
Right side, you mean to say?
Right side.
Right side, again, in clinical scenario, personally, I have seen they don't do well with the targeted therapies, even if it's wild type. So we normally go with bevacizumab on the right side.
So this is something, again, that I had mentioned before. On the right side, irrespective of your molecular markers, you should give chemotherapy with bevacizumab, which is a VEGF antibody. On the other hand, on the left side, if it is not, RAS is not mutated, then you should add a target therapy. Now, on the right side, there's something else that actually I think people are doing a lot now. What is that in terms of MSI patients?
Yes, I mean, if you do MMR or MSI, then you can add the immunotherapy to them. Actually, they do well. Those patients who have got high MSI or deficient MMR, whichever way you want to do.
On the right side, since target therapy doesn't work, and MSI should definitely be done, AMR should be done, and if it's deficient, rather than giving chemotherapy and that, the best option is giving immune therapy. You have pembrolizumab, nivolumab, which are PD-L1 inhibitors, and patients sometimes do very well. This is the first line treatment we're talking about. The first line, this is the ESMO guidelines, what he has talked about. But in the second line, I think everything is open. Everything is open. Even if it is right side, you still give target therapy if that was wild type and you have.
When no options, you try everything.
So in the second, third line, you have lots of other options. You keep on drug. Even anti-HER, the one that Madam mentioned, that for breast cancer we use trastuzumab. In third line, we actually even use that, even in the progressive disease. So there are a lot of options today, from simple chemotherapies to doublet, triplet, having target therapies against the EGFR, and now you have target therapies even for BRAF and RAS. I mean, you have specific target therapies which are for the mutated RAS and BRAF. You have the PD-L1 inhibitors available to us, and you have, of course, Avastin, and then you have things like regorafenib, which is a multi-kinase inhibitor. So you have lots of treatment which can be done, and this patient can remain comfortable for a much longer time. I think when you talked about 12 to 13, 14 months, I think what is the time now where we are not operating? What is the maximum that we can go ahead with?
So I think in good cases up till even 2.5 years, I would say.
2.5 years. Yeah. A patient with extensive liver mets, bony mets, everything going on, still a good 2.5 years of quality life, not on the bed. So I think we have to change our narcissistic view of stage 4 cancers, not just colon, all the cancers. Today, the medicines available have made them a chronic disease from a end of life disease. And these target therapies have made a difference. So how are our case treated? So now I'll come back to Dr. Jalaj. Dr. Case 1, what you would do. And I think neoadjuvant chemotherapy is given in all the patients, so that is fine.
Okay, then I think it should be avoided the resection of the liver when the colon, obviously, when the flame setting.
So I think simple surgery would be sufficient in that scenario. What about case 2? Because it has one lesion very close to the vessel.
Well, that I think further chemotherapy should be given.
No, chemotherapy has been given. What we did in this patient was we did surgery for the main lesion and an ablation of the other lesion. So this is a combined treatment that we're giving. It's not just one size fits all. So in the same patient, a resection for the bigger one and an RFA or MWA can be offered for the smaller one. This patient can be cured very well. And what about this patient? Bad liver, cirrhotic, multiple liver metastasis. I think you will send to Dr. Yogesh. And Dr. Yogesh is going to take over.
Take care
this scenario, and maybe if there's some area where, as he said, some jaundice is about to occur, then maybe Dr. Arun would like to give some SBRT or things like that.
In case 2 and case 3, there is a role of SBRT. Case 2 that.
No, why would you give SBRT if I'm operating this patient?
if not operable.
No,
then-
no. Case
yeah,
1 and case 2 are operable.
Yeah.
They are very well operable, apna. And let us again put into perspective, the best results are with the surgical resection. Second best results are with ablation. And third best with chemotherapy. So the quantity and the chance of local recurrences are least if you have a good margin, which is possible with a good pathological specimen. RFA, in spite of whatever they said, they have a slightly higher local recurrence rate, even though in many cases, the overall survival doesn't change, especially for small tumors, if they're there. Same with SBRT. But in terms of local recurrence, the best scenario is still surgery.
Sir, I would like to put it in a different way.
Yeah.
Surgery is the best, but with help of others.
Absolutely. I mean, we have to. So this is my last slide, and this is just to summarize that in patients with a colorectal liver metastasis, we have to decide whether this patient is eligible for no evidence of disease, or it is not possible to have no evidence of disease after treatment. Now, if it is possible to have no evidence of disease with treatment and low risk, you can go from upfront surgery or local regional therapy and followed that by adjuvant therapy, which is again a very small, minuscule proportion of cases. On the other hand, if it is slightly higher, though eligible, we will prefer to go for neoadjuvant chemotherapy, followed by surgery local regional, and followed up with a complete adjuvant therapy. On the other hand, if we're initially non-NED eligible, we try to translational therapy with target therapies with the other surgical options like PV and other procedures. And if it becomes NED eligible, then a surgery can be offered to the patient followed by adjuvant therapy. If it is still NED eligible, it goes back to our medical oncologist who keeps on trying and trying till either it becomes surgically acceptable or he goes up. So, either of that.
इसके आगे एक और चीज हो सकती है जो हमने डिस्कस नहीं की है कि इसके कीमोथेरेपी का इफेक्ट अच्छा हो तो गायब ही हो जाते हैं.
हाँ, of course, there are disappearing meds.
और तब सर्जन के लिए और डिफिकल्ट हो जाता है.
There is something called disappearing meds, but most of these patients have pathological residual disease. And so it is very important in this scenario to use maybe, if possible, put a fiducial clip beforehand. But again, using a CMRI in these scenarios and a lot of other things, this is the indication where we need to use them for scars.
One question based on that. So if you have got single metastasis and you have given chemo, you have done this, and it has almost disappeared on the scan. But would you consider doing surgery still?
Yes.
If you put the marker?
There is a 25% chance of pathological disease, even in a completely radiologically disappeared metastasis.
Exactly.
There's another school of thought कि अगर नहीं मिल रहा है, difficult है, तो छोड़ दो, वापस आएगा तब काटेंगे.
So, but उसमें chances होते हैं कि तब तक फैल भी सकता है अपना. So, I think I've taken enough time. Try to keep on time. Actually, Dr. Shang would be happy. I've saved at least 45 minutes. So, at the end, I would just like to say that colorectal liver metastasis is not a nihilistic thing for the patient. This is a patient who can be cured or at least have a good 5 to 10 year survival. You have 10 year survival of 10 to 15% in many patients if early colorectal liver mets. And it is a younger generation especially. Of course, we as doctors are still doing it, but the younger generation needs to understand that they are the ones who are going to see a lot of patients today. And the system that our generation doctors have, because that is what was there, that of stage 4, go home. We should avoid that. The treatment of cancer has undergone a completely transformed sea change. We have target therapies, we have methods to make these patients disease-free, and we should be at least aware of these things so that we can ask the patient to go to a right center to get that treatment done. And with that, I think I thank all my panelists. And if there's any question that the House wants to ask from our experts about anything, they are very senior experts doing everything that we have talked about out here. None of these things are something that they have not done it. From operating on PVs to TACE to SBRT, everything that we've talked about. This is not a discussion of something happening in the US and we are just talking about it. It's possible here in Meerut. So if there's anything that you need to ask from our experts, I think they'll be very happy to answer. I think...
So at the end of this session, I will thank all our esteemed faculty members for such a comprehensive talk over the topic. And I will also thank Dr. Umang for such a beautiful session. And I guess that's all. The house is open for questions. Anybody has got any doubt? That's all.
Thank you, everyone. I would now request Dr. Deepak Singla, sir, to kindly felicitate Dr. Umang Mittal, sir. Thank you, sir. I would now request Dr. Sanjay Pandey, sir, to kindly felicitate Dr. Rani Bansal, ma'am, and Dr. Yogesh Kumar Nichal, sir. Thank you, sir. I would now request Dr. M.K. Maheshwari, sir, to kindly felicitate Dr. Jalaj Bakshi, Dr. Shishir Chauhan, sir, Dr. Arun Verma, sir. Thank you, sir. I would now request Dr. Shashank Mishra, sir, to kindly felicitate Dr. Deepak Kumar Singla, sir. Thank you, everyone. Moving on to the next session, I would like to invite on stage Dr. Medhavi Tomar. Dr. Medhavi Tomar is a renowned minimal access surgeon and is currently the head of the Department of General and Minimal Access Surgery at Star Hospital and Laparoscopic Surgical Center, Meerut, and Metro Hospitals and Heart Institute, Meerut. Sir has had the privilege of serving at various elite institutes all over India. Sir has been proactive in academic activities and has presented many talks and lectures at various conferences. Sir has also played an integral role in organizing many workshops and CMEs himself. Sir is a lifetime member of ASI and is currently holding office as the Secretary of Meerut chapter of ASI. We would like to invite you on stage to chair the session, sir.
I would like to invite Dr. Vikas Singh, sir. I feel honored to call upon Dr. Vikas Singh, sir, for the session. Sir is a renowned minimal access surgeon. He is a professor in Department of General Surgery in RML Lucknow. He has published many articles in national and international journals. He has also started community awareness program for laparoscopy. He became ATLS course director and conducted ATLS provider course in various medical colleges and hospitals. We welcome you, sir.
Thank you all. And I would like to have thanks to Dr. Gyanendra and Dr. Shashank. Thank you for inviting me out here. And after an exhaustive, wonderful symposium by Dr. Umang and the whole of the panel, which we were trying to be engrossed, but yes, at times there were a couple of bouncers which are going up over the head. I would not say because the hypoglycemia is already setting in. So that is why. So with your permission, this is not about hardcore colorectal malignancies. This is what we aspire for as an undergraduate, as an intern, as initial days of the post-graduation, and obviously once we become the young faculty members. That is what I'm here for, role of minimal access surgery. So I would not be going into too deep. I'll be going in more something which you all can sustain that hypoglycemia and still the oxygen level is maintained. Yeah, this is off, sir. Standby mode. आपके दोनों रेड लाइट हो गई सर. Talking of colorectal, till the time they go in for this, आपके स्क्रीन सारे blackout हो गए सर. अरे स्क्रीन उनके नहीं है, ये केस हमारा नहीं है, उनका वाला है, वो चल रहा है सर. Okay. Lap surgery has been in India for the last more than 30 years now. Way back in 1991, 31st of May, Laparoscopy Day is being celebrated. And we have already completed or more than 30 years, rather to be exact, 32 years now. And we all know about minimal access surgery, or better known as laparoscopic surgery, and all wish to become laparoscopic term general surgeons. And we have seen that the gold standard treatment for cholecystectomy is laparoscopic cholecystectomy without any say. Has no contraindication. Only thing, your light is off, sir. But the way laparoscopic cholecystectomy or lap hernia have been taken up by all the surgeons all across the world, somehow laparoscopic colorectal surgery is yet to achieve that. My dear friend, Dr. Rudra Prasad Acharya was here. He did speak a lot many things, so he's not here to listen, but he made my job pretty clear that whenever we are talking of colorectal surgeries, that is one forte in which lap surgery can give you wonders. And that wonders, when we are talking of, इसी को घुमा के रख दूं क्या? हाँ? Because lap colorectal surgery also was first done in 1991, way back till when the time lap colis were being done. At that time, the first lap colorectal surgery was also done, which was more of a segmental resection. But still it did not pin up. The reason being, there are many reasons that why we say that. Jabki literature has proven it, that in England as in India, something around 60 to 80% of the colorectal surgeries are indicated to be done by lap. But still, we are not taking up all the indications, all the procedures which are, they are very much possible by laparoscopic surgery. But still, the takers are much less. Without ado, I would say that everybody knows about the advantages and disadvantages of lap surgery per se. So I will not go into those details, that shorter stay, lesser pain, lesser hospital stay, better preserved pulmonary function, especially in long period of colorectal surgeries as compared to others. Reduced post-operative adhesions and ileus both, means patient can eat quickly. And obviously far more, the most common thing, and that is the better cosmosis. There are disadvantages if we're talking of advantages. higher conversion rate to begin with. First and the foremost, longer operative times means you need to really have a patience and stamina and foot movements to sustain those 3 to 2 hour surgery if you're planning for lap surgery. Higher chances of iatrogenic injuries if you are planning for, because inside it is more of a Pandora's box that you are going in. In earlier times, it was as our panelists, they were discussing about the seedling or the metastatic in the seedling tract. Similar case was being observed in lap surgery, that was port site metastasis. But those things have been given away. And obviously the last, which is the most important as far as the Indian scenario is concerned, unclear cost effectiveness. And this unclear cost effectiveness, I wrote it down purposefully, the reason being, once you're in the initial part of your career, you are depending entirely on the devices, be it staplers, be it energy, or be it other things. But once your learning curve improves, you can do lot many intracorporeal suturing and you can bring down the cost. So if you are good enough in handling the tissues or your own equipments, it will be, the cost is going to be much lower as in comparison to others. There has to be reasons for less enthusiasm that we are going in for lap colorectal surgery, better known lap CRS if I say so, because we are talking of the whole Pandora's box, and Pandora's box means it is right from below the diaphragm right up to the rectum that we are looking at. So that means multifactorial or multi areas or more than one quadrants are involved. So at times you need to shift your monitors from the shoulders to the leg or maybe to the opposite side if you want to mobilize. So that is one that you may not have infrastructure or that kind of energy to stand over there. And it is a movable organ, if I say so, because it has a pedicled mesentery, and that mesentery can invite trouble because it has a lot of vasculatures written. What you see in the books, the arteries and the veins, they don't look like the one once we go inside, because it's a diseased abdomen. And once we go in a diseased abdomen, it is very difficult to identify those anatomical landmarks if you have not been thorough with it. And obviously the diversity of the operations. Lap chole was only one surgery, one quadrant, and one, we were supposed to prevent only hepatic artery and CBD. Rest all we can take care. Even the liver also we can burn it like anything. Put in a ball cautery, put in whatever you want to. But out here, you are supposed to be very precise if you're talking of lap colorectal surgery. And that's why that went on to the longer learning curves. So when I say learning curves, it is learning curve and not developmental curve. There is a small difference. Developmental means I start doing right hemicolectomy. I learn right hemicolectomy and I try to master right hemicolectomy. I can master right hemicolectomy, let's say in 5 to 7 cases. But the moment I will shift to left hemicolectomy, again I need to start scratch because the anatomy is different, handling might be different, the structures behind might be different that I'm going to deal with. That's why it's more of a developmental curve rather than only the learning curve. So, and the presence of the critical structures, because as the saying says, non primum nocere, that means do no further harm. We are there to remove, but not to remove the ureters which are sitting behind, or not to expose the gerotas fascia and move into the kidneys and the surrounding structures. There are whole list of indications, whatever you can think of both benign as well as malignant, as our elite panelists have already discussed about, that lap colorectal surgery is whole Pandora's box if you can control it. But I would say that rather than just going through the list, the polyps or the colorectal malignancies, as far as the malignant portion is concerned, whenever you are trying to begin with, there are certain basic steps which you have to master in. And those basic steps, these are the numbers that I have written. Localization of the lesion, that can be on the basis of clinical, radiological, and the diagnostic laparoscopy that you go in. So a detailed diagnostic laparoscopy will clinch the diagnosis, where is the lesion exactly. And things can change on the table if you have not worked before with your radiologist friend. Mobilization of the lesion. This will again depend on the detailed anatomical knowledge which you have of that particular patient, maybe with radiological support or maybe on table. And not only that, the vascular anatomy per se that we are talking of, that is very, very essential. And any aberrance, if there is, that if you know beforehand, you'll be better prepared to take care. Devascularization is one of the major causes of conversions, because what we are dealing with is a whole network of vessels. If we clip and ligate something wrong, our dissection area increases. Or maybe later on, if we don't identify it on the table, it is going to have a blowout in the future. That is number one. Number two, it causes a readout of the laparoscopic screen. So when we say laparoscopic screen, everything becomes red. Everything starts pouring in, and it is very difficult to clear. You may have a high definition xenon light source, but still if there is red inside, all the light is going to be absorbed by that red blood inside, and it's going to become dark. So that's why you need to be very careful while you are going in for devascularization. Preventive measures for the local recurrence. This was something which was not discussed in the elite panel, but that is something that if whenever we are going in for, we may utilize certain chemicals. Let's say just a betadine, sprinkle of the betadine, that may take care of the surrounding serosal, whatever spillage has been done because of our handling. Protection of the wound during the specimen retrieval, one of the most important parts, because in the initiation there may not be port site metastasis, but definitely there can be the wound protection which is required for two things. One, the contamination from the fecal, whatever is present out there, and two, from the port, means the met cells which might be there on the surface, that is the serosal surface. So for both the things we need to prevent, and that can be done by using a wound protector mechanical separators. And finally, restoring bowel continuity. And that bowel continuity, it will be, expertise level is going to be higher if you are going in for intracorporeal anastomosis. It might be, let's say, comparatively lower if you are using staplers, but you must know how to use correctly, how to fire them correctly, and how to manipulate them inside a small abdomen if the patient is a small one. So that will depend on what exactly are you dealing with. Operative instruments, what you require. I would, needless to say, it is not with 0 degree. It has to be done with 30 degree or at times even 45 if you are comfortable enough. That is high quality camera with obviously a xenon or a LED light source. Atraumatic bowel graspers, I wrote it down specifically 5 or 10 millimeters, because handling of a dilated bowel, handling of an inflammatory bowel, or in cases if there is query diverticulosis, when there is thinned out, if you handle with anything else, chances are that iatrogenic perforations are very common. So once you land up in iatrogenic perforation, your case changes. Then all the focus is on managing that perforation which you have accidentally done rather than the disease per se. Then energy devices, because here is the one where you really need to have a lot of things in that Bahubali portion, 3 things at one that you go in for. And that is the monopolar, which we all are good in, but we need something as harmonic, but harmonic has its own disadvantages if you ask, because it cannot take care of the mesenteric vessels all along. And that's why we need higher version, and that is the ligashore, or a good vessel sealer, which can take care of arteries per se up to 7 millimeters. So in that way, our operative time can go down drastically. And that's why we need good energy sources. And then to prevent any, means what do we say, damage surgeries, along with that, we may need ureteral stents. They may be optical or they may be non-optical. So if you are going in for complex or redo surgeries, you require them to be identified on the table itself, rather than thinking it later on that why this patient is not pouring urine or the drain is pouring urinary-like fluid. Patient positioning, it has to be either supine as we are comfortable in, but it is always preferable that we need to change places at times. That's why with a lithotomy positions on the stirrups and with widened leg, so that in case if required, you can switch your places all along. So that is what is required at most of the times. And at times we also require, because intracolic compartment to move in, we can require exaggerated renal work position. And with a steep tilt, so your patient is supposed to be bounded properly with the straps and take care that the shoulder pads are also on. These are just two images which I have put in. So this is the one which I am focusing on. It is always better to have in this particular position for the simple reason that these stirrups, because these patients, they usually require, let's say, more than 2-hour surgery. And already patient has a disease per se in which coagulability can be a problem. And that's why these stirrups will take care of the long-term surgery and the compression stockings per se, which we're supposed to give in. And we can always change our position and the assistant position both. And in cases if we are planning to go in for inspection and some manipulation of the anal region or the perineal region, this position is far better than only the supine. So supine to be taken up only in select certain cases, but this, if you practice with this, this is going to be for all the colorectal cases. 4 diagrams, A, B, C, D, and multiple things can be seen. Don't get confused by that. So I'm not going into details of this. What is important is, because colorectal surgeries means you have done a couple of cases. You have assisted, you have seen, you know how to work with the ergonomics of lap surgery. So once you know the ergonomics of lap surgery, you know something known as predictive anatomy, you know where the monitor is going to be, you put in your first port for the diagnostic lab, and rest of the ports are dependent on the basis of the target area to be defined. Let's not this target organ, it is the target area in which we are going to. So depending on that, our rest of the ports are going to be placed. The same things, ergonomics means we are looking forward at the triangulation, we are looking forward at the manipulation angle, and we are looking forward at the azimuth angle to speak of. And that's why the whole ergonomics does come into the play. But usually we place the first port above the umbilicus for the simple reason that gives a better visualization of liver, the upper surface of the liver, rather than going below it. That is one of the main reasons that we go in for the camera port above. Plus, whenever we are planning for putting in a stapler, we need to be away from the target organ so that we can manipulate our ergonomic, or we can manipulate the head of the stapler accordingly. That's why we need to be away from the target organ. Operative steps, I have written only 2. The reason being, safe access and creating a pneumoperitoneum is the first and the foremost, especially if you are going in for any kind of a bowel surgery. Because while going in, if you aaye the Hari Bhajan ko otan lage kapas, so if you try to go ahead, you might land up into more trouble. So that is 1. And 2 is, before planning to put in your knife or energy sources, go in for a detailed diagnostic laparoscopy. So even if you are good enough in doing open surgeries, at least go in for doing a detailed diagnostic laparoscopy in those cases. You will learn exactly what all areas to be seen, what all things to be noted down, how to do a bubble walk, how to go in for the supracolic and infracolic compartment, how to handle a heavy omentum per se, and how to see exactly where are the vessels. So once you learn that, in a few cases, maybe you will be ready with your rest of the armamentarium and take care of your next patient. Then again, you have multiple options depending on your capabilities, depending on your team exactly with which you have trained yourself. That whether you are going in for the most comfortable, that is the multi-port laparoscopic surgeries, because these patients, there is cosmesis, but what we are offering against is a midline big laparotomy. So with that, whether it is 4-port or 5-port or 6 ports, doesn't matter. What matters is whether are you able to handle things properly inside. Because if the things keep falling onto you, especially the omentum or the mesentery or the transverse colon, loaded transverse colon along with, then you may not be able to progress further. That will add on to the frustration, and maybe next case you will not take up. So what is more important is, as cricket is being taught, you need to learn about the stances. And once they teach, they don't teach with the ball, they teach without the ball, so that you learn the exact stances. And once you learn, then only the ball is given, and that too tied on a string. so that again you practice it with the string, and later on ball comes by a bowler, and that to somebody who doesn't ball properly, so that you are better prepared rather than somebody giving a ball and you are not wearing something what was required and you are bowled out. So next time you will always have a fear with that. In the initial part, even now what's being done, something known as hand-assisted laparoscopic surgery by HAL spot that we keep. And that I'll be showing in the next image. What is that HAL spot? And that is something which what everybody thought, and that is still amenable, that with the hand inside, because with the lap, if you are not good enough, tactile feedback is totally off. So that tactile feedback, that is only to be saying, not to be doing, because once you get into the field, you can feel even with those metallic instruments. So, but still, with the one hand inside, maybe you can palpate better. Maybe you can retract better, because the same incision will be utilized as a wound protector, as a specimen retrieval, and also for extracorporeal anastomosis if required. In case if you are not able to afford, or the patient is not able to afford the stapler cost, because each stapler cartridge is going to cost 10,000 rupees. So if you're using 30,000 straight away, which you may not be having, or the patient may not be affording. So it is always better to keep your skills, that is your extracorporeal suturing, through that port that you can take out. So that is hand assisted. And third is, once you are good enough, only certain cases can be done by single incision lap surgery also. This is the hand port that we are discussing. This is how it looks like. This is the part which goes in between the abdominal musculature. The inner part, the upper part, and this is the loose part through which we are moving in and out with our gloved hand. So once we move in and out, and it has a valve inside through which the air does not escape out. So it is one way. So air doesn't escape out, means the pneumoperitoneum is still intact, and still we are able to do a combination of laparoscopic surgery with the hand-assisted laparoscopic port. That is why the name goes in with this. Means you can see the camera which is there, it is insufflated and still one hand is inside. So you can add on to, let's say, to transition between open surgery to complete laparoscopic surgery, we can go in with a HAL spot. This is learning curve order, let me say learning curve steps. Each step that you can have the mastery of. Segmental resection was the first surgery of the lap colorectal which was being done in 1991. And that still, and let's say segmental resection, the commonest example if I give in is limited right hemicolectomy for ileocecal tuberculosis. Because ileocecal tuberculosis, you are not worried about which vessel are we going to clamp and at what place, whether medial to lateral or lateral to medial. So that's why, plus lot many patients of ileocecal tuberculosis might be there running around in the OPD with a lump which is not settling down, with features of so-called subacute intestinal obstruction or maybe visible peristalsis. If they are coming up even after taking ATT, they are not settling down, diagnostic lap and proceed. And maybe you can hand out your segmental resection, the first one in such cases. Second, the stoma formation. Again, malignant case, obstruction, emergency, whenever you are planning to go in for, either you go in for laparotomy, or if your time and the institute permits, post them in your routine OT, go in for a laparoscopy. You will do a diagnostic laparoscopy for the malignancy that you are looking at, and on top of that, you can just take out one segment of the bowel, make an incision and bring it out. So that is stoma formation, means choosing out which part of the bowel to be taken out can be done with the help of laparoscopy. That is how it is very helpful. Sigmoidectomy or anterior resection, again, this learning curve order is as per you are comfortable with handling 4 to 5 ports or your instruments, and having to handle those instrumentation by your learned team members, those who are developing over a period of time. Having those energy sources and the detailed anatomical knowledge about your case or that particular patient. Only then this learning curve is feasible. It's not that you can start from this, so we will be able to do this. Yes, you might be able to do this, but the oncological principles, in case if you are going in proctocolectomy or low anterior resections, that is supposed to be managed. And that's why there is always a set learning order that we always practice, so that once you know APR, rest of the things are going to be a kickball for you. So that is what is required in a gradual manner. There is reduction in the learning curve, and that's what I'm saying. Those are the stumbling blocks or the hurdles, if I say so, because they are the most which deter you from not becoming a good laparoscopic surgeon. And that is, if you don't understand the pathophysiology of the disease or of your particular patient, which is important, how the things are going to behave in during surgery and even the after surgery. That is what you are supposed to know. Knowledge of anatomy, I am being re-emphasizing, I should have made it bolder enough, but this is something which you cannot have any other excuse for this. Adequate experience in conventional surgeries, unless and until you know exactly what you are handling, because the tactile feedback diminishes down or goes down, so you need to have a good exposure in open or the conventional surgeries which you are going in. Adequate lap surgery principles, that is, you must know hand-eye coordination, you must know dissection techniques, you intracorporeal and extracorporeal suturings, and especially how to tackle your long length instruments going across the whole bowel length onto the opposite side. How to take care of vascular structures out there and to flip over just in bowel walk as we are trying to do. And the last but not the least, which the young fellows are more capable, is record your surgeries. Don't do anything without recording. As somebody was telling in Japan, Dr. Rudra, somebody was telling in Japan, you click a picture. If there is no picture, that means you have not done. Lies can be later. The same thing out here. You need to record your each and every procedure, so that in case, one, they are going to be learning for you. Two, let's say you can post yourself. Okay, this is what I did way back, 10 years back, I was this good. And over a period, these many surgeries I have done. So somebody who's aspiring to become, you can always give over those recordings and let them see. If you are giving it to your junior fellow or colleague, let them do, but have a recording, so that in case if you have gone out for a tea and if something happens, you can just rewind and see exactly what went wrong. So that's why you need to review and have a positive feedback. Let's say the critique of it, not critical analysis. Critique means the positive feedback. And the positive feedback means what good have you done and what could have been done better in this particular case. That is what we are looking at the learning scenario. So I would just end or conclude my lecture by just giving you some take-home points. Lap colorectal surgery is safe and oncologically equivalent to open surgery, as that was discussed in the panel as well. Many short-term and long-term benefits exist for lap surgery. Short-term we have talked about in regards to shorter hospital stay, lesser pain, lesser read of antibiotics, early return of bowel movements, early feeding, all those things. Long-term means patient is going to be more productive. And that is one of the, and plus patients' hospital visits are going to be less. The burden on your own unit is going to be less. That is a longer effects that let me talk of. Several variations in surgical approaches and techniques exist. No surgery has ever been said to be done only by a single method. That's why there are n number of surgeons doing in n number of ways. The only thing is basic principles must be maintained. And those techniques should be reproducible. So if your techniques are reproducible, yes, you can be one of the masters. The thing is, you need to master that particular technique. That is what is the first and the foremost principle. Be it medial to lateral, like in colorectal surgeries we tell, or lateral to medial dissections as we go in for the Turnbull technique as we do in colorectal malignancies. Several patient-specific factors can have impact on the outcome of lap CRS. So that's why it is always said, choose well, cut well, and get well. So you must choose your patients very wisely. That's why the amount of time which you are spending beforehand with the patient, with your radiologist friend, with your pathologist, will decide you to choose your patients well for a better outcome. And the last but not the least, the learning curve for the lap colorectal surgery is steep and often requires a strong foundation during surgical training. That's why when the big surgeries are being done in your respective institutes or colleges or unit, learn to stand behind the operating surgeon or be in that OT, so that at least you learn one thing, and that is persistence and perseverance, and increase your stamina to stand on both the feet and be attentive all through. That is first and the foremost things. If you talk about me, take home messages. Thank you all.
Thank you, Dr. Vikas, for this energetic delivery of a very important perspective on adoption of laparoscopic surgery in colorectal scenario. I have a few points to make. I agree fully with whatever you have said, but I think the initial resistance can be overcome only by initiatives by institutional players, where a good mentorship under maybe an outside faculty who is conversant with the techniques of colorectal surgery, hands-on training programs have to be arranged. Second thing, what I find is the main reason for this gap in adoption of laparoscopy in colorectal is that most of the times colorectal surgery is done in malignant patients. And unfortunately, we have had a very lively discussion on the rectal malignancies just before this talk. But unfortunately, most of our oncological surgeons have not been trained in laparoscopic surgery. And I think the way to go ahead is to have a senior laparoscopic person along with you and start venturing into this field. You have to come out of your zone of comfort, and then only the resistance will go. It took 10 years for us to overcome the resistance in laparoscopic cholecystectomy. But now every patient comes and just asks once, "Saab durbin se karoge na?" That is something we want to achieve in any other sphere. It has been proven beyond doubt that the same oncological principles which are honored in open surgery can be honored in laparoscopic surgery. The outcomes are similar as far as the oncological clearance is concerned. Rather, I particularly find that the lymph node yield is still better in laparoscopic surgery.
Definitely, sir.
With that, I would like the House to put up any questions to our learned speaker, Dr. Vikas. Any questions from the audience, please? I hope everybody has.
That is another stumbling block.
Yeah,
Because
I
nobody
hope
asked the questions.
either you have understood everything or you have not
That's
understood
what I'm saying,
anything.
sir. You were asking all the resistance. This is the stumbling block. I said, stand behind the surgeon in the same OT for that much hours, because you are doing work in the wards. You are preparing the patients, but standing and seeing that perseverance of the surgeon to take care of those cases, to have a hit with your anesthetist fellow colleagues, and to taper them down. This has to be done. To convert, patient is having this, but your persistence is the key. So you must know about your patient well. Once you know about your patient well and your anesthetist well, you can definitely do wonders. Know exactly what do they want after the OT or before the OT. Provide them with those things. Like I saw LSD was being served just before the session. LSD means life-saving drink was being offered. Some cold drinks were being offered to the residents behind. So that LSD was being given. So whatever is required, that should be given, but that persistence must be there. If you don't start this now, you will not gain anywhere. Let it not be only of the oncologists, because lab training is more so in general surgery, not over there. You agree with that, sir? And that's why foundation is out here. So if your foundation is wrong, you cannot do wonders out there. You can do wonders maybe theoretically, but practically speaking, you would be on the lower train.
That's why I've talked about the collaboration between the oncosurgeons and the laparoscopic surgeons.
So,
and obviously, the greatest asset for a surgeon is patience and perseverance. You have to be patient. It may take 2 hours more than your routine persist with it. Slowly your curve will come down. You will have less time. Initially, when I started laparoscopic cholecystectomies in 1994, my first cholecystectomy took me 2.5 hours. But now I do 3 per hour. So that's it comes naturally. You are a toddler to begin with, then you start standing up on your feet, and then you start running. So that's true with every procedure which you adopt. The more hours you have spent behind the camera, the more tactile feel you have with your instruments is ultimately going to reduce your unnecessary movements. The only difference between an experienced surgeon and a beginner is useless movements. On an average, a surgeon who is less than 5 years in experience, maybe in open surgery or even laparoscopic surgery, the productive movements are just 20 minutes per hour. Whereas a surgeon who's been operating for 15 years plus, the wasted movements are only 10 minutes per hour. That means 50 minutes are productive movements. So that is the difference in speed, nothing more than that. You don't rush through surgery. The
Definitely.
only thing is your movements become more meaningful.
That's
that
what the
takes time.
positive feedback is. Once you record your surgeries, you see exactly that your camera, your instruments have been idling for more than 5 to 7 minutes in various frames. And once you decide what went wrong, you will think that because our other instruments were not ready, that's why we were idling inside. And that is the reason that 3.5 hour surgeries can be given into as videos of, let's say, 15 to 20 minutes. Only because we know that salient steps were being done, but maybe idling times was much more. So over a period of time, you reduce your idling time, and your each minute, each stroke should be more of a productive, as sir said.
Thank you, Dr. Vikas, once again.
Thank you, sir.
I think we should close this session. Thank you.
Thank you, sir.
Thank you, sir, for the talk. Now I request Medhavi Tomar, sir, to facilitate Dr. Vikas Singh, sir.
May we please request on stage Dr. Madhubala ma'am to please facilitate Dr. Medhavi Tomar sir. It is to request you to all the chairpersons, faculty members, delegates and colleagues to please proceed towards the lunch, and we'll resume the sessions after 20 minutes. Thank you. anorectal anomaly. To chair the session, may we please call on stage Dr. Gaurav Gupta, sir, Professor, Head of Department, Pediatric Surgery at LLRM Meerut. He is a member of Asian Association of Pediatric Surgery and Indian Red Cross Society. His field of interest is neonatal emergencies, anolectal malformations, pediatric urosurgery, pediatric laparoscopic surgeries. Next, we would like to invite on stage Dr. G.K. Sharma, sir, General Surgeon, Meerut, to speak on anorectal anomalies.
The speaker on anorectal anomalies, may we please invite Dr. Mohit Kumar Mathur, sir. He is currently working in GIMS, Greater Noida. He is a member of Indian Association of Pediatric Surgery and also the member of Pediatric Endoscopic Surgeons of India. He has published many papers in the reputed international and Indian journals.
Good afternoon, everyone. First, I would like to thank our organizing committee to invite in this academic feast on this colorectal diseases. But my topic is somehow different because it is not a disease. My topic is on absence of this colorectal and anal organs. And as Vikas sir said that prevalence, there is a dominance of hypoglycemia, but now hypoglycemia is over, but the sleep waves are more dominant after lunch. Coming on to my topic, that is anorectal malformation. And I would covered most I will cover all this topic in this from introduction to management, but I will not cover that pouch colon and cloaca. And this topic or this talk is more beneficial for residents. And in your in a late night in an emergency or surgical emergency, you will, or from a pediatric department, you got a call that, sir, there is a neonate which presented with the abdominal distension and not passing stool or meconium. So when we see these types of cases, what you will find is that there is a absent anal openings. But the catch is that these are all different type of anomalies. So that might be a mild variety of that or might be a complicated ARM. So might be one of the patient get a single stage surgery or some get a multiple stage surgery. So first we have to understand what is anorectal malformations. Anorectal malformation is a wide spectrum of disease which involves both male and female babies, and that includes involves the anus, rectum, and genitourinary system. And that can vary, the defects can vary from mild anomalies to the complex anomalies like cloacal malformations. And all this, the one thing is common, that there is absence of anal opening, and this type of patients initially noted by the failure to pass meconium. First, we go through the history. In 1710, the litter suggested performing a inguinal colostomy for imperforated anus. In 1787, Bell suggested using a midline perineal incision to find the bowel. In 1826, Diefenbach described anal transposition. Then in 1835, Amusat did mobilization of the bowel through a perineal incision with suturing of it to the skin, and this technique gained rapid acceptance. In 1930, Wenger-Steen and Rice described the invertogram X-ray that was most popular at that time. And in 1948 to 49, single-stage abdominoperineal procedure became widely used for anorectal malformations. In 1961, Douglas F. Stephen emphasized preservation of the puborectalis muscle. which was a part of the levator ani muscle group, and devised the sacroperineal anoplasty surgeries. And that time it was a taboo not to touch the puborectalis muscle. But in 1982, Alberto Pena is a renowned pediatric surgeon which is still alive and practicing in the US, published a description of a new technique of correction, that is PSRP, posterior sagittal anorectoplasty, and he divided all the muscle, including the puborectalis muscle or sling, which was once considered as a taboo at the time, and resutured it again. There is a lots of Indian contribution in case of anorectal malformation. I want to mention of their names. One is Dr. S.K. Chatterjee, who wrote exhaustive textbook on anorectal malformation, perineal canal, and perineal groove. Then Dr. T. Doraijajan, who described middle rectal atresia, which is prevalent in Madurai. And Dr. A. Vaklu, he worked on pouch colon, which is highly prevalent in north part of the India. And Dr. K.L.N. Rao from PGI Chandigarh, he devised another X-ray, that is prone table cross position X-ray in lieu of invertogram. So coming over to the incidence, the incidence is 1 in 5,000 live birth. That is not very uncommon. You can find out in your one day in your residency. Definitely you find 5 to 6 cases. And slight male preponderance is there. Birth order and maternal ages is of not significant. And the 26% of IRM are high lesion, 10.7% are intermediate, and 57.2% are low lesion. That means low lesion are more common. And high anomalies are more common in male child than female, and low anomalies are more common in female child. And in males, rectourethral fistula is commonest lesion in the male child, and while anovestibular fistula is common in female child. Coming over to the etiology, etiology is still unknown for anorectal malformation, but good antenatal care, supplementation of protein, folic acid, iron offer protection against this disease. So it's mean that it is more common in low socioeconomic strata group. There is a slight preponderance for male on the whole, so that hence X-linked, sex-linked inheritance is postulated. Some environmental factor are also associated with anorectal malformations, that is use of adriamycin, thalidomide, folic acid inhibitors, and retinoic acids. And some antenatal infections like cytomegalovirus virus and toxoplasmosis is also associated with the risk factor for the anorectal malformations. Embryology, that is a very important part. Multiple theories have been given, but most recommended and theory is that it is due to the imperfect fusion of the post-allantoic gut with proctodium. And second one is that leads to the imperforated anus. And the second theory is the theory of septation of the cloaca, the septation, that is urorectal septum. So you will find in your textbook that that complicated diagram, but you don't understand what is this, all these things. So I just make a simplified it. At the 4 to 8 weeks, that embryo is in a disc form. That is the dorsal form is called as embryogenic disc, and the ventral portion is formed by the that is covered layered by the endodermal layer, that is yolk sac. That red is yolk sac, that is the endodermal layer, and white is ectodermal layer, that is embryonic disc. Then there is a folding of that embryo. So this is the head end, the head fold. Then that posterior, that is the tail fold, and two lateral folds. So it's a think like a three-dimensional picture, and there is an invagination of that yolk sac inside that, and it become like this. So yolk sac or endodermal inside and ectodermal layer outside. Then anterior part is from the foregut, the middle part forms the midgut, and the posterior tail end form the hindgut. Now coming over to this picture, it is the hindgut. Hindgut forms the most of the colon, transverse colon, descending colon, but that distal most portion become dilated, and this forms the cloaca. This is cloaca, called as distal dilated form of hindgut is called as the cloaca, and there is a for diverticulum, allantoic diverticulum formation is there. So above this diverticulum is the primitive gut, and below is the urogenital system. You can appreciate in this picture that this is a urorectal septum, and above is the primitive gut, that is the urogenital sinuses, and this septum reach up to this point, that is the futuristic perineal body. And anterior to this is the ectodermal layer called as the anal membrane, and posterior is called as the urogenital membrane. And when this septum reach up to the perineal body, then it gets both the genital system and rectal system separated. But this is the cloacal duct, and persistent of these lead to the fistula in future, right? And this anal membrane later on, if septum reach up to the perineal body, but sometimes what happened is that anal membrane invaginated up to the primitive duct, that is called as proctodium, and the fusion of this may lead to the imperforated anus. This is the anatomy behind all this anorectal malformations. But it is more than that, and there is a many variety are there, still there. Now coming over to the anatomy, normal anatomy, you must have taught about all this in this CME, but I just want to revise all these things. You should know, before handling any case of anorectal malformation, you should know the normal anatomy of the anorectal region. So rectum is around 15 centimeter and begin with the level of third sacral vertebra, and it follows the curvature of the sacrum and coccyx. And at the anorectal angle junction, the guts curve backward, and its concavity is held by that puborectalis sling or muscle, right? And the anatomical anal canal is the outlet of the digestive system. Some smooth muscles and striated muscles are very important for the continence. So one is the internal anal sphincter. It is the circular layer of the rectum which surrounds the upper part of the anal canal. And this is the internal, it is a smooth muscle, so it controlled reflexively and involuntary by the autonomic nervous system. So in the parasympathetic system, by the pelvic nerve S2 to S4, and through the nerva erigentis, and it promotes the relaxation. And the sympathetic system by L2 to L4, through hypogastric plexus and hypogastric nerve, it promotes the contractions. And one is the striated muscle, that is external anal sphincter. These anal sphincter has a three component. One is cutaneous, superficial, and deep. So subcutaneous part is the lowermost end of the, and it tethered with the overlying scale. It is from the corrugate cutis ani, that is the outermost part of the anus. And then the superficial part is seen as the two parallel muscles strips in the axial plane, and intraoperatively can be appreciated as a parasagittal fiber. When you do a PSRB surgery, you will find this parallel muscles during. So these are that parasagittal muscles. And deep part of the external sphincter, it finally merge with the lower part of the levator ani muscles. And the sphincter, these sphincter supplied by the inferior rectal nerves and by a perineal branch of fourth sacral nerve. So you can appreciate in this picture, these are the external inspector. This is the deep part which merged with the levator and eye muscles. This is the superficial part, and which is seen as a parasagittal fiber in PSRP surgery, and this is the cutaneous muscles. Now, another important striated muscle is levator and eye muscles group. It's formed the pelvic floor and forms the pelvic diaphragm. This muscle is comprises of three muscle groups. One is puborectalis muscle, or you can say sling, and pubococcygeus and iliococcygeus muscles. The puborectalis muscle forms the most medial part of the levator hammock, and puborectalis muscle form a sling around the anorectal junction. That is the reason that responsible of that angle, anorectal angle. And the nerve supply of the levator and eye is by the third and fourth sacral nerve and perineal division of the pudendal nerve. So if you see in the internal view, intra-abdominal view, you can find out that it is the puborectalis muscle. It's like a sling. Then the most medial part, then pubococcygeus muscle, and more laterally is the iliococcygeus muscle. And these are three forms the levator and eye muscle group. Now coming over to the classification, various classification has been given and to define the nomenclature and the type of variety of that ARM. But I think still classification are still going on. But I mentioned three of classification. In 1970, the international classification was formed, but it was complete classification, but it was very difficult to follow. So some simplified version were needed. So in 1984, wing spread classification was formed, and the wing spread classification was somehow easier, but it had also some lacunae in that, and it is not included all type of ARM. Then in 2005, Krickenberg classification was given, which does not focus on the anatomical or embryological feature or on imaging. It is divided in two main groups by the major clinical group and rare or regional variant, and is based on the frequency of occurrence and allow management outcome to be measured. So this is a wing spread classification. It divided the anorectal malformation three group, low, intermediate, and high according to the level of the puborectalis muscle. And Krickenberg divided the malformation in the major clinical group or rare or regional group. Now, associations. Actually, it's a embryological condition. So due to the defect in the embryology, so there must be some association always associated with the some other body systems. Say like ARM is most commonly, that is 29.2% associated with the some genitourinary diseases like hydronephrosis and renal dysphagia, but most common associated genitourinary lesion is vesico-ureteric reflux, and in 19.3% cases associated with the vertebral anomalies. It could be hemisacrum, hypoplastic vertebra, or sacral agenesis, and 9.2% cases is associated with the cardiovascular anomalies like ASD, VSD, tetralogy of Fallot, and PDA, and in 6.8% cases associated with the gastrointestinal tract diseases like tracheoesophageal fistula, duodenal atresia, etc. But ARM also associated with some syndromic condition. So in any case, you have to rule out some syndrome, and some syndrome which are associated with the ARM. One is the Down syndrome. In 2 to 3% of cases, ARM associated with the Down syndrome, that is the trisomy of the chromosome 21. And most common associated syndrome is the Vectral. That is the most asked question in case of anorectal malformation. And Vectral is an acronym in which the V stands for the vertebral anomalies, and A stands for the anorectal malformation, C stands for the cardiac defects, T or E stands for the tracheostomy fistula, R stands for the renal defects, and L stands for the limb defects. And so in case of a vector association, you have to look for all these conditions. Another syndrome associated with the ARM is the cat eye syndrome. It is it involves the ARM, coloboma of iris, atresia of the external auditory canal, and it is due to the duplication material of the chromosome 22. And Currarino triad, that is an important triad which is asked frequently asked. It is made by this triad is by hemisacrum anorectal malformation and presacral mass. It could be the anterior meningeocele, teratoma, or enteric duplication cyst. And it is due to the mutation or deletion in the coding sequence of HLX-B9 gene on chromosome 7. Then Townes-Brocks syndrome. In this syndrome, ARM, hand malformation, external ear malformation, sensorineural deafness, or it is autosomal dominant variety, and Pallister-Hall syndrome. In this, it includes the hypothalamic hematomas, anorectal malformations, polydactyly and respiratory tract anomalies are involved in this syndrome. Now coming over to the clinical examination. It's there are lots of things to understand about the clinical examination, but in first look, what will you find out? That one is no or improper anal opening. No or improper anal opening. Inability to pass. You will got a call that patient is not passing meconium. So first you have to look for that anal region in that case. So inability to pass meconium. Meconium, or sometimes meconium is seen but through an abnormal position. You may find a patient with the abdominal distension, sometime passing meconium per urethra. That is this condition called meconiuria. This is it denotes the high variety of the anorectal malformation with the fistula with the urinary system. And only single opening is sometimes seen in the female. That is denotes the cloaca. So you have to look to genitalia properly. So before handling anorectal malformation, now we have to investigate the type of patients. But what is the aim behind investigating all these patients? So the aim is to demonstrate the level and anatomy of the anomaly. Means we want to know that it is a low variety or intermediate or high variety of anorectal malformations, or to know if it is a high or low, but you also want to identify is there any fistulous communication. Also look for the presence or absence of any other congenital anomaly. As I already told you that ARM is associated with the multiple conditions and syndromes. And as a pediatric surgeon, we also want to know about the spinal cord anomalies and integrity of a perineal nerve supply and sphincter muscle complex available for reconstruction to prognosticate or to know the prognosis of that child regarding incontinence. So these are the aims of the investigation. Now, what investigation you go through when you get such type of patients? So first and foremost and most important is the perineal inspection. That is the foremost investigation. That is more of a clinical thing, right? Then go for routine blood investigation and urine analysis. The blood investigation for your PAC workup for anesthetics, or also rule out any sepsis so that you can add antibiotic and it, because most of the patient presented late. Then go for some radiological examination. In that you go for a babygram. Babygram is nothing, that's a full body X-ray of the neonate. Then prone cross-table lateral view X-ray. This is more recommended these days. And Wenger-Stein invertogram, this is more of a theoretical purpose. And it is already obsolete. But it's just, it's still asked in MCQs and in exam. So you should know it for theoretical purpose. Then go for ultrasound. It is done to rule out some associated any renal anomalies and to find out some other findings. And if there is a availability of echocardiogram, then get a echocardiogram also to rule out any major congenital cardiac anomalies. And you should also pass a nasogastric tube in that that is 8 French to it solve our two purpose. One is it rule out the esophageal atresia by because it get coiled. So it first it can rule out the esophageal atresia. Second is to decompress the stomach. And some other investigation, but these investigation are needed before the definitive repair. If you want to do that is MCUG, micturating cystourethrogram and distal lupogram to define the fistula level of the fistula before doing the definitive repair, and CT scan and MRI to know the about the muscle complex. So now perineal inspection. In most of the cases, you can find out the level of anomaly by inspection only. So how you identify a case of low anomaly? What you will find is you will find a good perineum. You will find a pigmented dimple of expected anal site. You can elicit the anocutaneous reflex, and some distal fistula tract might be seen. That is, if you can appreciate, that is a meconium pearl. That's meconium in the perineal tract, fistula, that is called as meconium pearl or epithelial pearl. And you can find out a buccal handle deformity. There is a skin tag through which you can pass any probe or any artery. So these clinical finding denotes the expected low type of anomaly in males. Intermediate variety doesn't come in the low or high, or if you are in doubt. So these are the conditions. And in case of high anomaly, you will find a flat perineum. You can find in the diaper, you can find a greenish mix, something greenish fluid coming, that is the meconium, or evident meconium passing through the urethra. So these are the findings which denotes the high anomalies. In case of low anomalies, there are lots of variety of female ARM. One is anovestibular fistula, which is most common. In the posterior, you will find 3 opening, urethra, vagina, and the one opening in the posterior fourchette in the near vagina. That is anovestibular fistula. Vaginorectal fistula. There are multiple variety, and one common thing is only single opening. If you see, it's a cloaca and ectopic anus. These are the some variety you can find out in the female babies. So now, after perineal examination, go for some radiological examination. One is that babygram. Babygram is what? Full body X-ray of a neonate, because the neonate is lesser than a cassette of a X-ray. So that's why it's called as babygram or infantogram, you can say. What we'll find out, you can rule out the vertebral anomalies by taking this, and you can rule out the pouch colon conditions. And invertogram, this is absolute now, but it is if it was done, that it would be done after 18 to 24 hours, or better to get a cross table prone position, that is only after 18 to 24 hours, not at the time of birth. That point to be noted, not at the time of birth. So don't be in hurry. If a child is born in the hospital, don't be in a hurry. Get X-ray after 24 hours, next day, because the neonate who ingested that air, it takes time to reach up to that level. Distal most part of the rectum, it takes 18 to 24 hours to reach that level, so that we can interpret the level of leveling the high or low. So in case of, if you done properly after 24 hours, then you'll this is the, I don't know, you can appreciate or not. In this, you can see a neonate in the flexed fib position at the level of 45 degree, and in this position this X-ray has bbeen taken, and through which we look for the PC line. PC line is pubococcygeus line, and if it is above that line, then it is high RM, and below it, it's lower intermediate variety. So PC line is, and that this PC line, P is that is upper border of the pubis, and the C is the point is the fifth caudal to the fifth ossific of the sacrum, the fifth bone, and joining this is the PC line, and it is usually asked in the exams. Then go for ultrasound to rule out renal anomalies and echocardiogram to rule out other cardiac anomalies. Now you have examined that patient. Now you decided that this is a low variety or a high variety. Now coming over to the management part. Any neonate, when you receive in surgery department, sir, first you have to rule out some immediate life-threatening situations and stabilize that patient, give IV fluid, put a nasogastric tube, give vitamin K, give antibiotic if needed, if patient is sepsis. First you have to stabilize that patient, because the child need a major surgery in a general anesthesia, and better to investigate an assessment type of ARM and associated anomalies, if any. Now, what to do? Now you have to decide, is it a high ARM or a low ARM? In high, no doubt, in emergency situation, go directly for the colostomy. And low ARM, if it is no ARM, go for anoplasty. So anoplasty or is for the low ARM of variety, and multiple procedure has been given. One is cutback procedure, YV-plasty, triangular anoplasty, cruciate incision in the perineum for the covered, and it depends on the surgeon's experience and training. And but in case of confusion, if you are not confirmed that it is a low or high, or you are in doubt in case of low ARM, it's better to go for colostomy. That is the catch point. If you are in doubt, go for colostomy directly. And if it is a high variety, then it become a 3-stage procedure. When you do a colostomy, it become a 3-stage procedure. So in first stage, you do a colostomy. That could be emergency colostomy. Then definitive repair by one of the popular surgery, that is PSRP, posterior sagittal anorectoplasty, and in third stage, just close that colostomy. So this is a picture showing a case of high anomaly. The child presented with the non-passing meconium for 3-4 days and with abdominal distension, and on perineal inspection, gluteal fold are good, but there is no other sign of low ARM, so it was in doubt. So it was something like intermediate variety. So we decided to do a colostomy. But in colostomy, there are multiple ways of doing colostomy. Some do loop colostomy, some do high divided sigmoid colostomy. But both are good, but more idealistic is high divided colostomy, because it is more diverting type. So high divided colostomy is recommended if you know that. Okay, if you don't know, do a loop colostomy, not an issue. Then after colostomy, then after 4 to 8 weeks, go for a PSRP surgery. That is a definitive surgery, PSRP. So this is the position of that while doing a PSRP surgery. And in this midline vertical incision given in the sagittal region, and it should be strict in the midline. So you have to first you resume anal opening, then take a stage suture, then give a posterior sagittal incision and go deeper and deeper. Then you will, after going through the parasagittal fiber, you will might find a vertical group of the muscle complex, and nearby that you will find a rectum, and through that you take a stage suture on that rectum, pouch and open it and tackle the fistula and pull down that rectum and create a new anus. This is how take down that and do a PSRP procedure. And initially you need, sometime you need a dilatation, and for that is a different thing, but this is how you go for a. And sometimes in some situation what happened is you don't find a fistula in that procedure, it is much higher. So there is another procedure, that is abdominoperineal pull through. In this, what happened is it is usually done in the higher variety of the fistula, above the bladder neck or bladder, connecting the bladder or bladder neck. And in this, the lower bowel is bowel is mobilized through abdomen incision, and simultaneously there is a new passage is created to the pelvic floor, keeping the close to the urethra, and the fistulous tract is divided and ligated, and the bowel is pulled down and mucosa stitched to the skin and form a new anus. And this is how and there is a some this is how abdominoperineal pull through is done, and this bowel is ligated and separated from that fistula and pulled down through the abdomen only and create a new anus. And there is a another way of doing it, that is laparoscopically assisted nanorectal pull through, LARP, for high ARM. In this, the colorectum in the pelvis is mobilized laparoscopically and the fistula taken down. Then urethral end of the fistula is closed with the endoloop, and the site of the anus is decided by the identified by the stratified marker using a muscle stimulator. Or if you don't have a muscle stimulator, you can use a low frequency cautery also. You can find out if some muscle twitch is there. So that is the expected level of the anus. And a small incision is made in that center of that site, and 10 mm trocar is introduced in the pelvis through that expected anal opening, and the mobilized rectum is pulled down through the port and anastomosis to the skin and form a new anus. The advantages of doing a laparoscopic approach are clear visualization of the fistula in the deep pelvis and magnification and accuracy. In female low ARM, there is a I'm not talking about cloaca, but for anovascular fistula, there is another surgery is defined, that is ASRP, anterior sagittal anorectoplasty. The indication of ASRP is all the low and intermediate type of abnormal in the females, and revision surgery following cutback operations. So it involves the midline incision from the fistula to the expected or putative site of the anus, and division of the muscle in the midline, and separate the rectum from the vagina under vision, and placement of the rectum in the sphincter complex, and reconstruction of the perineal body. This is how ASRP is done. It is commonly done in the case of anovestibular fistula type of variety. And this the ASRP incision is given, and that rectum is separated from the vagina and placed in the expected site of the anal complex and create a perineal body. So this is how ASRP is done. So my take-home message is, don't panic in case of inborn or in case of delayed presentation of ARM. Still don't panic. First, you have to stabilize that baby, and you have to wait. Still, you have to wait for 24 hours. If it is delayed, though, there might be finding of the low variety or high variety. You may find out by perineal examination only. But stabilize the patient and wait for the 24 hours. And always rule out the associated anomalies and life-threatening situation, condition, diseases, so that you can prognosticate that patient, that child, and tell the counseling about the related morbidities. And no investigation, that is more important, that no investigation substitute a careful examination, clinical examination. Do it in a proper light, but nothing can substitute a clinical examination. And in case of diagnostic dilemma, if you are in confusion, then go for colostomy, and high divided sigmoid colostomy is preferred. That is my take on this. Thank you. So thank you for patience listening. And anything you want to know or you want to ask, you can ask.
Hello. Thank you, Dr. Mathur, for giving us very illuminating and elaborate lecture. Although it's improper anus or anorectal malformation is a very vast subject, and it's not possible to cover each and every aspect of the disease. Particularly when many people are involved in the treatment, and physicians and many patients are received in emergency neonatal ICUs, where you don't expect them to do a complete survey of the investigation. But still, as you said, the takeaway message. There is no replacement of the closed perineal examination for the presence of any fistula or a flat perineum, number one. Number two, there is no replacement of a good cross-table prone invertogram, which will give us immense information. And third thing is, it doesn't take very long to decide whether to do a colostomy or an angioplasty based on these two observations. So, third thing which I would like to say, over the years of say 30 to 40 years of this posterior sagittal angioplasty, I have seen the transition from Stephenson's sling operation to posterior sagittal angioplasty, and I have had opportunity to assist Alberto Pina also for 3 days, who has designed this surgery. That the availability of good anesthesia, good postoperative care, the treatment of our imperforate NS has got tremendous change. And thank you very much for this.
Thank you, sir.
We would like the audience to ask any questions.
Just to conclude, to summarize one more point about the babygram. Babygram is to be done as early as possible, but with a NG tube in C2. Again, I am saying NG tube in C2, not just now I would request Dr. Dhanesh Kumar sir to kindly come on stage and felicitate Dr. G.K. Sharma sir and Dr. Gaurav Gupta sir. Now, our next session is recent guidelines for management of rectal prolapse. And to chair the session, I would like to invite Dr. Vishal Agrawal, sir. Sir is a renowned surgeon, and his clinical skill has helped spread the good name for far and wide. He has many international and national publications in journals. Kindly join us on the stage, sir. I would like to invite Dr. Nimesh Agrawal, sir, who is the head of the Department of General Surgery at Kalpana Chawla Medical College, Haryana. Sir has a teaching experience of more than 17 years and has published more than 30 papers in various national and international journals. Sir is extremely proactive when it comes to organizing academic events like CMEs and conferences. Kindly give us a mic, sir. Thank you, sir.
स्लाइड चेंजर
स्लाइड चेंजर नहीं है सर,
स्लाइड चेंजर है हमारे पास
नहीं सर, स्लाइड चेंजर नहीं है, आप ऐसे कर सकते हैं, एरो से कर सकते हैं, एंड दिस इज द पॉइंटर सर,
दिस इज द पॉइंटर हटा दो नीचे
स्लाइड चेंजर
आई Very good afternoon and greeting from the Karnal, which is the land of the Danvir Karn and Uran Pari Kalpana Chawla. And I am thankful to organizing committee headed by Dr. Shashank for inviting me to present my topic. So with permission of chairperson, I want to start my topic given to me. That is the recent guidelines in management of rectal prolapse. Basically, we'll discuss about the changing concepts in the rectal prolapse and how to evaluate and what are the surgical solutions. In 1831, Frederick Salmon has written in his practical observation of prolapse of rectum that there are few diseases to which the human body is liable, more painful and distressing to bear than that which forms the subject of the following pages, or one which at the same time I regret to add is more common yet less generally understood. This is in 1831, and in 2015, a study has been done, and author's conclusion were lack of high quality evidence, small sample size of included trials, methodology weakness, severe limit of usefulness of this review for guiding, impossible to identify or refute, longer follow-up with current studies and larger rigorous trials are needed. So in so many years, there is no conclusive evidence what to do and what not to do. Still we'll to try, take a aspect and reach to a conclusion. So rectal prolapse may be full thickness rectal prolapse, mucosal prolapse, or the internal interception, and it may be due to the sliding hernias, or it may be due to circumferential interception. It is associated with the fecal incontinence, with the constipation, and or the pelvic floor abnormalities. In changing concept, no more it is an isolated disorder, often associated with the other compartments, like in anterior compartment, urethra, bladder may be involved. In the middle, wart, uterus, small bowel may be involved. Posterior rectocele or rectal prolapse may be involved. So now, new term POPS, that is pelvic organ prolapse syndrome, is coming up. In evaluation, like in any other disease, we take the history, we do the examination, and investigation in mandatory, which is standard, is sigmoidoscopy, dynamic evacuation, proctography, and the MR deprofocography. And now desirable, which is the recent, are the dynamic transperineal ultrasound, 3D ultrasound, manometry, and the electromyography. So these are the few investigations. Then American Society of the Colporectal Surgeons have given this grading system for the recommendation, where 1A is having the strong recommendation with the high quality evidence, and 2C has the weak recommendation of low or very low quality evidence. So they have, so we'll discuss one by one the various aspects and see what are the recommendations they have given in the 2017. So evaluation of rectal prolapse, the initial evaluation of patient with a rectal prolapse should include a complete history and physical examination with focus on the prolapse, on anal sphincter structure and function, and on concomitant symptoms and underlying conditions. Additional testing such as fluoroscopy or MRI dephecography, colonoscopy, barium enema, and urodynamics may be used selectively to refine the diagnosis and identify other important coexisting pathology. Anal physiological testing may be considered to assess and treat coexisting functional disorders associated with the rectal prolapse such as constipation or the fecal incontinence. So treatment of rectal prolapse is mainly to restore normal anatomy with the hope of improving function. There are more than 100 procedures. Resection or plication of renal bowel may be done, or fixation of rectum to the sacrum. So as the English proverb is saying, there is more than one way to skin a cat. First, we discuss the non-operative management, that is rectal prolapse cannot be corrected non-operatively, although some of the symptoms associated with this condition such as fecal incontinence, pain and constipation can be palliated medically. In the long term, patients with rectal prolapse who do not undergo surgery and are only managed medically will develop irreversible fecal incontinence. Allowing prolapse to continue untreated beyond 4 years may lead to higher rates of subsequent rectal prolapse recurrence, presumably secondary to a secondarily weakened pelvic floor. So rectal prolapse should be corrected as a first step in patient reporting rectal prolapse and fecal incontinence. Conversely, constipation-inducing maneuvers such as the transaction of the lateral ligaments during suture rectopexy may be beneficial in these situations. So in the surgical strategies problems there are many techniques, few randomized studies, short follow-up, and lack of standardized pre- and post-operative evaluation. Also, we have got the different patient profile, like young fit male with obstructive symptoms may be there, young females may be there, middle-aged multiparous female with severe fecal incontinence, nulliparous middle-aged female with chronic constipation or the constipation, aged active female with total pelvic prolapse, and the aged senile males. So we have to tailor-made our treatment for the various demographic profiles. Some says that in the old patient we can do non-operative or the conservative management, but a study has done where they said that when selected appropriately, patient 90 years of age or older have outcomes similar to the younger patient. Therefore, age alone should not be the contraindication to surgery. In addition, elderly patients have a median survival of more than 4 years after surgery, so the operative risk can be worth the beneficial occurred. So, but there are various different surgical approaches and we can't compare the apple with the oranges. In the evolution, there abdominal rectopexy from the obliteration of cul-de-sac and presently to the ventral rectopexy, we have traveled a lot. And now our mainly is whether extent of mobilization may be posterior or the lateral ligaments, or posterior rectopexy sutured or mesh. We have to use the suture, with the suture it or the mesh fixation has to be done. We have to do the resection rectopexy, which leads to the constipation, or we can do the ventral rectopexy, which is the newer concept. So which way is better? Perineal or abdominal, open, laparoscopic or robotic? How should the rectum be mobilized? Resection of the adherent colon should be done or not? How should the rectum be fixed? And which mesh should you use, prosthetic or the biological? So in the perineal procedure, we have seen that Delmers has the 0 to 38% recurrence. Admers have the 0 to 16% recurrence. In patient with acceptable risk, the procedure of choice for the treatment of rectal prolapse should typically incorporate transabdominal rectal fixation. Patient with a short segment of full thickness rectal prolapse can be treated with mucosal sleeve resection, or rectal prolapse may be treated with a perineal rectosigmoidectomy. So these are the pictures showing the Delmos procedure, and these are the Admers procedure. So in rectopexy versus no rectopexy, it has been seen that in the two non-randomized trial, rectal mobilization alone may be enough. In suture rectopexy, mobilization and upper fixation by the fibrosis and suturing can be done. In suture rectopexy, it has seen that mortality is 0% and recurrence is 0 to 9%. In posterior mesh rectopexy, to create more fibrosis, a variety of meshes and sponges are used. Like local recurrence is 0 to 6%, pelvic substance 2 to 16%, and mortality is 0 to 3%. Incontinence improved, but constipation made worse. So if patient having already constipated, then it will become more worse. In the resection rectopexy, These are the procedures which have been shown. Posterior rectal mobilization without a rectopexy with or without a concomitant anterior resection is associated with the higher recurrence rates and complication and is typically not recommended. Rectopexy is a key component in the abdominal approach to the rectal prolapse. Sigmoid resection may be added to posterior suture rectopexy in patient with prolapse and preoperative constipation. There is insufficient evidence to argue that the posterior rectal prolapse repairs such as suture rectopexy or resection with the suture rectopexy are better or worse than anterior rectal prolapse repair such as ventral mesh rectopexy. Another prosper trial done in the UK, a randomized comparison of surgical treatment for rectal prolapse with abdominal perineal or approach or suture or resection rectopexy. Result said that large prosper trial is very large, but still it is underpowered. Abdominal and a perineal approach have similar outcomes. Sutures and resection rectopexy have similar recurrence. Demrose versus Altman's procedure have similar recurrence, and meta-analysis with other relevant trials are required. It has also seen alternative in the lateral ligaments, where Speakman 1991 and Mullen 2000 done that division may result in denervation of the rectum due to the damage to the parasympathetic component of the inferior hypogastric plexus, causing more constipation. So preservation may result in the more of the recurrence. So problems of the posterior mobilization is that there is high incidence of constipation, that is 30%. There may be sexual and the bladder dysfunction. There may be autonomic denervation following posterior mobilization. So posterior mobilization of rectum with mesh fixation of the anterior rectal wall to the sacral promontory may be used for treatment of rectal prolapse, but is associated with the higher morbidity. A modified Wells procedure using a variety of foreign materials for posterior fixation of the rectum may be used for treatment of the rectal prolapse. So mesh suture to the anterior aspect of the rectum and fixed to the sacral promontory. Ventral mesh rectopexy offers an alternative approach to the repair of the rectal prolapse with acceptable short and the long-term complication rates. This is sarcocolpopexy. And in the process of the development of new technical surgical techniques, correct the leading cause, that is full thickness insusception, correct concomitant antrocele or the rectocele, preserve the rectal ampulla, avoid autonomic nerve damage, and it should be reproducible, that is the safe laparoscopically, as sir already told. So introduction and uptake of the laparoscopic ventral mesh rectopexy. Here it is saying that there is no major post-operative complication and there is improvement in the fecal incontinence and the obstructive symptoms. Conversion rate is around the 3.7% and minor morbidity in 7% and recurrence rate is 3.6%. The unique feature of laparoscopic ventral mesh rectopexy is avoiding post-lateral dissection of the rectum. In lap versus open, studies show the lap as effective as open, but a benefit of lap is that there is reduced pain, reduced hospital stay, no difference in incontinence, constipation, recurrence, and less complication in the laparoscopic group. So a minimally invasive approach to rectal prolapse by experienced surgeons is associated with the improved morbidity and comparable recurrence compared with the open surgery and should be considered when technically feasible. So surgical treatment for rectal prolapse, he has shown that retrospective review of the American College of Surgeons National Surgical Quality Improvement Program that no significant difference in risk adjusted morbidity and mortality between the laparoscopic versus the perineal surgery for the prolapse. In the lap versus the robotic, it is seen that robotic ventral mesh rectopexy, longer operative time, less blood loss, fewer early complication, better improvement in the post-operative ODS score, digitation, staining, and satisfaction after defecation. But maybe this robotic longer operative time may be due to the experience. Later on, it has further studies that now time of the laparoscopy as well as the robotic are mainly same. So it's also seen that in the another study that there is doing the laparoscopic ventral rectopexy for obstructive defecation syndrome, there is improvement in ODS in 88% of patients, and in one patient the mesh was rejected and finally removed. And in the next case where abdominal ventral rectopexy in a study on fecal incontinence constipation, it has seen that 65% patients were cured and 32% improvement and 2.5% unchanged. De novo constipation rises in 5%, improvement in constipation 65%, recurrence in the 1%. So there are other studies where it's seen that there is improvement in the fecal incontinence and the constipation. It has also seen in the next study that most frequent complication of the anterior rectopexy for full thickness rectal prolapse is the UTI and the urinary retention. Mean recurrence rate was 4.7% with a median follow-up of 23 months. Improvement in constipation 3 to 72% of patient. Worsening of new onset constipation occurred in the 0 to 20%, and incontinence improved in the 31 to 84% of the patient. So abdominal rectopexy has seen that there's conversion to open is the 0 to 29%, and it is also seen that median follow-up of the 17 months. So optimal strategy is that there is no significant difference for determined between the tag. They have done the fixation, mesh fixation during laparoscopic ventral rectopexy. They have fixed the mesh either by the Protac 5 mm tracker or by Ethibond XL20 stitches or by the Karlsruhe screw. So they have seen that the mean disruption force was 58 N for the 3 Protac tags, 55 N for the 2 stitches, and 70 N for the new screw. So the use of screw therefore led to a significantly stronger fixation compared to the use of stitches. No significant difference was determined between the tags and the screw fixation and between the tags and the stitches fixation. The use of one screw for proximal mesh fixation therefore a reasonably alternative to the use of the several tags or sutures, because in deep pelvis when we're using the multiple sutures and the trackers, it can cause the more trauma and as well as time. So single suture is giving the maximum force fixation, then it is better to use that only. Then it is also seen that there is no significant difference in the term post-operative morbidity procedure length, post-operative symptom improvement between the two groups where we have done the glue fixation with the mesh fixation in the sutures. So for the biological mesh or the synthetic mesh used, biological meshes appear to be as effective as the synthetic mesh in the short term for the laparoscopic rectopexy. So these are other studies we have done where showing that the laparoscopic surgery is the gold standard for the rectal prolapse, but it should be under the competent surgeon. So risk factors for recurrence after laparoscopic surgeries are that it is the overall recurrence is 11.7%, and age more than 70 years and poor preoperative continence we are associated with the recurrence on the unvariate analysis. Predictor for recurrence are prolonged symptoms and using synthetic mesh as compared to the biological graft. Technical failures contributing to a recurrence include mesh detachment from the sacral promontory and inadequate mid-rectal mesh fixation. So in multi-center collaboration, it has been seen that 23 patients require treatment for minor erosion morbidity and 18% were treated for the major erosion morbidity. So this mesh erosion of mesh is a major concern for the surgeons doing the laparoscopic ventral mesh fixation for the rectopexy. For the whether to use the synthetic or the biological mesh, it has been seen that the similar occurrence, similar recurrence, similar complication, and biological mesh appear to be as effective as the synthetic mesh in the short term laparoscopic. So it has been seen that the apparently better functional outcome after the VMRP, and it is an endpoint is at the 1 year. It is a balance in the constipation and primary endpoint changes in the obstructive disorder of the syndrome. So functional outcome measured by the preoperative to postoperative changes in ODS score was not significantly superior in patients who underwent the ventral mesh rectopexy compared with those who had posterior suture rectopexy. This is a slight pinch of salt that FDA released the warning. In 2008, FDA released the warning to a healthcare professional outlining serious complications associated with the transvaginal placement of the surgical mesh in treating pelvic organ prolapse and stress in urinary incontinence. To date, FDA has received almost 10,000 reports of adverse events linked to the surgical mesh. The agency issued a second warning in July 2011 as a result of spike in reports of serious adverse events associated with the mesh. So mesh erosion, it has been seen that in the 45 patients, 20 vaginal erosions, 17 rectal erosions, 7 recto-vaginal fistula, and 1 perineal erosions are been there. So indication of rectopexy is where hysterectomy is done, or the vault or the vaginal prolapse, large cystocele, grade 4 or 5 rectal insusception, grade 3 enterocele or descending perineum, poor sphincter functions, external prolapse, young men with the above and or solitary rectal ulcers, relapsing symptoms post-STAR, and any of the above in women plus urinary stress incontinence or stress incontinence post-ventral mesh rectopexy, failed gynecological repair, dermatitis or ultimus posterior rectopexy, or poorly executed ventral rectopexy. Also in the 2017 Dutch guidelines gave the clear-cut instruction that in the anorectal function test indicated in the rectal prolapse, in the fecal incontinence or the obstructive obstruction, it is not indicated in the external rectal prolapse. But in internal rectal prolapse, for the diagnosis, conventional dephagography or functional MRI is indicated. Then, for the conservative treatment for patient with internal rectal prolapse and functional symptoms, lifestyle counseling and the high fibrous diet, sufficient fluid intake, physical exercise. In addition, patient are advised to start taking stool bulking agents. Then optimal surgical treatment for the rectal prolapse, both the IRP and ERP, is the laparoscopic ventral mesh rectopexy. Material used for the LVR is the polypropylene mesh. So these are the 2017 Dutch guidelines. So conclusion, prolapse is not an isolated disorder. Middle compartment is involved and associated vaginocele, uterocele or wall prolapse may be present. Pelvic organ prolapse syndrome is the compound that is doing all the symptoms. Autonomic nerve injury in posterior decision can occur. Need to preserve lateral ligaments. Lap ventral rectopexy is the new gold standard, which improves the obstructive symptoms as well as improve the fecal incontinence and the constipation. So we have to tailor the procedure to patient's condition, fitness and anesthetic risk, inform patient about the risk and the recurrence rates, role for perineal procedure in elderly unfit patient, low morbidity and high recurrence rate, role for rectoscopy, preferably lap or robotic if fit, posterior suture rectopexy as good as the posterior mesh, avoid taking the lateral ligaments. Ventral mesh rectopexy adds the risk of mesh, but it's superior if perineal descent and the middle compartment prolapse presents. So lastly, evaluation and the treatment algorithms is the rectal prolapse. If medically fit, we can go for the sacropexy or ventral meshpexy. If it is they are not fit, high risk, then they can go for the EMG testing. If EMG is normal, then go for the Altimeus or the levatoplasty. If EMG shows non-relaxing, then they can go for the Altimeus procedure. Thank you so much. Thank you.
Hello. First of all, I would like to congratulate Dr. Nivesh Agarwal sir for such a nice and elaborative presentation. He has almost covered all the aspects of recent guidelines and managements over the rectal prolapse. I think there is nothing to add in this description. And it's a great honor for me to chair a session of my teacher. He is my teacher. I was doing SR-ship in Subharti Medical College. He was my assistant professor in the same institute. So I am thankful to Dr. Shashank Mishra, head of the department, for giving this honor. Thank you. Thanks a lot. Any question from the audience, please? Thank you. Thank you, boss. Thanks a lot.
Now I request Dr. Vishal Agrawal sir to felicitate Dr. Nivesh Agarwal sir. I request Dr. Shashank Mishra sir to facilitate Dr. Vishal Agrawal sir. Moving ahead with the final discussion of Subharti Surgery Update 2023 on recent advances in management of hemorrhoids and its complications. The session will be chaired by Dr. Sunil Kamal sir, Senior Consultant in Advanced Laparoscopic Surgeries at Bhagyashree Hospital and Anand Hospital. Dr. Sunil sir has done its post-graduation from LLRM Medical College and Sarojini Naidu Medical College, Agra. The second person to chair this session will be Dr. Umesh Singh Sir, Assistant Professor, GS Medical College, Pilkhwa. He is an alumni of LLRM and is a fellow minimal assist surgery. He's a fellow in minimal assist surgery, a fellow in advanced laparoscopic surgery, and a fellow in International Society of Coloproctology.
May we please request on stage Dr. Hemant Nautiyal, Professor, Head of Department, Department of General Surgery, Head Bariatric and Body Metabolism Unit, with teaching experience of more than 18 years. He is a fellow in Minimal Access and Bariatric Surgery, Sir Gangaram Hospital in 2008. Sir has done his fellowship in Bariatric and Metabolism Robotics Center, Shri Aurobindo Institute of Medical Sciences, Indore.
Good afternoon, everybody. First of all, I would like to thank Dr. Shashank Mishra for inviting me to present this talk on recent advances in hemorrhoidal diseases. Though a very common topic, but to sum up and to make it was a little bit difficult for me. Because there are no as such new things. There's a lot of confusion in the textbooks also, which procedure should be done, what are the advantages of particular procedure, how to choose a procedure. It is confusing for the patient as well for a surgeon. But what is happening, the surgeons, whatever the technique they know or we know, we do it in most of the cases and say this is the best method. So going through the literature review and trying to look for the level 1 evidence and grade A recommendations, I have tried my best to get the best available data in the literature and to present the guidelines what is recommended, so that we become more wise after this talk, how to choose a procedure and what are the pitfalls and the advantages of the particular procedures. One thing. Yeah. Okay. So as we know, hemorrhoidal disease is a very common disease. It afflicts from 4% to 14% of the world population. And it is mostly, presentation is mostly after the 4th decade, and it affects up to the age of the 65 to 70 years of individuals. As described years back by Golliger, and the same classification is still accepted by the American College of Colorectal Surgeons, European Coloproctologists, and Association of Colorectal Surgeons of India, hemorrhoid is divided into 4 grades. It is very important to know this. I'm just summing it up, because the treatment decision depends on the grade of the hemorrhoids. So as all we know, grade 1 is the prominent hemorrhoid vessel with no prolapse. Grade 2, where there is a prolapse during defecation and the spontaneous relapse of the prolapsing hemorrhoids. Grade 3, when it requires manual reduction, and grade 4, when it cannot be reduced manually. Etiopathogenesis is still exactly not known. There are various multiple factors, maybe due to decreased vascular anal tone of these specialized vascular channels in the submucosal region of the anal canal, vascular hyperplasia, dilatation of these vessels, elevated intra-abdominal pressure, and increased flow in the superior rectal artery. So as the pathophysiology, there is no one particular factor. That's why there may be multiple treatment methods to treat this disease condition. Choice between various treatment methods is very confusing. If we go by the grade, consensus is there regarding the grade 1, that it should be basically the dietary changes, lifestyle changes, and the conservative management. Grade 4, hemorrhoidectomy is still considered the procedure of choice. There is a very high recurrence rate and failure rate with other high-tech methods or the minimal invasive procedures. but the confusion lies between the grade 2 and the grade 3. So still now, conventional open hemorrhoidectomy is a gold standard. So every new technique, whichever comes in the market, is compared with this open hemorrhoidectomy because it is a gold standard when it comes to the recurrence. So then what is the problem? When it has a least recurrence rate, when we compare it with laser hemorrhoidectomy, MIPH, infrared coagulation, sclerotherapy. The problem is that it has a post-operative period there is a pain, discomfort to the patient, and sometimes bleeding is more as compared to the other available methods of treatment of hemorrhoids. So attempt is there by the various associations how to choose a procedure so that the patient can have a least recurrence rate as well as a comfortable post-operative period. So knowing that open hemorrhoidectomy is the procedure of choice when it comes to recurrence, it is a gold standard. The various adoptions or new innovations were done by the surgeon to reduce its post-operative problems, like Ferguson closed method, rubber band ligation, stapled hemorrhoidectomy, also known as MIPH or PPH, infrared coagulation, and nowadays very in thing is a laser hemorrhoidopexy or hemorrhoidoplasty. So each of one had their advantages, but they have disadvantages. So it is very important to understand for a surgeon because the result depends on 3 to 4 things. First is the acceptance by the patient, cost to the patient, post-operative discomfort to the patient, and skill of a surgeon. So latest method, which is non-excisional laser hemorrhoidoplasty, which is an in thing. It is a costly procedure, and it is claimed that it is as good as open hemorrhoidectomy in grade 2 and grade 3. But grade 4 and grade 1 it is not required, and grade 4 it has a high recurrence rate. So I will be discussing all these modalities against this new thing. Because this is a costly procedure in the market private sector, they are charging around 50,000 to 1 lakh rupees for the laser treatment of the hemorrhoids. Cost of the machine is around 10 lakh rupees, 7.5 to 10 lakh rupees. But the good thing is that the patient is always ready for this if he can pay you. Utter a word, we will treat you by the laser method, and he is ready to pay you 50,000 rupees. But you say open hemorrhoidectomy, he will say no. So he is not bothered about the recurrence more. He is more bothered about the term that it is treated by the laser. But you explain to him that it may have a more recurrence, then he will say, okay, then you do it by the open method. I don't want a recurrence because I have to spend again 50,000 rupees. So as a surgeon, we should know all these things because the patient may take you to the court later on that I was not given the option. So treatment of the hemorrhoid has now become a cafeteria choice of a thing for the grade 2 and grade 3 hemorrhoids. You have to give the options to the patient that these are the options available. I do these surgeries and these are the advantages and these are the disadvantages of or the demerits of this surgery. So he can choose with advice of a surgeon, counseling by the surgeon. So he is happy post-operatively also if he has a recurrence. I have seen many of my colleagues explaining to the patient when MIPH became popular that in this method there is no recurrence and you spend extra 20,000 money for the gun and the patient is ready for that. He's innocent. He says, okay, if I spend extra 20,000, there will be no recurrence. But we knew from the start that its recurrence rate is more than the open hemorrhoidectomy. So in the consumer court era, we should be well aware of this thing. We have to give option to the patient, explain to the patient. So this is just a summary of the recently published guidelines by the European Society of Coloproctology. So grade 1, it is the dietary changes that all we know, constipation, irregular bowel habits are one of the most important accepted pathophysiology for the hemorrhoids. So all these patients should be advised high fiber diet, high fluid intake to avoid constipation, not spending more than 5 minutes in your toilet. If you're not feeling that you are not able to defecate, come out of the toilet, go when there's a next urge. So it is accepted worldwide that there should be conservative management first. If this fails, then there is a role of infrared coagulation or sclerotherapy. Because rubber band ligation or MIPH can cause a disaster to the patient. MIPH can lead to the severe pain in the post-operative patient. We had one patient admitted for 1 week in the hospital after MIPH due to severe pain because the patient MIPH was done in a case of grade 1 hemorrhoid. the staple line came below the dentate line, and there was so much of the pain, the patient was on IV analgesics for 1 week. Similarly, in the band ligation, there can be problem if you are using band ligation in a grade 1 hemorrhoid. So if the conservative management fails, then infrared coagulation and IRC and sclerotherapy are the recommended therapies for the grade 1 hemorrhoids. Grade 2 hemorrhoids, as I said, 2-3 is the land of confusion. There are multiple options are there, and they are sometimes equally efficacious with some ifs and buts. And grade 4, as I said, open hemorrhoidectomy is still a gold standard. If open hemorrhoidectomy fails or the patient refuses for that or there are contraindication for surgery, then the band ligation can be done. STAR procedure, which was very much pushed when the MIPH came into the market, is recommended. It should not be done in the grade 4 hemorrhoid disease. So first degree hemorrhoids, as I said, improve bowel function by laxatives, increase fluid intake, regular bowel habits, patients should be explained regarding that. Regarding those creams which are available in the market, that is Ano, Bliss and all these things which are frequently written by the physicians and even by the surgeons, the evidence shows that there is no use of these things. Evidence-based science literature shows it has not shown any benefit in these patients. Rather, the dietary changes, lifestyle changes is the thing which can make the difference. As I said, refractory cases, we may go for rubber band ligation with the query, preferably injection sclerotherapy and the infrared coagulation. Regarding the phlebotonics for the hemorrhoids, Cochrane database has given a guideline. In the randomized trial, it has been shown that they are beneficial. That is flavonoids and rutoside, all these things. They have shown they help improving the patient in relieving their symptoms. So they can be used. That is a in thing. They have evidence that they prove beneficial to the patients. So these things are sufficient in the grade 1 hemorrhoids. If these measures fail, then IRC and sclerotherapy is the answer. So now let me come to the second and the third grade hemorrhoid, which is the most confusing area for the surgeons. And the data is also confusing because it is not considered a very disease like a carcinoma rectum, carcinoma breast, where you will get a very well-designed studies worldwide, because they are considered, yes, this is a disease, this should be, research should be done on this disease. Hemorrhoid is considered as a trivial disease by the physician, by the doctor, by the patient. So you will surprised to know that though it is a very common disease, but the data is scanty when you come to the randomized trials and the very good studies which we can easily do. So in my presentation, I will be only presenting the grade 1 evidence and grade A recommendations. So rubber band ligation, as I said, for the grade 2 and 3 is the most popular and the effective treatment which have been shown superior to the IRC and sclerotherapy. So if it's grade 2 and 3, rubber band ligation is worldwide accepted by all the societies and the countries as one of the most preferred treatments. Various studies have shown that recurrence after 2 years is only 11%. Yes, if you compare it with open hemorrhoidectomy, it will have more recurrence rate. But if you compare that there is a post-operative discomfort, it is very less, complications are very less as compared to open hemorrhoidectomy. So even if you explain to the patient, rubber band ligation has a recurrence rate of 10% after 2 years, and open hemorrhoidectomy is a nearly zero recurrence rate, the patient may go for rubber band ligation because it's only 10% after 2 years. Post-operative, there is no discomfort. It is an office procedure. You can discharge the patient from the OPD. So patient will easily accept it as compared to the open hemorrhoidectomy. So there is one caveat regarding the studies that what should be done if the patient is on anticoagulants or there is a portal hypertension. In those patients, which procedure should be done? So evidence in the literature shows that rubber band ligation should be avoided in this patient because here the mechanism is ligating at the base, and there is then later on the sloughing of that hemorrhoidal mass. So brisk hemorrhage has been noted. So of the patients who are on anticoagulants and who are on the portal hypertension, the rubber band ligation should be avoided in those patients. So as rubber band ligation became famous, the studies comparing it to hemorrhoidectomy, the data has emerged. This is the recent 2021 data analysis of the only meta-analysis of only randomized controlled trials. There are no prospective or retrospective studies, and out of that data, when the data was summed up for 1208 patients, it was found that hemorrhoidectomy is superior to rubber band ligation when you compare the symptoms, post-operative pain and complications. So when it comes to the bleeding, there is more bleeding in open hemorrhoidectomy as compared to the rubber band ligation. Very simple to understand because it is an invasive procedure. When we come to recurrence rate, there is significantly increased recurrence rate in rubber band ligation as compared to open hemorrhoidectomy. When it comes to post-operative pain, again the open hemorrhoidectomy has a more post-operative discomfort and the pain as compared to rubber band ligation. When it comes to urinary retention, again more incidence of urinary retention in open hemorrhoidectomy patients. Anal stenosis is another problem with open hemorrhoidectomy as compared to the rubber band ligation. So when it comes to post-operative complications, rubber band ligation is a very safe procedure as compared to the open hemorrhoidectomy. So that is the reason it has become the number one or the preferred position procedure for grade 2 and grade 3 hemorrhoids. Again, anal incontinence is more in the hemorrhoidectomy. So then came the era of the Doppler-assisted hemorrhoidal artery ligation. 6-7 years back, you go to any conference and you will see Doppler DAHL. This is the procedure of choice. And now you see it has gone again, taken the back seat, and you will not see it proponent. And now the surgeons have shifted to laser treatment. 3-4 years back, it was MIPH. So the problem is that as soon as there is a new technology in the market, to show what we are doing different, we just jump onto that strategy. I am doing this because you will be called on the stage only if you are doing something different. Surgeon who is doing very good open hemorrhoidectomy will not be given a place in the stage. So this is a tendency. And after a few years, see when the data emerges from the international market, you see that thing has gone out of the market. That has happened in many of the things. You all know this. 10 years back, notes, natural orifice transendoscopic surgery. It was a talk in the surgical forums. Everybody, a few people in India were doing. I also went specially to Mumbai to attend his lecture. I thought it's a very stupid procedure, very risky. Why he is doing like this? Just to add small incisions. But everybody there in the forums, he was the big shot from Mumbai, I will not name him, and he was showing all his cases. And now you know notes have been banned in the country Germany from where it is originated. Now you can be jailed for doing a note. And at that time it became a fashion doing a notes that if you don't do notes, you are a stupid surgeon. So this happens in our surgical community, in the academic forums also. So this came the DH and it was propagated because there are companies also after that, you have to buy a Doppler. Patient also thinks doctor will use some machine to identify the vessel, they will ligate it. And then came the Hubble multi-center trial. This trial was conducted in the 17 centers of the United Kingdoms. 1 year follow-up was done. It was a random trial. Random patients were assigned randomly. So biases were excluded from the study. And they found that though the recurrence rate was less in the Doppler-assisted hemorrhoidal artery ligation as compared to the rubber band ligation, but the post-procedure pain was more in that procedure. Recurrence was less in HAL because rubber band ligation required sometimes multiple sittings, though they were just office sittings. You can do it in the OPD, we all know we have done it, and you can discharge the patient. But for Doppler assisted, you have to admit the patient. Maybe it is a daycare surgery, but you have to admit the patient. Loco-regional anesthesia is required, but it is more associated with post-operative pain. The cost of the procedure is more. So it was found after the survey of the various patients and the insurance agencies, they said that rubber band ligation is a better procedure than the Doppler-assisted hemorrhoidal artery ligation. Yes, it is still an armamentarium in the hands of a surgeon where there is a recurrence or sometimes patient prefers it because there is less post-operative pain. So this can also be offered to the patient, but knowing its advantages and the disadvantages. And you see the complication rate. As compared to the rubber band ligation, hemorrhoidal artery ligation has a significant more bleeding, urine retention, even uncommon few cases of sepsis, pain which may be requiring readmission in the hospital, and vasovagal upset. When it comes to the cost is around 2 to 3 times more than the rubber band ligation. When it comes to quality of life, both the procedures are same. So when the recurrence is same, if you do the rubber band ligation in the second visit, if there's a requirement, And all the complications are more in the hemorrhoidal artery ligation, then what is the sense of going for that procedure? More complications, more costly, long-term recurrence rate are favorable. Yes, you may require more sittings in a rubber band ligation. So that this detailed analysis were published in the Lancet, and the bubble of the hemorrhoidal artery ligation was busted, and now you will not see people talking of this anymore in the conferences. Those who are having, they will show it. Yes, it's a good thing for the specific cases, you can do it. But we should know about all these things, and we surgeons should know about different procedure in the hemorrhoid also. We should not stick to one procedure because I have bought a laser machine, so I will do every case with laser. If I know MIPH, I will do only MIPH. We should know different techniques so that we can offer to the patient, we can select the patient according to the merits and the demerits of a procedure. Then came the infrared coagulation. We are also having this machine, we frequently use it. Cost is not very costly, it's 1.5 lakhs to 2 lakh rupees. It's office OPD procedure. So then people shifted to IRC infrared coagulation. It was terms of laser से कर रहे हैं, laser से कर रहे हैं. Patient is very happy क्योंकि आप जैसे ही लिखोगे sclerotherapy कर रही है, injection लगाना डर जाता है, injection लगाओगे आप कहोगे laser से करेंगे तो he is very happy. So it became the trend. The people started buying the IRC machine, and the patient was ready to get it done immediately in the OPD. So then in latest data I am presenting the 2022 in the British Medical Journal. This was presented a meta-analysis of only the randomized trials. So this meta-analysis of the 931 patients showed that there is no difference in the efficacy between the rubber band ligation and the infrared coagulation. There is no difference in the post-operative bleeding rate between these. In RBL group, there was slightly in few case studies showed that it has a higher post-operative pain in the first or second day, but later on the pain score was same. And there is no significant difference between these two when it comes to recurrence. So again, now it is said that for the grade 3 and 2 hemorrhoid, you should not go for IRC. IRC may be better for the grade 1 because the complication of IRC are more severe than of the rubber band ligation because there is sometimes sloughing of the mucosa and the big ulcer forms there. And it takes sometimes few weeks to heal, and there may be bleeding, irritation, post-operative discomfort to these patients. Then came the MIPH. We know it is a very good procedure, painless procedure, daycare surgery proposed by the Longo when he did it. But the surgeon extended his guidelines. He said do it for grade 3. But we know it is now frequently done for grade 2, and some people started doing it for grade 4 also. Though the guy who invented this procedure, who knew the pathophysiology behind it, he never said do it for grade 2. So still in the recommendation, I will say as per the American, European, Indian Association, it is said it is a procedure, one of the very good procedure for grade 3 hemorrhoid. It should be done selectively in grade 2 hemorrhoids, but it is a total disaster in 1, and it should be avoided in grade 4. So the data came comparing this ultrasound guided arterial hemorrhoidal artery ligation, or you can say dearterialization, with the MIPH, and it was found that the recurrence rate was more in the patients with hemorrhoidal artery ligation. So this MIPH is provided apart from the benefits of the decreased post-operative pain, less recurrence rate as compared to the hemorrhoidal artery ligation. And when you compare its recurrence with the open surgery has nearly zero or significantly less recurrence rate as compared to the MIPH, but it is office procedure, no post-operative pain, no discomfort to the patient, no sitz bath. The patient can attend his office very next day or after the 48 hours, which is not possible when you go for the open hemorrhoidectomy. Post-operative bleeding significantly higher in patients who underwent MIPH. We all know there is a staple line disruption, and it leads to sometimes significant bleeding as compared to the open hemorrhoidectomy, where the chances of bleeding are significantly less. But the problem is that the complications of MIPH are sometimes very cumbersome to treat, that is anal canal stenosis, which is very difficult to treat, which you rarely get in the open hemorrhoidectomy surgeries. Then studies came which compared MIPH before it was established in parallel to the open hemorrhoidectomy. Again, this was a multi-center randomized trial conducted in 32 hospitals of the England for 2 to 4. And it was only they could conclude that stapled hemorrhoidectomy is less painful than traditional hemorrhoidectomy, that is the open hemorrhoidectomy. Quality of life after 1 month or 2 months is same in both the patients, they say, nearly same. So when you compare to quality of life, MIPS does not offer any additional advantage apart from the post-operative discomfort, and the pain is less. And the recurrence rate is more as compared to the open hemorrhoidectomy. Then came the laser. For last few years, laser is there. It is giving very good results. I'm not saying it is a market gimmick. It is giving very good results. And now the data has come. I will be presenting the 2021-2022 meta-analysis of the randomized trials. This was only the prospective study which was published, which showed that though there is higher rate of recurrence in the hemorrhoidopexy with laser as compared to open hemorrhoidectomy, but the complication rate, bleeding rate is quite less as compared to the MIPH. And this is a chart. Here you see stapled hemorrhoidopexy has more pain, less bleeding, more incidence of incontinence, and very less incidence of recurrence as compared to the laser hemorrhoidectomy. This was the initial data which came in 2021. So it showed that recurrence is more. Maybe the surgeons were not attuned with the new technique. They were learning the new technique. But later on, in 2020, a double-blinded trial was done on 121 patients for the second and third grade hemorrhoids. And it was comparing the suture mucopexy, which is not done nowadays. It is a very high recurrence rate, 50% recurrence rate within 1 or 2 years. So I will be comparing it with the laser hemorrhoidoplasty with open hemorrhoidectomy, that is excisional hemorrhoidectomy. And it was found that it takes less time. Recurrence rate was more. So again, the laser hemorrhoidectomy has a more recurrence rate as compared to the open hemorrhoidectomy, which nearly it is 0%. We have read since our student date that it is the gold standard when it comes to recurrence. Quality of life is better after excisional hemorrhoidectomy. Again, if you see the quality of life, somebody says you will be better after 1 month. Once the acute phase or the healing phase of external hemorrhoidectomy is excisional hemorrhoidectomy over, it scores better even than the laser hemorrhoidectomy, though the common sense says you should have a better discomfort or quality of life after the minimally invasive procedure. And this is again the latest systemic review of all the pooled data, where around 2,000 patients data was pooled who underwent laser hemorrhoidoplasty, published in recently 2021. They also found that lower pain, obviously post-operative pain is less because the hemorrhoidectomy is an open procedure. But the long-term follow-up, they found that nearly equal recurrence rate. So very interesting finding has come from the large pool data. Maybe the surgeons have now acquired that skill. They understood better the technique of doing with the laser. So now it is coming that at the follow-up of nearly 2 years, it is giving equal results. Maybe they say maybe after 4 or 5 years, they may be increased recurrence, but we have to watch for that. But till so far now, it is faring equally well with the open hemorrhoidectomy. Long-term recurrence rates seem to be equal. There are two different wavelengths used in this, and they say the low wavelength 980 nanometer is superior to the 1470 nanometer, which is another wavelength used in this method. Time performed is only 15 to 20 minutes when you acquire the skill. So this data said that is laser hemorrhoidectomy. If you go by this data, it is equal to or better than the open hemorrhoidectomy, even when it comes to recurrence. So this is a very good findings that have come after pooling of the data. And this is the recent 2022 data, where laser hemorrhoidectomy was again compared. Systemic review meta-analysis were done, and they said the recurrence rate is same. It means the laser hemorrhoidectomy now has an ample amount of data that the recurrence rate is also equal to excisional hemorrhoidectomy, and the post-operative discomfort is obviously less. Another new thing in the market is the radio frequency ablation. I don't know whether it's available in India or not, though it is. The studies were conducted in the UK and other European countries in 2008. And again, a new data has been published in 2019, which shows that it has a very low recurrence rate, though it has not been compared with other techniques. the stenosis, post-operative complications, bleedings are less. But they are combining it IRC, that is radio frequency ablation, with either IRC or with the laser. So their conduct, it means alone as a procedure, it is not as good as the laser hemorrhoidoplasty or the open hemorrhoidoplasty. So 4th-degree, as we all know, open is still the gold standard. If open surgery fails or the patient is contraindication, then we can go for the band ligation or we can try the MIPH. So in the conclusion, I will say, 1st and 2nd-degree hemorrhoids often respond to conservative and non-surgical, less invasive procedures. Conventional hemorrhoidectomy remains an important management. It offers favorable long-term cure. However, it is associated with post-operative pain and occasional severe complications. Newer techniques like IRC, laser, they promise to be less painful, yet long-term results are uncertain and questions remains regarding their recurrence rates. A patient with symptomatic hemorrhoid should be counseled regarding the advantages and disadvantages of the surgical approach, and he should be taken into confidence while choosing the procedure for him, considering his job profile, considering the finances involved, considering is the access to the healthcare, how many times he can come if there's a recurrence. And surgeons managing hemorrhoids should be skilled in a variety of techniques to offer a tailored management strategy for each patient. Thank you. So this is just a video. By the time you can ask questions. This is how IRC is done, because still not available in most of the institutes. I've just attended its conference in the company. It's very simple procedure, but I have still seen the misuse, people doing it in grade 1. I have seen in the conferences, still there are no recommendation that it should be done. Yes, the data will come in the few years where it can be done in the grade 1 also, because if it is successful in the grade 2 and 3, or maybe the frequency of the wavelength, they have to choose different. For 4, it is still not recommended. For 2 and 3, it is a very good procedure. Thank you.
Hello. Thank you, Dr. Hemant Notial, for the elaborative presentations. And thank you, Dr. Shashank and Dr. Ganen, for inviting me as a chairperson. The take-home message is this: the grade 1 and grade 2 hemorrhoids seldomly require the treatment. Do not go for the laser and the other treatments. Just go for the lifestyle changes. And you may go for the sclerotherapy. One, I am doing the laser and MIPH, but the laser is for good for only the 2nd-degree hemorrhoids. Grade 3 prolapse hemorrhoids doesn't go with the laser. It requires the MIPH is a good option. Another technique is the Schuette's or the Shivate's technique is the another technique जो हम MIPH के alternatively use करते हैं हम लोग यहाँ पे. Grade 4 hemorrhoids में kept on the conservative management initially. If you go 1 or 2 for the surgery, then always go for the traditional open hemorrhoidectomy. Never apply the MIPH or the laser surgeries. Am I right, Dr. Patel?
Yeah.
Thank you very much.
Thank you very much.
If the hemorrhoidectomy is being performed with the help of harmonic, the pain scores are lower. So if you have got harmonic, the take-home message, if you have the harmonic, you are going for hemorrhoidectomy, go with the harmonic.
Yeah, that is the
pain scores will be definitely less. Number 1. Number 2, regarding anal stenosis, one thing can be practiced. You don't excise the redundant skin. You just go into the submucosal plane, go beneath the submucosa, deal with the pedicle with the harmonic or something ligated, and take this skin up into the anal canal and suture it over there.
Yeah.
So the chance of anal stenosis will not be there.
Absolutely right. And the advantage of MIPH is that if you have additional external hemorrhoids, then you can go for the MIPH. It will pull that hemorrhoids also, and you may not have to do anything for those external hemorrhoids. But what people are doing, they're doing the laser hemorrhoplasty for the internal hemorrhoid and doing the then excision of the external hemorrhoid. So you have defeated the purpose of that minimally invasive procedure. Patient is going to have pain in the post-op. So what is the use of doing then when you are doing one side minimally invasive and on the contrary you are doing excising the external hemorrhoids? So that is, and one thing in the post-op, again, I've not added in the slide, there is ample data that after doing the open hemorrhoidectomy, if you use the nitroglycerin or these diltiazem ointments, they significantly reduce the post-operative pain. Regarding the metronidazole use, when his senior surgeon used to say if you give oral metronidazole, there is a decreased post-operative pain. It has been debunked. There is nothing like that. The literature says it is a placebo. It is not like that.
Definitely. Any questions from the audience?
Sir, are you routinely doing these laser?
No. We are in the process. We have written to our administration. We are not doing laser. We are not doing IRC. We have. We do it. Then MIPH we are doing. And then open we are doing.
Okay.
Laser.
You just go into the pedicle, burn it with the laser. Before doing that, you just go to the lumen. Without touching it, you deliver the pulses. That will lead the mucosa will shrink out over the laser.
I know that procedure, boss. My query is this: if you have a machine of 980, there are the two machines. One of 980 and
1470.
1470. Is there any difference with the wavelength when we are doing the laser hemorrhoidopexy?
Yes, sir. The both techniques I have shown in the slide also.
Is there any difference? If we are,
yes. Recurrence rate are more with 1470 technique.
More.
Yeah.
980
980 is a superior. They have said don't do it 1470.
980 is better for take-home moses is
for hemorrhoidopexy.
For hemorrhoid. For
yeah. Okay. That has been shown in randomized studies.
Now I request Dr. Sunil Kamal sir to felicitate Dr. Hemant Notial sir. Now I request Dr. Sanjay Pandey sir to felicitate Dr. Sunil Kamal sir and Dr. Umesh Singh sir. Moving towards the end of Subharti Surgery Update 2023, we are here for now the PG competitions held in Subharti Surgery Update 2023. The first competition was the PG quiz competition in which 6 teams participated, and the first prize went to the 2 teams from Jolly Grant Medical College. The first team was Dr. Abhinav K. Singh and Dr. Jay Rajesh Desai. I request Dr. Vikas Singh sir to give the certificates and the prize to the winners. The second team is also from Jolly Grant Medical College, Dr. Surya Deep Yadav and Dr. Shalvika Kashyap. May I have them on stage? The second prize in the quiz competition was from Subharti Medical College team Dr. Komal Jain and Dr. Subulakshmi. I request Dr. Komal Jain and Subulakshmi to come on stage. Thank you, Dr. Vikas Singh, sir, for your time and best wishes. Now I request Dr. Shashank Mishra, sir, to felicitate Dr. Harender Sandhu, sir, for being the judge in poster presentation. As the poster presentation is still on the verge of its end, we'll take 10 minutes for the results of poster presentations to be announced.
So the winners of the poster presentation competition has been announced. The first prize goes to Dipali Srivastava from Rajshri Medical College. May we please call upon stage Dr. Nivesh Agrawal, sir, to please facilitate her. The second prize goes to Dr. Sunidhi Mishra from Subharti Medical College. Third prize goes to Dr. Surya Jain from Subharti Medical College. Thank you so much, sir. May we please call upon stage Dr. Gyanendra, sir, Organizing Secretary, Surgery Subharti Update 2023.
Good evening, everybody. After 2 hectic days of academic schedule, I stand here as a proud organizing secretary to express my heartfelt thanks to all those who have made this event successful. I would like to start by thanking management of Subharti Medical College, who have always been supportive of our initiatives and encourage us to strive for excellence. I would like to extend my gratitude to Principal Sir, Vice Principal Sir, HOD Sir, esteemed faculties of the Department of Surgery, Dr. Ruchi Ma'am, guests who have been our guiding lights, imparting wisdom and knowledge to us. I would like to express my appreciation to our guests who have taken time out of their busy schedules to grace this occasion with their presence. I would also like to thank interns, UG students who were always present there, and especially UG students who came for Saraswati Vandana. Every resident of Department of Surgery, for your extreme support and participation in making this event successful. Finally, I would like to thank our supporting team, our clerks, attendants, council hall in charge and working staff, housekeeping, Mr. Navinji, security persons, and our sponsors team. Without your support, we would not have even thought of success of this event. In the end, I would like to express my sincere thanks to all of you. Thank you.